the uterus, the length, complete length of this uterus here, from the body of the uterus to the neck. So the body of the uterus, also known as the corpus, that is around 7 to 8 centimeters in length, and the cervix alone is around 3.5 to 4 centimeters in length. So this 7 to 8 centimeters length is seen in nulliparous woman, and in multiparous woman it will become a little bigger. The multiparous is around 8 to 10 centimeters and it is still called normal. So when we do a pervaginal examination, we can make out whether it's a woman who's delivered a child, because the uterus will be slightly bigger, because whatever happens when the uterus becomes hypertrophied in pregnancy, after the delivery, it never comes back to the pre-pregnant size. It will be always a little bigger. So we call it a multiparous size uterus. So that will be around 8 to 10 centimeters long. Now cervix length is 3.5 to 4 centimeters, and a short cervix, we can do this MCQ here itself. Short cervix is anything less than 2.5 centimeters. Very common MCQ. So what is the length of this fallopian tube? If you see this complete length of the fallopian tube, that's around 7 to 12 centimeters. All right. So the vagina, the length of the vagina is 7 centimeter in the anterior fornix and 9 centimeters in the posterior. All right. So let's get into understanding what are the appearance of the cervix when the woman is young and she's never delivered a child, or when a woman has already delivered. So if you see the cervix end on, see, if you imagine my hand as the uterus, so this is the coronal section of a uterus. But if you see the uterus in a woman who is lying down, then you'd see the cervix like this first. So this cervix, how does it look like in a woman who is nulliparous? See, it is a small circular opening of the cervix. So this is a nulliparous woman. The cervix is circular. And in a multiparous woman, she is delivered once, so once or twice. So this is a transverse slit-like. So in a multi, it is transverse. This also came as a MCQ once, the cervix of a multiparous woman. Now, so if you see the epitheliums of the uterus, so when I talk about all the epitheliums, let's start from the fallopian tube. Now, fallopian tube, you know that it has to catch the oocyte, and the oocyte has to move into the fallopian tube and make its journey towards the uterus. So the fallopian tube, can you see in the picture, the fallopian tube is like a clasp. It is sitting over the ovary. So when the ovary ovulates, the fallopian tube catches the oocyte, and this oocyte will make its journey in the fallopian tube because of the peristaltic action of the fallopian tube and also the cilia which is there in the fallopian tube. So if you see that, the fallopian tube has got this ciliary epithelium. So ciliated columnar epithelium that is seen in the fallopian tube. And this epithelium helps in the movement of the oocyte along with the peristalsis of the tube. Now, what happens to the epithelium of the uterus? The uterus also has some microvilli. So when this uterus has this microvilli, we can comfortably call the epithelium of the uterus also ciliated columnar epithelium. All right. Now, you have to understand a little bit more closely when we go lower down in the uterus. When the uterus is changing its anatomy here, so this area is known as the area where the cervix is starting. So it is known as the internal os. And this area is known as the external os. Now, when we know this anatomical parts of the cervix, that when the uterus starts to become the cervix, it is known as the internal os, and the opening of the cervix is known as the external os. Now, let us see the epithelium of the vagina, cervix, uterus, and the fallopian tube. So, whatever is exposed in the body, like our hands, our face, everything is squamous. But whatever is inside, the organs inside are having epitheliums which are softer, like the cuboidal and the columnar epithelium. So by that logic, let us try and understand here that the vagina, the external part of the body, vagina is and cervix is fairly external part of the body. So vagina is squamous and it has many layers of squamous epithelium, and the cervix is also squamous. So I'll draw this in blue. So this is all squamous epithelium. Now let's go to the other end of the pelvis and the other end of the organs in the pelvis. Let's see the fallopian tube. Now fallopian tube has a responsibility of catching the oocyte when it ovulates. So follicle has ruptured, the oocyte has gone into the fallopian tube. Now how does the oocyte move in the fallopian tube? So fallopian tube is like a clasp. It is clasping the ovary, and this ovary, when it ovulates, the oocyte is caught by the fimbria. So to make sure that this fimbria does not lose the oocyte, the fimbria is clasping, like a panja in Hindi we say, it is clasping the ovary, and the oocyte is caught here, and then the oocyte moves in the fallopian tube with the peristalsis of the fallopian tube, but also because of the ciliary action in the fallopian tube. So yes, the epithelium of the fallopian tube is ciliated columnar. So ciliated columnar epithelium and the peristalsis will move the oocyte in the fallopian tube. Now, the uterus is also similarly having microvilli. There are microvilli in the uterine lining. So we can call this also a ciliated columnar epithelium. The uterine epithelium, which is ciliated columnar, please note here, it continues to be ciliated columnar even in the early part of the cervix. Now be very careful. The cervix has already started anatomically here. This is known as the anatomical internal os. The anatomy of this uterus has now become cervix, but the epithelium continues to be ciliated columnar. Now, anatomy has changed, but the epithelium changes somewhat lower down. Here it starts to become columnar epithelium. So this place where it becomes the columnar epithelium, there we say now this is the histological internal os. So the anatomical internal os is higher than the histological internal os. The anatomy changes higher and the epithelium changes a little lower. So ciliated columnar continues to be ciliated columnar, and now it becomes plain columnar epithelium in the upper part of the cervix. Now, still there are some more changes which happen in the cervix. The cervix now starts to get exposed in the vagina. As the cervix starts getting exposed in the vagina, you know the vaginal epithelium is squamous and the cervical epithelium is columnar, and the area where it is getting exposed, this columnar epithelium starts becoming squamous. So this area where the columnar epithelium is in the process of becoming squamous, this is known as the transformation zone. Also known as the squamo-columnar junction. This is located 1.7 to 2.3 centimeter from the external os. So try and understand that the epithelium of the cervix, it is initially ciliated columnar, then it becomes columnar, and the columnar epithelium starts getting exposed towards the vagina. So there is a transformation from columnar to squamous. This is known as the squamo-columnar junction, and then it is squamous epithelium in the cervix and the vagina. So that's the epithelium of this whole pelvic organs in the woman. Now, what is the importance of this? Let's see next. So when the epithelium is changing from the columnar to the squamous, I told you that is known as the transformation zone. Now this transformation zone, we must try and understand that the columnar epithelium is in the process of changing into squamous. So there is a rapid cellular division happening place. The cells are in the process of changing. Columnar becoming squamous, columnar getting exposed, becoming squamous. So there's a code here that yes, this is the area which is getting exposed in the vagina. So it's better you become a stronger epithelium. So columnar becoming squamous, columnar becoming squamous. But if this woman gets exposed to human papilloma virus, that is because of having sex with men who are having human papilloma virus. So that human papilloma virus comes and corrupts the code here. What is the code here? Columnar becoming squamous. Now the human papillomavirus, the DNA comes here of the human papillomavirus and that corrupts the code here. The code is columnar becoming squamous. The HPV DNA comes and corrupts the code to become abnormal squamous cells. Columnar becoming squamous, HPV comes and now columnar becomes abnormal squamous. That's what you have to understand. So the first site where abnormal squamous cells start forming, or in other words, where CA cervix starts forming, first site of CA cervix is the transformation zone. It starts here. So first changes, I'm not saying it is going to be CA cervix here first. It's going to be some changes in this epithelium. We'll start showing new types of cells, intraepithelial neoplasia. Then those cells will start invading into the cervix a little bit, early invasive cancer, and then full-blown growth or a full-blown cancer of the cervix. So where does it start? In the transformation zone. So when you do a pap smear, yes, for screening of CA cervix, a pap smear should have the component of transformation zone. If a woman is being screened for CA cervix, whom do you screen for CA cervix? Sexually active woman for having sex for at least 3 years. That's when the HPV changes can start. So when a woman is sexually active for 3 years and beyond, we start doing the pap smear like we discussed in the chapter of CA cervix. And when we do the pap smear, it's from the cervix. Now, when we do this pap smear with the IR spatula and plate it on the slide, under the microscope, you should see transformation zone component. If that is not present, then you will discard the slide and repeat it again. Now, continuing with the importance of the epithelium which we spoke about the transformation zone just now. Now, let's see. I said the part where the cervix starts. See, the uterus is now becoming the cervix. This is known as the anatomical internal os. And then somewhat lower, here is the histological internal os. So this area between the anatomical and the histological internal os is known as the isthmus of the cervix. Anatomy MCQ. What do you understand by the isthmus in the cervix? Where the area which is between the anatomical and the histological internal os. What is the importance of this? Now, what is the importance of this isthmus? This isthmus is only 0.5 centimeters in length in a non-pregnant uterus. But when this woman becomes pregnant and is at full term with the fetus inside, this pregnant woman has a upper segment and a lower segment. We know that very well. And this lower segment is in fact the isthmus. Yes. This isthmus becomes the lower segment of the uterus. So this isthmus, which is 0.5 centimeters, now becomes the lower segment of the uterus when the lady is pregnant and is at term. And this lower segment is around 7 centimeters in size. So what is the lower segment? It is basically the isthmus, which is stretched and become the lower segment of the cervix when the patient is about to go into labor. What is the importance of this lower segment? That this upper segment, this will contract and the lower segment will retract. So the uterus contracts like this. See, if my arms are the uterus and my palms are the cervix, upper segment contracts and the lower segment retracts. That's why the fetus moves down with every contraction. If everything was contracting, the fetus will stay where it is. So the upper segment contracts and the lower segment retracts. And what is the lower segment? It is that isthmus of a nulliparate uterus or a non-pregnant uterus, which becomes the lower segment. So that's the importance of the epithelium of the uterus and the cervix. Now let's move on and see the story about the follicles. Now let us see the follicular story. So when we see the ovary here, the ovary is 3 into, let's say 3.5 into 2.5. The third dimension can be 2.5 to 5 centimeters sometimes. So this is the size of the ovary. If I want to know the volume of the ovary, I'll multiply by 5 by 9. So why 5 by 9? Because ovary is not a perfect shape. It's an ellipsoid. So volume of the ellipsoid is 3 dimensions into 5 by 9. And now we get the volume of the ovary, and less than 10 is normal volume, more than 10 cubic centimeters is enlarged volume of the ovary. Now the ovary has a follicle, one dominant follicle every month with a oocyte every month. So this oocyte, how many oocytes are there? How many eggs are there? One egg every month. How many dominant follicles are there? One dominant or mature follicle per month is seen. But in this ovary, there are many small fluid-filled follicles also. So those fluid-filled follicles are around 6 to 7 per month. Now these fluid-filled follicles are known as the antral follicles. Okay, so 6 to 7 per month are the antral follicles, and one becomes the dominant follicle, and in that dominant follicle there's one egg every month. But what you can't see is hundreds and thousands of very small follicles in the ovary. So these are known as the primordial follicles. Now primordial follicles are many in the ovary, but every month how many are recruited? Around 1,000 primordial follicles are recruited every month. 1,000 primordial follicles are recruited every month to give 6 to 7 antral follicles. So when the FSH starts to increase in the beginning of the month, that is going to recruit around 6 to 7 antral follicles every month. But before that, how many primordial follicles came into this cycle? You know that 1,000 primordial follicles come to ovulate every month. And out of that, the brain sends the FSH to select only 6 to 7. So if we understand it like an application for an interview, 1,000 applications are given every month. And out of 1,000, 7 are recruited for an interview. And out of 7, one is finally selected to ovulate. So that kind of selection goes in the ovary to make one follicle dominant and ovulate. We know the other story very well, that there are millions of sperms and one sperm goes and fertilizes the oocyte. Look at the part of the ovary also. Women are also undergoing a similar selection, but we never cared to remember that. So women have around 1,000 follicles recruited every month, out of which 6 to 7 become antral, and one becomes dominant and ovulates, and one egg is released every month. So best oocyte, best sperm make the best embryos and the best humans. All right. So quickly, let's see how many primordial follicles are there. That's the sad part of the story in a woman. Primordial follicles, which are going to be recruited every month, 1,000, and 6 to 7 become antral. Women are born with a set number of follicles. Men will go on making sperms all their life. Even a man is 50 or beyond 60, 70, he'll still be making sperms, and he can technically father a child even when he's 70 years old. But a woman will run out of follicles, and this is because she's born with a set number of follicles. So what is the meaning of that? Primordial follicles, there are around 6 to 7 million primordial follicles at 20 weeks of intrauterine life of this girl. When this girl whom we are talking, when she was in a mother's womb, during her intrauterine life, the follicular number was maximum, which is 6 to 7 million. Now, what happens? There are only 1 to 2 million. The atresia of the follicle starts in the intrauterine life itself. So after 20 weeks, the follicle number is only 1 to 2 million at birth. And then there are only 3 to 4 lakhs left at puberty. So we know that puberty starts, let's say, roughly at 12 years. So menstrual life of a woman is generally from 12 to 50 years, let's say around 38 years of menstrual life is there in a woman. So every month, how many follicles she's going to utilize to make one dominant follicle? 1000. In 1 year, she's going to use 1000 12 times. That is 12,000 follicles every month. So in 10 years, 12,000 into 10, 1,20,000. And in 38 years, it is going to use up all the primordial follicles. So if she's going to have 1,000 primordial follicles utilized per month, that means 12,000 primordial follicles utilized per year. That means 12,000 into 38 years is equal to 4,56,000 primordial follicles will be utilized in 38 years of menstrual life. So let's look at this picture. Roughly how many follicles she's born with? She's born with 1 to 2 million. At puberty, she's left with only 4 lakh follicles. So even if there are 4 lakh follicles, around 4.5 lakh follicles will get over in 38 years of menstrual life. I'm not saying 38 years of age. I'm saying 38 years of menstrual life. So when does a woman start ovulating? Around 12 years. That's when she starts menstruating also. And how long she'll menstruate? As long as the follicles stay. Now, how long the follicles are going to stay? Till 50 years of age. So 12 to 50, roughly 38 years of menstrual life. And in 38 years, we know 456 follicles will get 4,56,000 follicles will get utilized. Now, when 4,56,000 follicles get utilized in 38 years, some women will have menstruation for, let's say, 38 years. Some will have at 35 years, 36 years. So that's why some women have menopause at 50. Some women have 47, 48 also. All right. So that's the simple mathematics of the follicular story. But remember, women have this drawback of having set number of follicles, and men can have sperms all their life. So we must understand women will run out of their follicles around 50. So we should utilize these follicles when the woman is young, around 20 to 25. These follicles are great in number. There's a good choice to have a good follicle ovulate and give a good pregnancy. So around 35 and beyond, the follicles start getting, the remaining follicles are only present. So the chance of pregnancies are much less after 35, and after 40, the chances of abortions are almost 40%. So that's why the best time to have a pregnancy is 20-25. We can say in today's life, women want to settle in the careers. So we say between 20 to 35, they must plan their families. All right. Now let's see the other aspect of this follicle. Now, in this ovary, there is this dominant follicle with a oocyte in it. Now, this dominant follicle has granulose cells in it. These granulose cells will make estrogens. How do they make estrogens? They will convert the available androgens to estrogens by aromatization, and this estrogens will act on the uterus to cause proliferation of the endometrial glands. So, proliferation of the endometrium is because of the estrogen which is coming from this follicle. Now, this follicle will then ovulate around 14th day of the menstrual cycle, and now the oocyte will be caught by the fallopian tube. Now, once the oocyte enters the fallopian tube, this follicle will now shrink, and this shrunk follicle will now make a yellow colored body. A yellow body, like we call it. So this yellow body, yellow is luteum, body is corpus. So we call this the corpus luteum or the yellow body. Now this corpus luteum will make progesterones, and this progesterone is very important to make these endometrial glands secretory and juicy, because soon an embryo is going to come and implant on this endometrium, and for this embryo to get nourishment, there should be juices which is going to give nourishment. So that juicy endometrium, that secretory endometrium is because of this progesterone. So estrogen causes proliferation, progesterone causes secretion. So before I go into more details, please try and understand the events of the uterus. The events inside the uterus, the endometrium, are governed by which organ? By the ovary. The ovary first makes a follicle, which makes estrogen, proliferation of the endometrium, and then the ovary gives an egg. If this woman has intercourse, this egg is going to get fertilized and make an embryo. Embryo is going to get implanted. So for the implantation, the same ovary has now made a corpus luteum, which is going to make progesterone, which is going to make the endometrium secretory for the embryo to come and get implanted and get nourishment. So all the events of the uterus are managed by the ovary. Ovary is the master of the uterus, and that ovary has what organelle, which is the master of the uterus? The follicle. Follicle is in fact the master of the uterus. The follicle is making estrogen and progesterone, which is making the endometrium proliferate and secrete. So how long are the follicles present? Only till 50 years. That's why the uterus works also only for 50 years. Alright. So that follicle is the master of the uterus. Now, when this oocyte goes into the fallopian tube, and suppose if this woman has sexual intercourse, the sperms have gone into the body of the woman, and these sperms will now reach the fallopian tube and fertilize the oocyte in the ampulla. That's the site of fertilization. Otherwise, the life of the oocyte is only 24 hours to 48 hours. If they ask you one, mark 24, the life of the egg. The egg is going to be fertilized in the ampulla by the sperms. Now the embryo will form. Now that embryo will definitely survive. So now the embryo forms here, and this embryo will survive. Now this embryo will reach the uterine cavity. This embryo reaches the uterine cavity on the 3rd to the 4th day. If they ask you one, mark 3, 8 cell stage. 4th day is 16 to 32 cell day. So it reaches the uterine cavity on the 3rd to the 4th day, and it implants earliest on the 6th day. So where are these days calculated from? These days are calculated from the day of ovulation, or the day when ovulation happens. The fertilization also happens on the same day, because the life of the oocyte is only 24 hours. So don't get confused. When I say 3rd to the 4th day, the embryo reaches the uterine cavity, it is the 3rd to the 4th day from the day of ovulation, or the day of fertilization means the same. And when it implants earliest on the 6th day after ovulation, which means the 6th day from fertilization also. So 6th day it implants earliest. It implants earliest on the 6th day. Can happen from the 6th to the 10th day of ovulation. In other words, yes, if you see, when does the ovulation happens in the terms of menstrual cycle? It happens on the 14th day of the menstrual cycle. So from 14th day, if you see, then it means 20th to the 24th day of menstrual cycle. So let's not get confused. This is very simple. From the 6th day of the ovulation, the implantation happens earliest, and that can happen till the 10th day. In other words, from the 20th day to the 24th day of the menstrual cycle, implantation can happen. All right. Now let's look at all of this once again. That all of this starts from the hypothalamus in the mediobasal nucleus, also known as the arcuate nucleus. And from there, the GnRH comes and acts on the pituitary. So this is known as the gonadotropin releasing hormone. It's in a pulse. It's a pulsatile release, which is once in 60 minutes in the follicular phase and once in 90 minutes in the luteal phase. So faster in follicular phase and longer in luteal phase. So once in 90 minutes, okay, not in seconds. Now this gonadotropin releasing hormone acts on the pituitary to release LH and FSH. So that's why gonadotropin releasing hormone will release the gonadotropins. LH and FSH are known as the gonadotropins. And where do the gonadotropins act? They will act on the gonads, which in this person are the ovaries. In men, it is the testes. So gonadotropins will act on the gonads, and this ovaries, how will they respond? When the FSH acts on the ovary starts to make a dominant follicle with a oocyte in it. But now what else happens in this follicle? This follicle will convert the available androgens to estrogens by the enzyme known as aromatase. Now, where are these androgens coming from? These androgens are coming from the cells which are surrounding these follicles, and these are known as the theca cells. So, theca cells in the ovary makes the androgens. The androgens get into the follicles, and the follicles convert the androgens to estrogens by the enzyme called aromatase. Now, this estrogen comes out from the follicle and gives a stimulation to the uterus to cause proliferation of the endometrium. But this estrogen also gives a feedback to the brain to stop the FSH, that I don't need FSH anymore. It gives a negative feedback to the FSH, but it tells the brain that, hello, I am ready to ovulate. Okay, I have a follicle which is mature. It is making that required amount of estrogen. What is that required amount of estrogen? This amount which is going up is around 150 to 200 picograms of estradiol. So that follicle is sending a message to the brain that, hello, I don't need FSH anymore. Stop that. I've grown enough. But yes, send me LH because I'm ready to rupture. So how does the brain send the LH? It is banking on the information sent by the ovary. Ovary sends the information that, okay, see, this X amount of estradiol, you want around 200 picograms for me to pass. I'm sending you 200 picograms. I'm mature enough. I'm sending you 200 picograms. Now send me LH. So this is a positive feedback for the LH. So now the LH comes out and it ruptures the follicle, and that follicle becomes yellow in color, corpus luteum, which makes progesterone, and progesterone will make the endometrium secretory. All right. So that's the play of the hormones. Now, what is finally the purpose of the FSH? If you remember all of this very well, what I told you, very good. Otherwise, remember that when the brain acts on the pituitary to release the GnRH and the pituitary releases the FSH, the purpose of the FSH, how it does, where it does, is to bring estrogen back to the circulation in the brain. So the purpose of FSH is to make estrogens. And what is the purpose of LH? You know that LH is high because it has to come and rupture the follicle, and that follicle will now get exposed to the luteinizing hormone, and this granulosa cells will become yellow in color. And now this yellow granulosa cells will convert the available cholesterol to progesterone, and this progesterone will give secretory activity in the uterus, but it gives a feedback to the brain to stop the LH. So what is the purpose of LH? If you remember all of this, fine, but you must remember LH came out from the brain to make progesterones. So FSH for estrogens and LH for progesterone. Remember these punchlines. These are very important for the following chapters like combined oral contraceptive pills and also for polycystic ovarian disease. All right. So talking about follicular stimulating hormone, the normal follicular stimulating hormone in a woman is 2 to 6 international units per liter. And you know that the purpose of FSH is to make estrogens. So if the ovary is healthy, some FSH, let's say 2 or 3 will stimulate the ovary, and the ovary will make a follicle, and the follicle will make estrogen, and the estrogen will give a feedback to the brain to keep the FSH low. But as the woman gets older, the follicular number reduces. Follicular number reduces, estrogen amount production reduces. So the feedback to the brain reduces, but the brain is always young. Ovaries are getting old, but the brain is always young. The brain will go on increasing its stimulus to the ovary. Make estrogen. But the ovarian follicles are reducing as she's getting older. As she's getting 35, 40, 45, the follicle number is reducing. Estrogen amount is reducing. So the FSH starts to increasing. The brain goes on stimulating the ovary to make follicles. So as the woman gets older, the FSH increases. So yes, if the FSH is more than 10 international units, it is suggestive of menopause. And if the FSH is more than 40 international units, it is diagnostic of menopause. And if the FSH is more than 40 international units, but before 40 years of age, then that is known as premature ovarian failure. All right. So that's the FSH story. Now look at the story of the antral follicles. Now, when I spoke to you about the antral follicles, there are around 6 to 7 antral follicles which are recruited every month, and out of one will become the dominant follicle. Of course, the primary follicles are around 1000 which are called for, and out of which 6 to 7 become antral. So now see, if I do an ultrasound, we call it a follicular monitoring scan, follicular monitoring by ultrasonography. So when I do an ultrasound in the beginning of the menstrual cycle, I know that she's going to recruit 6 to 7. She's going to recruit 6 to 7 antral follicles every month. Now see here, this is the scan of the ovary in the beginning of the month, and you can see 1, 2, 3, 4, 5, 6, 7, 8 antral follicles have been recruited in this woman's ovary. Now, one ovary has 7 to 8 antral follicles, which is a very healthy number. And out of which, how many will become dominant? One will become dominant. Can you see the same ovary now? There is just one dominant follicle. Of course, it has an oocyte. That oocyte you cannot see on the ultrasound because that's very small. It's only around 120 microns, the oocyte. So you can see the follicle which is big. Now, that is the follicular monitoring. We start doing follicular monitoring around 9 to 10 days of the menstrual cycle, and we see that one follicle will become dominant. Around 14 days, it will become very big, which is around 15 to 20 millimeters. A mature follicle is 15 to 20 millimeters, and then after 14-15 days, when you do the scan, you will see that this follicle has shrunk because it has ruptured. So why am I telling you about this follicular monitoring now? I'm trying to tell you that in the beginning of the month, if you do an ultrasound of a woman, in that ultrasound, you will see 6 to 7 antral follicles. Antral follicular count. Now, this is around 6 to 7 per ovary in a young woman. It's a good indication that the woman is having a good selection of follicles. Now, what am I getting onto? I'm getting onto a very important topic of our physiology of menstruation, and that is the ovarian reserve or the capacity of conception. So what did I discuss with you so far? I said the ovarian size is around 3 into 3.5 into 2.5 to 5 centimeters, this diameter, and that is a normal size of an ovary. Then what is the serum FSH? It is 2 to 6 international in a young woman. And what is the serum estradiol? Serum estradiol is higher, around 150 to 200 picograms per follicle. You'll see around the mid-cycle, you'll see a high amount of estrogen in a young woman. And you'll see the antral follicular count, AFC, will be 6 to 7 per ovary. Now, when you see these parameters in a young woman, what do you see in an old woman? Now, in an older woman, around 40 and beyond, the size of the ovary will be smaller. The serum FSH will be more than 10 international units. The estradiol will be lesser, and the antral follicular count will be less than equal to 3 per ovary. So this is how we know. We can do this test and we can find out that the woman is now getting older because the FSH is higher, ovary is getting shrunk in size, and the follicular number, the antral follicular count, is reducing. Now, another thing which you can see is the anti-Mullerian hormone. Now, this is also made from the granulosa cells, and this is around 2 to 6 nanograms per ml. Now, this anti-Mullerian hormone is also made from the granulocyte cells. And if you know that the granulocyte cells are adequate in number, that means there are adequate follicles in number in this woman. So if there are adequate granulocyte cells, the AMH will be 2 to 6. But if this AMH is less than equal to 1 nanograms per ml, then that signifies a older woman. Now, all of this we can understand that a woman is younger, you'll see these values. A woman is older, you'll see these values. Now, if these values which are in an older woman, if these are seen in a young woman, let's say a woman of 28 years has these values: a small ovary, a high FSH, a low estrogen, and a low antral follicular count, and a low AMH. If it is seen in a younger woman, then that woman has a poor ovarian reserve. This is the importance of knowing these parameters. A young woman will have these values, old woman will have these values. It is understood a young woman will conceive easily, old woman will conceive with difficulty, because these are their parameters. But if these old values are seen in a young woman, that young woman is known to have a poor ovarian reserve. So what is an ovarian reserve? It's the capacity to conceive. Why do I want to measure it? I want to measure it because some women who are now around 25 to 35, they should conceive easily. But when they come to my infertility clinic and I do their AMH levels, I see they are only 0.5. I see their FSH is around 9, 10, 15 sometimes. So this woman is getting into a poor ovarian reserve. Her capacity to conceive is poor. Maybe I should do a IVF as a faster treatment than going through the initial treatment of infertility. So this ovarian reserve calculation has become a very important topic, and all of this has already come in your exams. So yes, there is also inhibin B as a parameter. Inhibin B is also made from the granulocyte cells, and inhibin B, if it is lesser, that means it's a poor reserve. Now, all of these factors put together make the ovarian reserve, but which are the good factors? The factors which are of importance are the serum FSH, and then the antral follicular count, and then the anti-Mullerian hormone. These are the important factors. But the exam question which has come, the exam question is, which one of these is the single best parameter? The single best parameter, yes, that is the exam MCQ, is the anti-Mullerian hormone. This has come as a MCA exam and a PG entrance exam question many times. So this is about the ovarian reserve. This is something which I got to know only as a postgraduate in gynae and as a fellow who was doing infertility treatment. But you guys who are into only your MBBS so far, now you guys also have to know the parameters of ovarian reserve. Now let's see this menstrual cycle in a well organized chart. If a normal menstrual cycle of 28 days is made into a graph with all the parameters which we discussed so far put together, then we see that the pituitary hormone FSH is high initially, then there's a small mid-cycle peak, goes low, and at the end of the month it is high again to be a little high in the next cycle. So when does the cycle start? When the woman starts bleeding, that's when the menstrual cycle starts. That is what is called the first day of the period, when she starts bleeding. So 1, 2, 3, like that, day 14 tak, then day 28. So when she starts menstruating is the first day of the menstrual cycle. And mind you, all calculations about the period of gestation and the calculation of expected date of delivery are all from the first day of the LMP. When I say that her period is on 1st of January, when is the expected date of delivery? We add 9 months and 7 days to this LMP of 1st January. Then if I say the pregnancy is 7 weeks, where is it calculated from? 7 weeks is from which part? That is from the first day of the LMP again. So all calculations are from the first day of the menstrual cycle. All right. So never get confused. When we say that, when is the time when you see cardiac activity on the ultrasound of early pregnancy, we say 5 weeks and 3 days. So where are these 5 weeks and 3 days taken from? They are taken from the first day of the LMP. On TVS, you'll see at 5 weeks and 3 to 4 days, something like that. Okay, so pituitary hormone, FSH is high initially in the first 2-3 days of the menstrual cycle, and then it goes low. What's the purpose of that FSH? It recruits 1, 2, 3, 4, 5, 6, 7, or maybe 8 antral follicles. Now, the low FSH is good enough to maintain growth of only one of these follicles, which is now called the dominant follicle over the others. And now it has got this size of around 15 to 20 millimeters, and it's got this oocyte in it. Now, as the follicle increases in size, the ovarian hormone estrogen will increase in amount. And when the estrogen increases, that causes proliferation of the endometrium. Now, when there is proliferation of the endometrium, that is known as the proliferative phase. It is because of the follicle which is making the estrogen. So we also call it the follicular phase. This is synonymous. Now, when the follicle becomes 15 to 20 millimeters in size, it makes 150 to 200 picograms of estradiol. 15 to 20 into 10, 150 to 200 picograms. So simple. So 150 to 200 picograms is that amount which gives the message to the brain, which we saw. It gives a message to the brain to cause the surge of LH, and that LH surge will act on the follicle and luteinize it. It ruptures it and luteinizes it. So the follicle is released in ovulation, and now this follicle will shrink and become yellowish in color. So that's why it is known as the corpus luteum. So this corpus luteum, you know, this part is now going to start making progesterone. So this hormone which was low so far, after ovulation, this will increase. And when the progesterones will increase, that is because of the corpus luteum. Now, this progesterone, when it increases, it makes the endometrium start accumulating some fluids. So that becomes a secretory endometrium. And then later in the month, the glands become tortuous. So this is known as the secretory endometrium. And that is because of the corpus luteum. So it is also known as the luteal phase. So this corpus luteum, all of us know the life of the corpus luteum after ovulation. It is maximum function is 9 to 10 days. And after 9 to 10 days, the corpus luteum function starts to degenerate. Of course, the corpus luteum will live for 14 to 28, around 14 to 15 days it lives. But the maximum function of corpus luteum is only for 10 days. See here, the corpus luteum starts to reduce its function. So around day 24, it starts to reduce its function. By day 28, the function is totally lost. So that endometrium will start to degenerate and shed and cause the menstrual cycle. Okay, so that is the chain of events in the menstrual cycle. Please remember, when the estrogen is increasing, the endometrium is proliferating. When the progesterone is increasing, the endometrium is secretory. But also remember one thing, that with the increasing estrogen, the endometrial glands are proliferating. But when the progesterones come, the glands are not proliferating, they're secreting, but they're not increasing in height anymore. Please try and understand. Now the glands, because of progesterones, are secretory and also stabilized. So secretion and stabilization of the endometrial glands is brought about by the progesterone. Please remember that the estrogen, which was increasing progressively after ovulation, will take a dip. Small increase in estrogen again will happen, and then estrogen will reduce along with the progesterone. So remember, major production by the corpus luteum is of progesterone, but don't say it makes only progesterone. It makes some estrogen also. So yes, we know that progesterone reduces cause shedding of the endometrium. That's the major event, but also the estrogen reduces to help in the shedding of the endometrium. So what causes the shedding of the endometrium? Progesterone and estrogen withdrawal. All right. Now let's see this menstrual cycle in terms of a woman who is sexually active. Let's see if this woman had intercourse, IC, on the 14th day of the menstrual cycle, and the sperms have gone and fertilized the oocyte in the ampulla. This now has become an embryo. You know, the embryo implants earliest on which day of the ovulation? 6th day of the ovulation, the embryo will get implanted, which can happen up to 10th day of the ovulation. In other words, 20th to the 24th day of the menstrual cycle. Now, what I want you to notice here is that this pregnancy will implant on an endometrium which is secretory. This endometrium is secretory because of which hormone? Progesterone. Progesterone is coming from the corpus luteum. Now, that corpus luteum is working only for 10 days. Can you see here? Here, the corpus luteum is going to degenerate, progesterone is going to reduce, and the endometrium is going to shed, and she's going to shed her endometrium. She's going to abort this embryo. So, please be careful. After implantation, the corpus luteum is going to work only for another 4 days. 10 days is the best function of the corpus luteum. So, in these 4 days, if there is no stimulus to the corpus luteum is going to degenerate. If the corpus luteum is going to degenerate, she is not going to maintain the pregnancy. But we know the pregnancies are going to live for 9 months. So, what makes the corpus luteum continue functioning? So, that is what is important here, that we know that luteinizing hormone will make the corpus luteum, and that corpus luteum is pushed to work for 10 days to its maximum potential. After that, it is going to reduce its function. So now what happens? This corpus luteum was working for 10 days. It was about to reduce its function. Before this corpus luteum could degenerate, this woman got pregnant, and from the early cells of the placenta, the syncytiotropoblast, it starts making something like LH. LH is a gonadotropin, I told you. So it starts to make a gonadotropin from the early placental cells. Human chorionic gonadotropin. Yes, the corpus luteum needs a gonadotropin to function. LH is that gonadotropin, but now the LH has reduced. This woman gets pregnant and makes LH like HCG, which rescues the corpus luteum. Corpus luteum continues to make the progesterone. Progesterone continues to make the endometrium secretory, which continues to maintain the pregnancy. So it becomes a very good symbiotic relation, that corpus luteum was about to degenerate and reduce the progesterone, but the pregnancy came and started making HCG, which rescues the corpus luteum. It's like you give me HCG, I'll give you progesterone. It becomes a good symbiotic relation. So now this is what is asked in exams, that the alpha unit of LH is same as the alpha unit of HCG. Okay. In fact, you should also know that the alpha unit of TSH is also the same. So now the alpha unit of LH is same as the alpha unit of HCG. So that HCG will rescue the corpus luteum. In other words, the pregnancy itself rescues the corpus luteum. So what is this maintenance of pregnancy like? So let's see that in detail. So when we look at the maintenance of pregnancy, the pregnancy is maintained initially by the corpus luteum. So the corpus luteum is going to maintain the pregnancy for up to 12 weeks. It's going to function for 12 weeks. After that, corpus luteum becomes lesser and lesser functional. In fact, it will stay till the end of pregnancy, but its good function is only till 12 weeks. But now, see very carefully, corpus luteum is working for 12 weeks nicely, but around the 6th week, the placenta starts to form, and this placenta will maintain the pregnancy till delivery. So, placenta starts the primary placentation. So, primary placentation or the placenta formation starts around the 6th week. Look here, on the day of implantation, there were some initial cells, the syncytiotropoblast and the cytotrophoblast, that was making the HCG, which maintained the corpus luteum, and the corpus luteum made progesterone, which maintained the endometrium, which maintained the pregnancy. Now that went on for 6 weeks. The syncytiotropoblast and the cytotrophoblast, these trophoblastic cells made progesterones. Now they started making a shape of villus, and the primary placentation started. Now when the primary placentation started at 6 weeks, the placenta starts to make its own progesterone. So it tells the corpus luteum that I don't need your help anymore. I'm going to maintain the pregnancy myself. So that placenta starts to make progesterone and it reduces the production of HCG to degenerate the corpus luteum. The corpus luteum slowly starts losing its importance after 6th week. So this is your MCQ. The luteoplacental shift. When does that happen? Luteoplacental shift happens at 6th week. So the HCG graph, which was going on increasing, the HCG levels which were going on increasing, they will increase only till the 66th day of pregnancy. That's also an MCQ. HCG is maximum for the 66th day, which you convert into weeks is 9 weeks plus 3 days. That is 66 divided by 7. Get 9 weeks plus 3 days. So HCG is maximum for those 66 days, 9 weeks plus 3 days. And after that, the HCG goes low. So once again, the placenta starts to form around the 6th week. The placenta comes into good functional unit and that placenta starts making progesterone. It maintains the pregnancy till delivery. At the 6th week, it takes over from the corpus luteum. And at 6th week, it tells the corpus luteum you're not required. So you can slowly move out of the scene. So how does it make sure that the corpus luteum moves out? It also reduces the production of HCG. So HCG reduces and the placenta is now the master of the maintenance of pregnancy. So this placenta is very important. Now that is the major unit which is making progesterones. All right. Also, one more thing which we can see here, that the HCG is increasing till the 66th day. HCG is also known to cause the hyperemesis, the excessive vomiting in pregnancy. That hyperemesis gravidarum is because of the HCG. Now you can see with this graph, when is the hyperemesis gravidarum maximum? Around 9.5 weeks it is maximum. After that, the HCG reduces and hyperemesis actually abates by the time 10 weeks, 11 weeks come. By the time the hyperemesis is much relieved in this woman. All right. Another important chapter is the tests of ovulation. Now, when we talk about ovulation, what hormone increases? Progesterone. So, whatever tests you're doing, please see the effects of progesterone. So, if you keep this in mind that progesterone increases after ovulation, then some confusion which comes in some of the tests will go away. So, when the ovulation happens, progesterone increases. So, you're monitoring the temperature of the woman and suddenly if there's a rise of 0.5 degree Fahrenheit, 0.5 degree Fahrenheit from the baseline, if there is an increase. So, that's what is suggestive of ovulation. Now, progesterone is a thermogenic hormone. Why? Because it causes catabolism, breakdown of proteins, releases heat. So, that is why the basal body temperature increases. Now, serum progesterone levels, if they are more than 3 nanograms per ml on day 21 of the menstrual cycle. From the start of the menstrual cycle, she ovulates on the 14th day. You know that she ovulates on the 14th day and 6 to the 10th day from the ovulation, implantation takes place, or the 20th to the 24th day of the menstrual cycle. So 20th to the 24th day of the menstrual cycle, the progesterone levels are very high and they are also making the endometrium very good for implantation. So if you check the serum progesterone levels on that day, that will be more appropriate than earlier and later than the time between 20 to the 24th day. So day 21 days have correlated best with the tests of ovulation. Then serum LH. If the LH is more than 15 international units, that is suggestive of ovulation. So this serum LH we can do. We can also do urinary LH kits. Lot of patients buy these kits from the pharmacies and they check for the ovulation and they plan their coital activity around the time of ovulation if they're planning a pregnancy. Serum and urinary LH can be tested for ovulation. Now, another test for ovulation is the ultrasound for checking the follicular growth. So, when we're talking about the follicular monitoring, we have seen this picture that shows the ultrasound of the ovary in the initial few days and we see 6 to 7 antral follicles, and then you see these follicles from the 9th day onwards. You see how many of them have become dominant. Usually one will become dominant, and around the 14th day, that dominant follicle will be around 15 to 20 millimeters in size. So this ultrasound and follicular monitoring is the usual method in the OPD for assessing ovulation. This is what we usually do. Most commonly used method of assessing ovulation. Generally, we do a transvaginal sonography from the day 9th onwards, and every alternate day we call the woman and see the follicle growing. And when the follicle shrinks, you know, in this picture you see the follicle nice and round, and let's say on the 16th, 17th day you see the follicle has shrunk, we know that the woman has ovulated. All right. We also advise the women to have intercourse around this time because the pregnancy chances will increase. So that is the follicular monitoring. Okay. Then another test of ovulation is the endometrial biopsy. So what do you want to see? You want to see the effects of progesterone. So on the endometrial biopsy, when you scrape the endometrium, you will see under the microscope, when you do the histopathology, you will see secretory changes. Now, secretory changes is one part of the endometrial biopsy. When you do the endometrial biopsy, on the histopathological examination, you see secretory changes. That is why, that is what is telling us that the woman has ovulated, because progesterones have increased. Now, when do you want to do this? Again, you will want to do when the progesterone levels are high, around day 20, 22, 23, 24, like that. So, we always say do a premenstrual endometrial biopsy. You as interns must have posted a lot of women for endometrial biopsy in the OT theaters, because infertility women need to get a workup and we need to see the endometrium if they are ovulating, and the effects of ovulation are adequate on the endometrium. Now, what is the meaning of this last line? That the effects of ovulation are adequate on the endometrium. One, you see secretory changes. Look, you've taken a biopsy on day 24. You look it under the microscope, you see secretory changes. Good. But if you do the biopsy on day 20, don't you see secretory changes? Yes. You will see progesterone effect even on the day 20. But the progesterone effect on day 24 will be more than the progesterone effect on day 20. So yes, that's the other part you want to see. The adequateness, the appropriate secretory activity. So yes, one thing is you see secretory changes, and the second you see appropriate secretory changes for the day of biopsy. So let me try and explain this to you. Suppose you do the endometrial biopsy, for example, on day 24, and the histopathological examination shows day 24 secretory changes. That means it is appropriate amount of secretory activity. Pathologists are smart enough to look at the endometrium under the microscope and tell you that this is day 24, this is day 22, this is day 18, this is day 8. All of this they can look under the microscope and see the endometrial characteristics, and they can exactly date the endometrium. That is part of the training of a pathologist. They can do that very well. So on day 24, you see day 24 changes, appropriate. But suppose on day 24, you see histopathological examination of day 20 only. Now, the secretory activity which you're seeing on this day 24 is not adequate for day 24. It is showing you changes enough only for day 20. You're very, very sure that you've done the biopsy on the right day. When was the period? It was on 1st of June. When did you do the biopsy? 24th of June, day 24. And the secretory changes report which has come from the path lab, it is day 20. That means there's a lag of 4 days. There is secretory activity. It is enough to be called only of day 20. What is the meaning of that? She has ovulated. The corpus luteum has formed. It is making progesterones, but the progesterones are not enough for day 24. They are only enough for day 20. So yes, when there is a lag of 2 or more days in observed and expected changes, then we call it a luteal phase defect. That is a luteal phase defect, and yes, it is a known cause of infertility. All right. So endometrial biopsy, when we do, we can see two things. One is the secretory changes, and second is the appropriateness of the secretory changes. Another thing we can see on the endometrial biopsy, Yes, we can send it for a LJ media culture. We can see if she's growing tuberculosis, or we can do a CB-NAT to see if she's got tuberculosis bacilli. So that is one more thing we can do on the endometrial biopsy. We're talking about ovulation changes, so we'll stick to that for the time being. Now, another set of tests for ovulation are the Mittelschmerz. You know, Mittelschmerz is the mid-cycle pain due to the ovulation. Some blood, when ovulation happens, some blood will trickle into the pouch of Douglas from the follicle, and they'll cause irritation. And that pain, a lot of women can correlate with that pain. They will tell you that around 14-15 days of a menstrual cycle, I have a sharp pain in my abdomen, and that stays for a day, and then it settles by itself. So yes, Mittelschmerz is a test for ovulation, but it is unreliable, because a woman can get abdominal pain for so many other things, not just because of ovulation. She can have some PID, she can have some appendicitis, she can have some cyst of the ovary which is causing her pain. So it is not a very reliable test for ovulation, the Mittelschmerz. Now, laparoscopy is the best direct evidence of ovulation. If they ask you the MCQ, which is the best test for ovulation, if given the choices, then go ahead and mark laparoscopy, because you're doing a laparoscopy for whatever method. You're inside the abdomen of woman, you're doing a laparoscopy, you're seeing the uterus. When you see the ovary has a yellow body, or it has a punctum which is having a yellowish surrounding, yellowish halo. That is the pathognomic sign that yes, that woman has a corpus luteum. So if you see a corpus luteum, it's a direct evidence that the woman is ovulated. So that is the best evidence. Now be very careful of the language. The language in the exams is very clear. What is the most common method, or the usual method which is utilized for checking ovulation in the OPD? That is ultrasound. Now if they ask you the best evidence of ovulation, and if laparoscopy is given, go ahead and mark that. Okay, don't get confused. Language in the exam is very clear. The language recalled by you students in the guidebooks is a little vague, and we people can't help it because you give us the choices. So sometimes the guidebooks get a little misleading because the choice is recalled and the language recalled is not correct. So remember the theory, the MCQs will become easier. Now, cervical mucus studies. What does that tell you? You know that Spin-Barkett and fern tree pattern. Spin-Barkett and fern tree pattern is seen in the cervical mucus on the 14th day. Which is the hormone which is maximum on the 14th day? It is estrogen. So Spin-Barkett and ferning is because of estrogens. So be very careful. We are talking about tests of ovulation, and in this I've told you we want to see the effects of progesterone. Remember, cervical mucus studies showing Spin-Barkett and ferning maximum is because of estrogens. Now, you are doing this test in a serial method, like serial ultrasonography I discussed, 9 day, 11, 12, 14, 16, like that. So serial cervical mucus studies. What is cervical mucus studies? You do a per vaginal examination of this lady on the 8th day. You don't see much stretchability of the mucus. Day 10, you see some stretchability. Day 12, lot of stretchability. Good. And day 14, you see maximum stretchability, maximum Spin-Barkett. That means there is high estrogen. And then on day 16, you see the stretchability is reduced. Day 18, you see the cervical mucus is so thick that there is hardly any stretchability. So when the cervical mucus becomes thick and the Spin-Barkett is lost, you think, oh, the cervical mucus has become thick. Maybe she has ovulated. So please be careful. Don't say Spin-Barkett and ferning is ovulation. Loss of Spin-Barkett, loss of these. Yes. Now, when we talk about the treatment of abortions, let's say that when we talk, we are now looking at prevention of abortions because of chromosomal defects. Let me try and explain. A woman loses a child, or maybe a baby was born with Down syndrome. Next time she doesn't want to have a Down syndrome baby. So, can I do something? Can I give her some tablet? Can I do some treatment which can make sure that the baby is not Down syndrome? No. Down syndrome inheritance is a lot of probabilities, and you know the mode of Down syndrome formation. So if there is going to be a translocation, or if there is going to be a deletion, then there is going to be Down syndrome. So the chances are that it may not be 100% every time. So to make sure that the baby is not Down syndrome or any other aneuploidy like they say, we can do some screening tests, and those screening tests which can make a fair amount of doubt we can get if the baby is aneuploidy or not. Those are these. So screening tests for aneuploidies, what we can do? We can do around 12 weeks, we can do the dual marker test, pregnancy associated plasma protein A. PAP-A in aneuploidies will reduce. Human chorionic gonadotropin, the other part of the dual marker, will increase. Remember, H for high. Or we can do the NT-NB scan around 12 weeks. NT is the nuchal translucency, in a transverse view of the baby, we see the fat pad, and that fat pad should be less than 3. If it is more than 3, then it is increased aneuploidy risk. All right, that's a increase here. Then if the nasal bone NB is short or absent, more chances of a aneuploidy. Then triple marker, all of us know, are 3 markers which are done around 16 weeks. The bioanalytes, which we can use for checking aneuploidies. Unconjugated estriol, E3 is estriol. If that is reduced, alpha fetoprotein, if that is reduced, and human chorionic gonadotropin, if that is increased, again H for high, then a risk of aneuploidy is made by triple marker. Even more sensitive is the quadruple marker. Then quadruple marker is triple marker, all the factors of triple plus inhibin, and inhibin also increases in aneuploidies. So when inhibin increases, we remember IN for increase, H for high. So these HCG and inhibin are generally high, all the other analytes are low. So that's one way of remembering things. Remember, when we do these tests, we can just do the dual marker, we can just do the triple marker. So the sensitivity of a test is around 80 to 85% or maybe 90% when we do the quadruple test. But if you do all of these, that is known as the integrated screening, then your sensitivity of picking up abnormalities in the fetus is more than 95%. So that is known as the integrated test. We do all of these together. Now, there's one test which has been added in the list, and I want you to understand this. This is the non-invasive prenatal testing. NIPT is, you take the mother's blood, and in the mother's blood, you can look for the fetal DNA around 12 weeks. It is known as the cell-free fetal DNA. The fetal RBCs, lymphocytes, they don't reach the mother's circulation. But yes, the fetus undergoes some amount of hemolysis, like you and me also undergo some hemolysis. We have the spleen which is taking out all these broken cells and RBCs. But yes, before it is cleaned up by the spleen, some lymphocyte DNA which is broken lymphocyte or a broken RBC, the DNA which is freely moving in the fetal circulation, that can go through the villi and reach the maternal circulation. So yes, not the RBC, but the broken fetal DNA. Fetal DNA can be taken off from the maternal blood after 12 weeks and gives a fair amount of assessment. But that is more than 98%. More than 98% sensitive. So you may think it is very good, sensitivity is so high, but it is not 100%. That's why it is still in the list of screening tests. When it was introduced with a lot of fanfare, and the companies which were doing it, they were doing it very expensive, around 50,000 was the cost. Nowadays, it is done around 10,000 to 15,000 because we doctors are not relying it on so much, because it's a good screening test at best, because it's not 100% sure that the baby is Downs or not. So if you want that 100% surety, you have to do the diagnostic test. So yes, these are all the screening tests. Remember the timings of all the screening tests. In the exam, they're going to ask you that if the dual marker of a patient is sensitive of aneuploidy, what's the diagnostic test? So you should know that 12 weeks is the time when you do the dual marker. And what is the diagnostic test at 12 weeks? Yes, chorionic villus sampling. So you must know the duration of the timing of the diagnostic test and the timings of the screening test, and then give answers to these integrated questions which are going to come now. So remember, chorionic villus sampling is 10 to 13 weeks, and that is going to take the chorionic villi. Very simple, that the fetus, which is having its placenta here and the fetus is here. This is the amniotic fluid. So we put a needle into the placenta. Placenta is made up of syncytiotrophoblasts and cytoblasts, which make the villi. So placental villi is aspirated by the needle. So placental villi, we also want to call it chorionic villi. So basically, we're doing a biopsy of the placenta, and the fetal villi are checked for the fetal representation, fetal chromosomes and the fetal genes. So that fetal villi will give us the information, but we call it not placental biopsy, we call it chorionic villus sampling. So please don't get confused. Placenta is equal to chorion. So placental cancer is chorionic cancer, as simple as that. So placental biopsy is chorionic villus biopsy. It's as simple as that. Don't get confused. Now, chorionic villus sampling, what do? You take out the fetal villi. What do you see in the fetal villi? In the fetal villi, you can see the karyotype. And on the chromosomes, let's say these are the chromosomes. On these chromosomes, you can see the genes also. What are the genes on this chromosome? Long arm, short arm, etc., etc. So karyotype and genetic analysis you can do by the chorionic villus sampling. Now, amniocentesis, you put a needle into the amniotic sac after 16 weeks. 16 to 18 weeks generally is the time, and that again will tell you the karyotype and the genetic makeup. But yes, the chance of abortion because of this, chance of abortion is much lesser, less than 1%. Excuse me, less than 1%. All right. Then, chance of abortion in a chorionic villus sampling is 1% and more. So that's why a safer procedure is amniocentesis. Chordocentesis is after 18 weeks, you take fetal blood. So when you get fetal blood from the umbilical artery, that blood you can run a karyotype much faster. So that's why this is a still better test, but can be done only a little late. So these are the methods by which you can help prevent an abortion or an anomalous child coming next time. Now, what else can be done? Sometimes all these tests which you are doing, these are done in the pregnancy, and to confirm, we are going to do these tests which are invasive tests. All of these three tests are invasive. They're going to give us a definitive, a pakka answer. The baby is Downs or not? Baby is, Patau syndrome or not? Turner's or not? We're going to get that definite pakka answer. But these are all invasive. So nowadays we feel that maybe we can do something to prevent an abortion in this lady before she is pregnant. And that is definite. What is that definitive thing you can do before the lady gets pregnant? So before the pregnancy, we can only have a risk assessment. But now we have a method by which we can very surely say that the baby this woman is going to have is going to be 100% safe. That method is known as the pre-implantation genetic testing. So what else we can do for these abortions? We can take the sperm from the man, the eggs from the wife, make an embryo, and these embryos, day 3 or day 5, we can take a biopsy this embryo. We can take a biopsy of this embryo and send it for a genetic testing. And if the embryo is fine, then only we put it into the uterus. So we are very sure that whatever embryos are going into the uterus are 100% safe. So pre-implantation genetic testing, and this is now commercially available. We are doing this as recent as 2 months back. We did it in my hospital, and this woman had recurrent abortions and she had a baby with anomalies. The baby was lost, and now we took out, we made her embryos in the lab, and out of 7 embryos we got good 5 embryos which were sent for a genetic analysis, and only 1 embryo has come safe for having the defect which we were testing for. So yes, that safe embryo is going to be transferred. I hope by the time I do the next edition of the rapid revision, maybe I can tell you whether that embryo implanted and gave a healthy baby. Fingers crossed. So that is what is done. We take a day 5 embryo, and this day 5, okay, day 5. So this day 5 embryo, let's say this is a blastocyst, and we are holding it with a holding pipette, and then we have a biopsy pipette here. So with this, we'll give a suction through this wall of the blastocyst. This is a blastocyst biopsy. Of course, how do we break this? This biopsy is done with the help of a laser. Yes, there were methods by which you could physically break this by some sharp instruments which you used to have. Now that is outdated. That used to damage the embryos. So what we do a laser shots on this, break the wall, take out some tissues, and then freeze this embryo till the reports come from the genetic lab. So that is what is pre-implantation genetic testing. Now, let us get into the induced abortions. When we talk about induced abortions, we call them medical termination of pregnancies. And this act was passed in India in 1971. First amendment was in 1972 itself. Then many other amendments and some modifications happened. But the latest amendment, which has come in your exams now, and all of us know that we can do MTP till 24 weeks now. And from 20 to 24 weeks, if you're doing the abortion, 2 doctors are required. So many directions and many specific instructions have been given to the doctors. There's a whole gazette which has come out about this. But the latest amendment is that abortions can be done now till 24 weeks. Right. So when we're doing these abortions, what are the indications? Indications are the 4 main indications that the mother is at risk. Let's say she has for example, a very severe heart disease, and she's going to probably die because of the pregnancy, like Eisenmenger syndrome or a severe aortic stenosis. She's not going to make it throughout the pregnancy with this pregnancy. She's not going to last the whole pregnancy. Then maybe some severe renal disease. Then fetus at risk. Maybe the baby has an anencephaly. Or before 24 weeks, you know that it's a confirmed Down syndrome. So all of these, the fetus is at risk or the baby is dead. All of these, you can do an abortion. Then humanitarian causes, that there is a pregnancy due to rape. Obviously, then we can offer an abortion to this lady. And pregnancy due to contraceptive failure. Now, this contraceptive failure is a virtual, a free certificate to our women that, okay, they'll just come and tell us that, yes, I'm pregnant, I don't want to have this child. And I'll give her a lecture that, pregnancy is life and you should let the pregnancy continue. Don't abort a child and, keep it. And she said, sir, my condom burst and that's why I didn't want to have a pregnancy. Now, there's no way I can prove that she never used a condom in first place. But those are debatable things. But this is a virtual certificate for anybody in this country to have an abortion. Contraceptive failure. So these are the 4 indications. Now, who can do an abortion? Only a doctor can do an abortion. That doctor better be a gynecologist. So MD, DNB, DGO. MD or DNB or DGO in obstetrics and gynecology. Okay? A gynecologist only can do abortions. Please remember that. Some modification is there. That, okay, an MBBS who is trained in gynae for 6 months has some idea about doing abortions now because has trained properly for 6 months, has worked with doctors who are doing regularly MTPs. Or an MBBS who's performed 25 MTPs under supervision of a gynae. So these are the people who can do an abortions. Then the ASHA activists, the ASHA worker and the Ayush workers, these people cannot do an abortion. All right, there's a lot of talk about them being allowed. Nothing is been so far. We are recording this in 2023, and so far there are no national recommendations that these people can do an abortion. And I would insist that all you doctors also be very aware about what's happening around you, and you should put your representation. I'm not trying to force a decision on you, but since you people are trying so hard to get into post-graduation, and so many of you are budding gynecologists, and I would not want all your effort to become a gynecologist be just compared to a person who's not done so much of work and has not had so much of training, and that person is allowed to go ahead and do an abortion. So still it is rapid revision. I don't want to tell you so many things about what I feel about this, but yes, ASHA workers and Ayush workers are not allowed to do abortion so far. And personally, I feel that the doctors only who have seen a lot of complications. Look, one more thing I can say. I have done a lot of surgical work as a gynecologist, and God has been, I'm blessed with some good luck. And I feel that I want to do a lot more in my life. But of all the surgeries I've done, all the laparoscopic work and all the open work I've done, and all the cesareans I've done, I'm very, very scared and I'm very careful about doing an MTP even now. I'm the head of the department wherever I'm working, and I'm very, very careful when I'm doing a medical termination of pregnancy, because even a normal pregnancy, which you're trying to abort because of an anomalous baby also, that baby, that MTP may bleed so much that you may even lose a patient sometimes. So please, abortions is something which I'm very, very emotional, and I don't want our pregnant ladies those young girls sometimes to have abortions by these untrained people, by these people who are doing these abortions in the back alleys and cause septic abortions, and these women get into ICUs and lose their lives. So yes, it's a very emotional issue, and you doctors should be very, very careful as to who is doing abortions around you. All right, keep an eye out. Let's move on and see how you do the first trimester abortions. Now, first trimester abortion we can do by medical methods. First trimester is up to 12 weeks, and medical abortions, this is the one which is now in vogue. A lot of people use this. Please, it's very simple method, and if you give mifepristone, mifepristone is an anti-progestin. Anti-progestin will kill the fetus. 200 to 600 milligrams. More later in the pregnancy, higher dose you can give. 200 is enough, but 600 is safe amount, which if you give, it will give surety that the pregnancy will degenerate. So anti-progestin will kill the fetus. You give it orally, and then 24 to 48 hours later, you give the vaginal misoprostol. Now, this is 800 micrograms. The tablet is 200 micrograms actually. So you have to give these 4 tablets vaginally. So this is prostaglandin E1, and that expels the baby. So this kills the baby and this expels the baby. Now, this is a very good method of doing abortions medically in the early pregnancy, but follow these steps. This came as a question in your NEET around 5 years back, that arrange in order the method of doing medical termination of pregnancy by drugs. So first, you always do the ultrasound to locate the fetus, whether it's intrauterine or not. If it is an ectopic, yes, the management is totally different. So if it is an intrauterine pregnancy only, then only you do an abortion. Then counsel regarding the drugs, that this is to be taken orally, this is to be taken vaginally, and after taking the drugs, you start bleeding vaginally, and that bleeding might be like a heavy period, normal to heavy period. And if you have too much of a heavy period, then come to us anytime in the hospital and we'll take care of you. So sometimes these medical abortions, if they bleed a lot, we may have to do a D&C. So counsel, then administer the drugs, bleeding to get over, and after that do another ultrasound. We say it a check sonography, a check ultrasound, to check if the abortion is complete. So if this is followed in this order, then the success of abortion is 99% if it is done till 7 weeks, which is the recommended time in India, and 95% if it is done till 9 weeks. Look, it is better that you do till 7 weeks. It's not that you cannot do an abortion in India by medical methods at 9 weeks. You can do, but it is better that if you do it till 7 weeks. It is a recommendation, not a law, that you cannot do beyond 7 weeks and you cannot do medical abortion beyond. It's a recommendation that you better do it till 7 weeks only. Now, what can be done in the first trimester apart from the medical abortions? First trimester, we can do a suction evacuation 8 to 10 weeks, and that is, in the uterus, we put in a Karman's cannula to suck out the fetus. Now, how can you make that suction? Karman's cannula is the device which goes into the uterus. It's a device like this pen, and it goes into the uterus, and the suction apparatus builds up the suction to pull out the baby. Now, suction, how can it be made? It can be made by an electrical machine. This machine you've seen in all your OTs, which is making the suction, and this pipe here, this suction which is made, this pipe here is connected to the cannula, and that cannula, when it is attached, this goes into the uterus and pulls out the fetus. Now, we can generate this section even manually. Now, that is the manual vacuum aspirator, hot shot MCQ in your exams. So, manual vacuum aspirator, what is the volume? It is 60 ml. And this question came whether it is 30 ml or 60 ml. 60 ml is the volume. It can be done in the outpatient department in local anesthesia. A negative pressure of 610 to 660 millimeters of mercury is made by this syringe, and this can be done even up to 12 weeks. All right. So this is the this is the company, the IPAS Miva Plus aspirator. All right. So this is a picture from the site, and we use this manual vacuum aspirator. You must understand that the Karman's cannula is going to be attached on the top, and when you pull this syringe, it's going to make the negative pressure in this cylinder of 60 ml, and these two flanges, when you pull this out, these two flanges will rest at the hub of the syringe, so that when you pull it, it'll stay pulled, it will not go back. So it'll keep the suction. You don't have to keep on pulling it. Moment you pull the flanges out, they will rest at the base of this syringe. And then with this pressure generated in the cylinder, you attach the manual vacuum aspirator, you attach the Kaman's cannula on the tip of it, and then put that assembly into the uterus to suck out the fetus. So this is how the Kaman's cannula looks like. So these are the various sizes. There's a color code, but what we generally ask in the exam, the sizes. There's a size code and a color code. And suppose it's an 8 weeks pregnancy. So 8 size Kaman cannula is used. 10 weeks, 10 size. Like that, the Kaman's cannula is selected. And this Kaman cannula, when it is inserted into the uterus, this will generate, this will suck out the baby with the generated pressure, which I told you in the previous slide can be made by a electrical machine or a manual vacuum aspirator. So this is the suction evacuation in the first trimester. Now, in the first trimester, you can also do the standard technique of doing an abortion, which is put in a curette inside and scrape the baby out. That is what is known as a dilatation and curettage. But after 12 weeks, you cannot put a curette and scrape a baby out. You know, the Sims curette which we keep showing you. That curette is not enough to take out a big baby of, let's say, 18 weeks, 20 weeks. That baby is just too big to be pulled out by a curette. So after 12 weeks, when the baby is very big, then we cannot do a dilatation and curettage. After 12 weeks, we do a dilatation and evacuation. Now for dilating the cervix, look, we are going to do an evacuation, that is to take this big baby out. For taking this baby out, we need some big instruments. We cannot scrape out, like I said, with a curette. Let me show you the next slide first. See, this is the instrument. This is the ovum's forceps. Ovum's forceps, this is an instrument which is going to go inside the uterus and grip the fetus and pull it out and take out the fetus in bits and pieces. You cannot take it out by this Sims curette. Sims curette is a instrument which can be used for taking out a fetus which is much smaller, and this is used for doing an endometrial biopsy, even for a DNC, but we cannot use it for taking out a fetus which is much bigger. So what I'm saying, I have to first open the cervix. How do I open the cervix? That is the dilatation. I can open up with these laminaria tents and Dilapan. So what are these? These are devices which will swell up once you put them in the cervix. So what is that first device? First device is the laminaria tent. It's a dried seaweed. That dried seaweed, when you put it into the cervix, it's going to imbibe the fluids from here and it is going to swell up. When it swells up, it's going to dilate the cervix. So this is how the cervix will get dilated with this, and this takes around 12 to 24 hours for the dilatation to happen. So it has got this one string attached to it. After around 24 hours, you pull it out and the cervix is dilated. Then you can put an instrument and take the baby out, or you can even induce contractions with prostaglandins. So dilatation and evacuation. How you dilate? With the laminaria tent. Now what is Dilapan? Dilapan is a synthetic dilator, and this synthetic dilator, that is going to work in around 6 hours itself. That works in 6 hours itself, much faster. Also, you can dilate the cervix by a serial dilatation, you know, from here to the biggest, from the thin wire size dilator to the biggest 16 to 18 size dilators also we have in Hagar's. So you can dilate the cervix and get the same results which we got with the dilatation in this laminaria tent. Of course, this will require some anesthesia, because dilating like this will require local anesthesia or a general anesthesia. So we dilate the cervix and pull out the baby with this device, the ovum's forceps. Now, what is the best method of these second trimester abortions? I said D and E is one method, but the best method of doing abortions in the second trimester is to use the prostaglandins. We can use misoprostol, PGE1, orally or vaginally or rectally. We can use danoproston, which is PGE2, and that can be given as a tablet orally or a gel vaginally. Interns must be familiar with this Cervi gel, Cervi Prime, which is used for labor induction in the labor rooms. It's the same thing, danoproston. And then carboprost, PGF2 alpha, 250 micrograms intramuscular only. Just like for PPH. PPH also we give carboprost, IM only, never IV. Causes sudden hypertension if you give it IV. So IM only. So these are the methods by which, depending on the gestation age, all these drugs have their own particular doses, but these are the methods by which we can induce an abortion using prostaglandins, and these are the methods of choice. Now, if nothing works, then we do a surgical removal, and that is hysterotomy. That is making incision on the uterus and taking the fetus out. That's like a surgery, and it is like a cesarean section. Only thing, it is done before the lower segment is made. So what is lower segment cesarean section? At around term, when the lower segment is formed, around 7 centimeters in size, the isthmus, becomes the lower segment, and then you can make an incision on the lower segment, and that lower segment is made in the time of labor. Just before labor, the lower segment is formed. Now, when the lower segment is not formed, let's say 24 weeks, and you're trying to take out the baby by incision, when there is no lower segment, then you're doing incision in the lower uterus, not in the lower segment. You're doing incision in the uterus, which is a incision which cannot be given trial of labor later on if she gets into normal pregnancy. So please remember, if it is a hysterotomy, it is not in the lower segment, it's in the uterus. An incision in the uterus is hysterotomy, and it is like a cesarean section, but it is in the upper segment. Okay, so when we're doing a hysterotomy, that to take out the fetus is the last desperate method. Complications of abortions, not just of a hysterotomy. I'm talking about all the methods. If we just draw a line here to allay your confusions, any abortions can bleed, and that's why I said, I'm still very careful when I have to do an abortion. Mostly, I will never do abortions. I mean, it's a personal thing of not doing abortions of live pregnancies. I would do for anomalous babies and babies which are dead. So, but even then, they can bleed a lot. They can be retained bits, which again can bleed, and you may have to do a surgical evacuation of the retained bits. They could be injuries on the cervix or the vagina. They can be uterine perforations. And uterine perforations, if they are because of a uterine sound, if it is because of a sound, then we can just do observation, because a sound is a very thin perforation and not cause a problem. This MCQ came in your NEET exam, that if it is a perforation with a sound, nothing much, observe, keep her for the day, send her home tomorrow, and nothing much happens. But if it is perforation with a dilator or by a ovums, which you're using for the evacuation, that is a very big tear in the fundus. You may cause a bowel injury, and the bleeding might be very severe. So if there is a perforation because of this, then you have to do a laparotomy or a laparoscopy. If there are gynecologists available who are good in laparoscopic surgery, better method is to do a laparoscopy and do a suturing of these defects. But yes, bigger instrument, go ahead and open rather than just doing observation. A uterine sound you can observe. Now, the patient can have a lot of infections after MTPs, and those infections are generally because of the enteric bacteria. It can be Klebsiella, it can be Pseudomonas, it can be Proteus, E. coli, staph, strep. Such severe sepsis can happen that the patient may end up in an ICU, and that's a very, even in a developed country now, I would like to say we are better than developing. Yes, we are still in the category of developing, but our metros are developed at least, and every metro, every big city in the country has a general hospital, a government hospital, which is providing free MTPs to all women. So why go to quacks and why end up in septic-induced abortions? So yes, septic-induced abortion can cause infection with the cause of the microbes, which I told you just now. But yes, how do you diagnose this septic-induced abortion? It is a patient having, why do we say it is septic-induced? If a patient is having fever more than 100.4 degree Fahrenheit, if there is purulent vaginal discharge, or if there is, when you're doing a per vaginal examination, there's a uterine and an adnexal tenderness. Now, the treatment of this septic-induced abortion is to give broad spectrum antibiotics, admit her in the high-risk wards or in ICU for that matter, give her cardiotonic drugs and increase her blood pressure by adrenergic drugs, and make sure that the BP is maintained and she's having a good urinary output, maintain renal perfusion, see her central venous pressure. So that patient requires ICU because of the sepsis, and many patients will even die because of the septic-induced abortion. So yes, all you interns have seen this happening, and I hope it is reducing as we all grow into a developed nation. And when there are septic-induced abortions, the grade of the sepsis, grade 1 is uterine infections. Grade 2 sepsis is pelvic inflammation, that is inflammation around the uterus into the broad ligaments and the tubes and the ovaries, the adnexal organs. And grade 3 is full-blown peritonitis. So yes, that is a very distressing complications of these abortions. So best way to avoid this is to follow the instructions given by the government, that do abortions only in government approved centers where there is availability of trained senior gynecologists and surgeons. Tumors. And when we talk about ovarian tumors, the age group is the 6 to the 7 decade. Not that small girls and young women don't have it. They can also have. But mostly the ovarian tumors, especially the malignancies, are seen in older women. Now, this is basically because of the main etiology of incessant ovulation, non-stop ovulation. Now, what happens with ovulation? You know, every month the follicle ruptures, oocyte goes out, and the surface of the ovary gets a scar every month. So when there's a scar every month, there are 12 scars every year. And when a woman has too many scars, too much of healing and overhealing can cause cancers. All right. Now, who will have more scars? Especially women who will have more menstrual cycles, early menarche, late menopause, then infertility treatment by ovulation induction. So what is happening in ovulation induction? We are making follicles every month, especially when you're doing IVF, we're making 10 to 15 follicles every month. And if you do 3-4 IVF cycles in a woman, that means around 50 to 60 follicles have been made. So 50 to 60 scars on the surface of the ovary. And then nulliparity. That means there is no break from ovulation at all. She's never had that break, because when women conceive, they will not menstruate for 9 months, plus another 1.5 years because of lactation amenorrhea. They will not ovulate and menstruate. So women who conceive, they protect themselves from ovarian tumors. And women who are nulliparous will have more epithelial scarring and more ovarian tumors. All right. Then ovarian tumors can be because of mutations in the breast cancer antigen 1 and the breast cancer antigen 2. And there is a very strong predisposition because of familial cancer syndromes, which I told you in endometrial cancer also, that if a woman has CA breast, CA endometrium or CA ovary, then there's a likelihood that the first degree female relatives can have these cancers, any of these cancers. So suppose a woman has 2 first degree relatives, that is her mother and sister have endometrial cancer. So this woman can have a ovarian tumor, almost 35 to 40% chances there if there are 2 first degree female relatives having this, any one of these tumors. All right. So when we discuss about the etiology of ovarian tumors, I told you that the main etiology is the injury on the ovarian surface because of ovulation and causing scarring. Then I told you the BRCA and, the correlation with family. So when we're discussing about all this, this etiology is going to cause, all of this is going to cause the most common ovarian tumor, and that is the surface epithelial ovarian tumor. So please remember, the most common ovarian tumor is the surface epithelial ovarian tumor, or simply called the epithelial tumor. So whenever I ask you the etiology of ovarian tumors, this is the etiology you have to discuss, and that is for the surface epithelial ovarian tumors. And suppose somebody asks you the etiology of germ cell tumors like the dermoid, or the sex cord tumors like the granulosa cell tumors, there's no specific etiology. So this specific etiology, the ones which I told you, correlates with the most common ovarian tumors, which is the surface epithelial ovarian tumors. All right. We'll discuss the pathology about all these individual tumors a little later in the chapter. But first, now let's see what are the associated features like the CA125. Now, CA125 is one tumor marker which may be increased in ovarian tumors, but it is not specific, because CA125 will also increase, remember, in endometriosis and then in gut cancers, sometimes in tuberculosis, pregnancies, fever, many places CA125 can be high. So please remember, ovarian tumors, CA125 is not specific, but it is a good follow-up tool. So if a woman has, let's say, an ovarian tumor and a CA125 of 6,000, and when you remove the ovarian tumor and the CA125 falls down to, let's say, 600, then it's a good follow-up tool. And you're keeping the woman on a follow-up, and suddenly after a few months, you see the CA125 from 600 has increased to, let's say, 4,000 now. So you may think of a recurrence. So as a follow-up tool, it is a good method, but not as the specific diagnostic tool. So the significant values of CA125 in a premenopausal woman is more than 200 international units, and in a postmenopausal woman, it is more than 35. Okay. Now, the pathology, like I told you, we'll discuss individual pathologies a little while later, but the symptoms of ovarian tumors are mostly because of its huge size. Now, how big can you imagine an ovarian tumor can be? Let me tell you that I have personally removed an ovarian tumor in the hospital where I'm working now, way back in 2004, which was around 23 kgs of a size. So that can be the size of an ovarian tumor. And I thought that it was a very big tumor which I removed, must be a record kind of thing. But I found out that in 2004, the record was already 300 pounds of an ovarian tumor. So yes, roughly 136, 137 kgs of a ovarian tumor has been removed in humanity. So that is the biggest tumor of mankind, biggest tumor ever removed. You can check on your YouTube or your Guinness, wherever you want. The biggest tumor actually ever removed is a ovarian tumor in all humanity, men, women, children put together. So that kind of a tumor can cause bloating, distension, can cause compression of organs, compaction of organs, and it can cause the, bowel and bladder symptoms. So basically because of the large size. But yes, they can be a malignancy wala signs. What are the malignancy signs? That they can be loss of weight, loss of appetite and other things, and cancer cachexia when there is a malignancy for a long time. Another feature, if a tumor is very rapidly growing, then it is suggestive of a malignancy. So after the symptoms, how do you make a diagnosis of an ovarian tumor? Now, when we say the imaging, the best imaging mostly in gynecology is magnetic resonance imaging. If you want to say, let's say in fibroids or even in endometriosis, we always say MRI is the best imaging. Mostly in gynae, if you say that, you'll be correct. Now, ultrasound is the first imaging and it is usually adequate. We do ultrasounds and mostly we make a decision on that. And if the patient is affording, we go ahead and do an MRI also. But then mostly our diagnosis is made by the ultrasound alone. So what are the features of malignancies when we do an ultrasound? So on the ultrasound, if the tumor is bilateral, that is both the ovaries are involved, surface of the tumor is irregular or there is a surface growth, which can be seen on the ultrasound, and cystic and solid areas together. The feel of the tumor, especially when you do a per-vaginal examination and you put your fingers in the vagina and you go next to the uterus, you feel a cystic mass, and that mass also has got a solid area feel. So that is called a variegated appearance, cystic and solid appearance together. So that is suggestive of malignancy. And if the tumor is septated, so septate like this, if you see septate especially a septated tumor with septae which are more than 3 millimeters, especially more than or equal to 3 millimeters in size. That is a significant size of a septate. Septated tumor, significant of malignancy. And another feature of malignancy is ascites in the abdomen when you're doing this ultrasound. All right. Now, all of these ultrasound features which I just now discussed with you, these along with the menopausal status of the woman and the CA125 levels, these are taken together to calculate something called the risk of malignancy index. That is, if I see a tumor on the ultrasound, what is the probability that this tumor is likely to be benign or malignant? So the menopausal status, if the woman is postmenopausal, she gets 3 points. If all these features which I discussed with you, if more than one is present, she gets 3 points. And the absolute level of CA125 is that is used. All of these are multiplied. And if the value is less than 25, then it's a low risk for malignancy. And 25 to 250 is a moderate risk, and more than 250 is a high risk for ovarian malignancy. Now, having known whether this tumor is malignant or benign, next thing is the management. Now, the management is combined with the staging. Now, what did I tell you about staging in gynae? All cancers in gynae are staged surgically except CA cervix, which is done clinically. So, what do we do in ovarian cancer? We do a staging laparotomy. And while we're doing the staging, we do the optimal debulking, maximal cytoreduction also. Now, that is the most important part of ovarian cancer management, the staging laparotomy and the optimal debulking. And they always ask you the steps about this staging laparotomy. Let's see about that now. Staging laparotomy and maximal cytoreduction. Staging laparotomy and maximum cytoreduction. Let's see what do we mean by that. So, you do a midline incision or a paramedian incision for that matter, and vertical incision, because if you require, you can extend it upwards. After doing the incision, you do the staging. But before I tell you the method of staging, remember, we are going to do a maximal cytoreduction. Remove all bulk of disease. Now, sometimes the tumors can be perfectly removed and all the other disease, suppose there's a tumor involving the bowel, you can remove, resect the growth on the bowel and do a reanastomosis. But sometimes it could be at a very sensitive area like next to the aorta, or a growth inside the diaphragm, which you cannot make a hole in the diaphragm, isn't it? So sometimes you may have to leave some disease or some tumor behind. So whatever you leave behind should be always less than 1 centimeter in size. So either you do maximal cytoreduction or you do an optimal debulking. Optimal debulking means if you cannot remove everything, what you leave behind should be less than 1 centimeters. All right. So now when you do the laparotomy, first thing you open the abdomen, you see if you see the tumor, but along with that, if you see some ascites, take the ascites and send it for cytology. Why we send the cytology? Because I want to see if the cells from the ovary are coming into the abdominal surface already. So that will change the staging. So I'll send the ascites. If there is no ascites, I will wash the abdomen with some saline, let's say 50 ml saline, and I'll wash the pouch of Douglas, and I'll wash the paracolic gutters, under surface of the diaphragms, and I'll take this fluid and send for cytology. So I must send some fluid for cytology when I'm doing the staging. Then I will also do a clockwise exploration of the abdominal viscera, right from the pelvis to the right iliac fossa, ascending colon, the hepatic flexure, the transverse colon, the splenic flexure of the gut, and the descending colon, the sigmoid area, and back to the pouch, and the area around the aorta also. So I'll look at all these areas and see where all the growth is involved. Okay, and then I'll do peritoneal biopsies, and I'll also sample the diaphragm by scraping under the diaphragm with a spatula. Then, very important is the supracolic omentectomy. Why do we do supracolic omentectomy? Why do we take out the omentum? Even if the omentum is looking normal, suppose there is some disease, the ovarian tumor is obviously involving the omentum. You remove it, it makes sense. But even if the ovary is having a cancer limited only to the ovary, let's say right ovary, and the normal, the left ovary is normal, the uterus normal, and there's no growth anywhere, why do you remove the omentum? Why do you do a supracolic omentectomy? Mind you, earlier we used to call it infracolic. From the last 2-3 years, the books are saying supracolic omentectomy, and that's what we are doing these days in practice. So why do you take out the omentum when it is even apparently normal? So the purpose is what I've written there, staging laparotomy. I want to know whether the tumor from the right ovary, whether it is spreading into the abdomen already. Sometimes you cannot see the growth. Obviously, it is involving only the right ovary, but who knows, microscopically, it is involving some organs in the abdomen. So how many organs are you going to take biopsy? There are so many organs in the abdomen. All the organs, you're not going to take a biopsy and send it to the histopathology. You'll take sample of that one organ, which is likely to be more than other organs to get involved. And that organ is the omentum. Yes, you know, it is known as the abdominal policeman, or it is also known as the abdominal scavenger. So the first organ which will likely be involved in a metastasis will be the omentum. So that's why even if it is looking normal and you know that the ovary is having a cancer, omentum comes out even if it is looking normal, and send that to the path lab. And if the omentum is involved, microscopic growth is there in the omentum, my stage will increase. We'll come to the staging next. This is the method of staging. Mind you, PG entrance students and MCI students, these steps have always been asked in the exams, and they'll ask you, which of the following is not a step of staging laparotomy? So these are the steps. And then you'll also do the retroperitoneal lymph node sampling as the last part of the staging laparotomy. So when you do this, remember, you have done this laparotomy, you remove the tumor, and you've done these steps of staging laparotomy. Now, what is the staging? After having done all what was the steps, this is the staging of ovarian tumors. The tumor is limited only to the ovary. 1A is one ovary, 1B is both the ovaries. Now 1C involving one or two ovaries, one or both the ovaries. But along with that, there is a surgical spill. While I was doing the surgery and I was, finally I had removed the tumor from the ovarian pedicle, I had taken out the ovary, and while removing, I made a nick on the ovarian surface and the fluid from the ovary spill into the abdomen. Because of my surgery, it spilled. So that surgical spill is now part of the staging, and these are new developments. Okay, C1 is surgical spill. So after that, if you have other information that the ovarian surface had some irregularity and there was some growth on the surface, that is C2. And the ascites which you sent, if that turned out to be malignant, then it becomes C3. After this, if the growth is going into the pelvis, so that is 2 stage. Stage 2A, uterus and fallopian tubes. Please look at this stage 2B, other pelvic organs. From the ovary, it's gone to the pelvis. In the pelvis, it's involving the uterus and the tubes first, and then the other organs in the pelvis. Other organ in the pelvis means the bladder, the rectum, the pelvic lymph nodes. So please note, we have discussed 2 cancers before this, CA cervix and CA endometrium, and both of those, bladder involvement is stage 4A, but here the bladder involvement will be 2B. So I have mentioned this in a very, very important manner here. Other pelvic organs, this is PG entrance questions. They'll just say C ovary involving pelvic lymph nodes, what is the stage? C ovary involving bladder, what is the stage? Don't say 4A. That is in CA cervix and CA endometrium. Here it is stage 2B. Okay, be careful. Then after stage 2, when it comes to the abdominal viscera, organs of the abdomen, if they involved, then we say, please, the point to be noted here is the viscera. If the abdominal organs are involved, then it is stage 3. Please note, ascites has malignant cells. That is stage 1. Although you know ascites is in the abdomen, don't say ascites positive with malignant cells is abdominal stage 3. No. If it is having an ascites which is having malignant cells, then it is still stage 1C. It is not stage 3. When organs of the abdomen like the liver, spleen, bowel or the diaphragm, something like this involved, then only it becomes the stage 3. Now what is stage 3? Stage 3A is retroperitoneal lymph nodes, and stage 3A2 is microscopic abdominal involvement. That is, remember I had sent the omentum and that omentum comes positive, then that becomes stage 3A2. Now stage 3A1, interestingly, they made it really, really detailed. Retroperitoneal lymph nodes if they involved, then it is stage 3A1. If it is less than 10 millimeters, it is A1 bracket 1, A1 ka 1. Then if it is more than 10 millimeter size lymph node, then that is A1 ka 2. Alright. So yes, this is a little excruciating detail, but fortunately it's not come in the exam. They'll just ask you if the retroperitoneal lymph nodes are involved, what is the stage? Go ahead and say stage 3A1. Now what is stage 3B? If there is a growth which is obviously seen with the, you can see with your eyes, then that becomes a macroscopic growth, but it should be less than 2 centimeters. And if it is more than 2 centimeters, it becomes stage 3C. And this also includes any superficial liver and spleen deposits. So I'll show you my liver. See, on the liver, if there's a growth on the surface, then that becomes stage 3C. But if the growth is in the depth of the liver, deep parenchyma of the liver or the spleen, any size of growth, that deep parenchymal growth becomes stage 4B, the worst stage possible. So superficial liver growth and deep parenchymal growth, these are also MCQs. And remember, inguinal lymph nodes involved is also stage 4B. But yes, deliberately I missed out that one stage which has been newly added, that is stage 4A, and that is malignant pleural effusion. If the woman has pleural effusion and you tap it and the tap shows you malignant cells in the cytology, that is stage 4A. Okay, so that is the staging of CA ovary. Alright, now what all have we done? We have done the surgery, and that is the staging laparotomy optimal debulking. After that, what do? Any cancer which is beyond stage 1C and beyond, it is basically an indication, go ahead and give 6 to 8 cycles of chemotherapy. And the chemotherapy, especially with the high risk variety means there is a high grade tumor, the surface has a growth, it's a cystic solid tumor, and these kind of tumors, it is better you give some chemotherapy. And mostly the chemotherapy is platinum based chemotherapy. So surface epithelial tumors, you have the PET regime, that is the cisplatin along with paclitaxel, and with germ cell tumors you have vincristine, bleomycin and paclitaxel. like that. We have many regimes, but mostly I've seen they've not asked you the regimes. You must know at least that platinum-based chemotherapy is used for these ovarian tumors. Now, what is the management when the tumor is very obviously stage 3 when before you operate? So we say, if you do the surgery and you see it is stage 1C and beyond, give chemotherapy. But when you see the tumor is obviously an advanced tumor, then you can also give neoadjuvant chemotherapy and then do surgery if possible. Now, what is the meaning of this statement? That many patients who have ovarian tumors, they are initially so extended that it is very difficult for you to do an initial surgical management. So give them neoadjuvant, that is before the surgery, you give chemotherapy, that is neoadjuvant. And this chemotherapy which I told you before, that is known as just adjuvant chemotherapy. Okay, so this came in your NEET exam recently, that what do you mean by neoadjuvant? Any chemotherapy which is given before the surgery. All right, so that is the chemotherapy management in ovarian tumors. Now, what is the role of radiotherapy? Radiotherapy in ovarian tumors, please understand, it has no primary function in the management of ovarian tumors. As a primary treatment of ovarian cancer, radiotherapy is useless. So it is not used, okay? I can say it is as good as useless, okay, in ovarian cancer management. But the MCQ will deliberately be given to you about radiotherapy in ovarian cancer, because there is one ovarian cancer which will respond, and that is the dysgerminoma. So only radiosensitive ovarian tumor, that MCQ has come, and that is dysgerminoma. We'll be discussing the individual tumors, and we'll come to this part again, that what are the individual peculiarities of the ovarian tumors which keep coming in your exams. All right. So let's see the individual ovarian tumors. So when we talk about the ovarian tumors, the most common ovarian tumors are the epithelial ovarian tumors. I also told you that we know the etiology of only the epithelial ovarian tumors. Now, in the epithelial ovarian tumors, these tumors are mostly bilateral and in older women. They are bilateral and in older women, and the most common epithelial ovarian tumor, this one, is the serous cystadenoma. So once again, what is the most common ovarian tumor? Epithelial ovarian tumor. Which is the most common epithelial ovarian tumor? That is the serous cystadenoma. So which is the most common ovarian tumor? Serous cystadenoma is the most common ovarian tumor. All right. Now, it is more than 50% is bilateral, and if it is malignant, then we say it is serous cystadenocarcinoma. It is more than 50% cases, it is malignant also. So it is bilateral in more than 50% of cases. It's a unilocular tumor. The tumor has one loculi like this. Like mucinous tumors, these are multilocular. That means there are many loculi like this. So mucinous tumors, the next one is multiloculated. So serous cystadenoma is unilocular, it is large in size, and it has these psammoma bodies, concentric rings of lamellar calcification. Okay, these psammoma bodies are seen in meningiomas and papillary cancer of the thyroid and mesotheliomas of the lung. So many places you guys know better than me, I'm sure. So these psammoma bodies can be seen in these serous cystadenomas. Now, what are mucinous tumors? These are the huge tumors which we keep discussing. I told you I have removed a 23 kg ovarian tumor. That was a mucinous ovarian tumor. They get to be very enormous and they'll fill the whole abdomen, and these are multiloculated. Now, what is pseudomyxoma peritonei? Sometimes this mucin containing cyst, this cyst will rupture and all of that mucin will collect into the abdomen, causing a mucinous ascites. So there is no myxoma in the abdomen. It is just that the mucin from the ovary has come into the abdomen. So that is why it is known as a pseudomyxoma peritonei. Now, when there is a pseudomyxoma peritonei, the woman will be having a lot of proteinaceous material lost in the abdomen. So there is a proteinaceous ascites, and that causes severe hyperproteinemia of this patient. All right. Now, another question which was asked in your exam was that what is the most common cause in ovarian tumors to cause a pseudomyxoma peritonei. In ovarian tumors, it is mucinous cystadenoma. And overall, what is the most common cause? Overall, most common cause of pseudomyxoma peritonei is the appendicular cancer. Okay, fine. Now, Brenner tumor, we are still with, we are discussing epithelial ovarian tumors, the heading in blue here. We are discussing the epithelial ovarian tumors, and we are talking about the serous cystadenoma, then the mucinous tumor, and there's a Brenner tumor that is also an epithelial ovarian tumor. Now, this is made up of transitional cells, like the bladder epithelium is transition, that type of cells are there. And the nests of these transition cells are known as Walther inclusion bodies. These Brenner tumors, they will increase production of estrogens. So, because of the estrogen productions in the Brenner tumors, these patients may also have a postmenopausal bleeding. It's a rubbery tumor with puffed wheat-like cells, and it is mostly benign. Now, most common cause of a pseudo-Meek syndrome is the Brenner tumor. Now, let's not get confused. Meek syndrome, all of you know, that is the holy grail of MCQs. Always Meek syndrome, you should know. All kind of exams, they'll ask you fibroma of the ovary, ascites, and pleural effusion. So that is Meek syndrome. Now, what is pseudo-Meek syndrome? Any other ovarian tumor with ascites and pleural effusion is a pseudo-Meek syndrome. So, pseudo-Meek syndrome, most common cause is the Brenner. Okay, pseudo-Meek can be dermoid, can be granulosa cell tumor. Any other ovarian tumor with ascites and pleural effusion is pseudo-Meek. Most common cause is pseudo-Meek. PG entrance students, please note. That is your MCQ. All right. Then endometrioid tumors. These are the endometriosis. All these endometriosis cysts, they all constitute the endometrioid tumors, and these are 6 to 8% of the epithelial tumors. And these endometrioid neoplasias include benign demonstration of endometriosis, and it is not most commonly malignant. I mean, it is mostly a benign lesion, so not a common malignancy. Then we discuss about the epithelial tumors. These epithelial tumors, like I told you, serous cystadenoma, and if it is malignant, like in more than 50% of cases, it is known as serous cystadenocarcinoma. But there is a variety which is in between these two, that is between benign and between malignant. All these epithelial tumors, all these 4 which I told you, all these 4 can be benign or malignant, but in between that there is a stage which is known as the borderline ovarian tumors, also known as the low malignant potential. Low malignant potential tumors, LMP tumors, low malignant potential tumors. Also, we should know that only surgery alone is adequate management of this. So, when we talk about these borderline malignancies, these are better than the full-blown malignancies. And also remember, in these borderline malignancies, there are some features which are asked in this PG entrance exam especially. And what are those features? The features are that there is hyperplasia, there is some mitotic figures, but there is no invasion of these malignancies into the stroma. So let me try and make the epithelium something like this of the ovary. And epithelium has these malignant cells. I mean, these mitotic figures, you know, these abnormal mitotic figures, which will make you think that there is a abnormal kind of a surface growth, which is looking locally malignant. You get that feature. So you'll see epithelial hyperplasia, you'll see mild nuclear atypia and increased mitotic activity. You will also see detached cell clusters. Suppose this is the stroma of the ovary. In this, you will see some detached cell clusters. Like that, you may see some clusters of detached atypical cells like that. But what you will not see, you will not see this destructive invasion from the surface into the ovarian stroma. See, from the epithelium, mitotic figures invading into the stroma. This you will not see. So, absence of destructive stromal invasion. So, borderline ovarian tumors. What are the characteristics? 1, 2, 3, 4. And in these characteristics, remember, we don't see destructive invasion. So, this is that standalone thing. Locally, if you look at these cells, they'll look like malignant, but you'll not see destructive invasion. So that's why these borderline ovarian tumors, if you just do the surgeries, the patient will be fine. Now, the next variety of tumors are the germ cell tumors. Germ cell tumors, if you see, the tumors are in younger women and the tumors are unilateral. Like I said, epithelial tumors, they are bilateral and they are in older women. Here it is unilateral in younger women, and they're 20% of all the ovarian neoplasms. They are not the commonest. Commonest are the epithelial ovarian tumors. Now, out of the germ cell tumors, which is the most common tumor, the teratoma is the most common tumor. Now, what is happening in a teratoma? Only 10% are malignant, 90% are benign. So, 90% of these are benign. Those benign teratomas are known as dermoid or benign cystic teratomas. So, now let us revise. What is the most common germ cell tumor? Teratoma. Now, what type of teratoma is more common? 90% of these are dermoids. So, what is the most common germ cell tumor? Dermoid is the most common germ cell tumor, which is also known as benign cystic teratoma. So, please watch what I am doing. I am telling you the MCQs. What is the most common ovarian tumor? Epithelial. And the most common epithelial tumor is serous cystadenoma. So, what is the most common ovarian tumor? Serous cystadenoma. Now, what is the most common germ cell tumor? Well, teratomas are common, and out of that, benign teratomas 90% are common, which is dermoid. So, most common germ cell tumor is the dermoid. Alright, that was quick revision. Now, these have the derivatives of all the germ layers: endoderm, mesoderm and ectoderm. So, that's why these dermoid tumors in your path labs, you must have seen a cut section of the ovary having a tooth and hair in it. So, there will be hair, teeth, and there will be endocrine tissues, there will be cartilage, there will be sebaceous secretions. So, all of that will be there. And they also have a protuberance through which the hair will grow, which is known as the Rokitansky protuberance, on which the hair will grow. And on the X-ray, it look like a radio opaque area that is known as the node of the dermoid. Okay, this Rokitansky protuberance. Now, 10 to 15% can be bilateral, these dermoids. Remember, mostly these germ cell tumors are unilateral. So, exception is dermoid, which can be bilateral in 10 to 15% of cases, and most common ovarian tumor of pregnancy and most common tumor which can undergo torsion is this dermoid. Alright, so let's move on and see the dysgerminoma. Now we are in germ cell tumors, and in germ cell tumors we discussed the teratoma first. Now we're talking about the dysgerminoma. This is again a germ cell tumor, but remember, it is the most common germ cell malignancy. What is the most common germ cell tumor? Dermoid. What is the most common germ cell malignancy? Dysgerminoma. Alright, be very careful with these MCQs. Don't say that the most common germ cell malignancy is a teratoma, then you really got it mixed up. So, most common germ cell malignancy is a dysgerminoma. It is bilateral in 10 to 15% of cases, frequently associated with hypercalcemia and also associated with dysgenic gonads. Remember, like cases of Turner syndrome, which we've discussed in the chapter of intersex in the app. Please take your time and read the chapter of disorders of sexual development properly, the chapter on intersex, very, very important chapter. So, Turner syndrome is the most common form of gonadal dysgenesis, and those dysgenic gonads, whichever type of gonadal dysgenesis there, may be associated with a dysgerminoma. And the cells are like seminoma. What are the seminoma cells? They are like dysgerminoma. What are the dysgerminoma cells? They are like seminoma. It frequently is asked in these two specialties. So, what are these cells? These are large polygonal cells with a clear cytoplasm and a dark nucleoli and a back-to-back arrangement of these cells. Okay. Now, they increase the LDH, plastinate alkaline phosphatase, and even HCG is increased in some of these dermoids, but it does not increase the alpha-fetoprotein. So, please remember, alpha-fetoprotein does not increase in the dysgerminoma. Alright. Now, continuing with the germ cell tumors, yolk sac tumors also is a germ cell tumor. It is known as the endodermal sinus tumor. It is the endodermal sinus inside the pathology slide is what is known as the Schiller-Duvall body, the inclusion body, and this has a very peculiar predilection for younger women, and they mostly have a bad prognosis. But please remember, this one increases alpha-fetoprotein. Dysgerminoma does not increase. The next one, embryonal tumors, also increase the alpha-fetoprotein. But this one has a specific marker known as the alpha-1 antitrypsin. And the embryonal tumors, which is seen in younger women again and has got a poor prognosis, this one specifically increases the HCG. Alright. Then, What are the sex cord tumors? Another heading. We're talking about ovarian tumors. We discussed epithelial tumors so far, and we discussed about the germ cell tumors. Now, next are the sex cord tumors. The sex cords, all right? The cords which give the sexual expression in a human, like Sertoli Leydig cells in a man and granulosa cell and theca cells in a woman. These are the sex cords. So, sex cords ovarian tumors, and the common sex cord ovarian tumor is the granulosa cell tumor, and granulosa cells, makes estrogen. So, granulosa cell tumors will make more estrogen. So, that high estrogen can cause menorrhagia and precocious puberty. In older women, it can cause hyperplasia and CA endometrium. But yes, this has the Karl-Exner bodies, that there are rosettes of cells, and rosette, the rose-shaped arrangement of these granulosa cells with a central eosinophilic material. So that's like a rosette, okay? From the top, if you see, it looks like a rose. So, and the tumor marker, please, granulosa cell tumors increase the estrogen, but that is not the tumor marker. The tumor marker for granulosa cell tumor is inhibin, okay? Then, what is Sertoli Leydig tumor? That is an androgen-producing ovarian tumor. If there is the Sertoli Leydig tumor seen in ovary, obviously you can understand that Sertoli Leydig cell tumors will make a lot of androgens. So, the girl will have rapid onset of hirsutism, or a young girl or a middle-aged woman will have rapid onset of hirsutism, and androgens, cause atrophy of the endometrium. So, the patient will present to you with oligomenorrhea and amenorrhea. All right. So, coming out of the classifications, there are many other types of tumors. I am discussing the common ones which come in exams, obviously. And coming out of these, the sex cord and the germ cell and the epithelial, this Krukenberg tumor, it comes as a separate entity. It is a secondary to the ovary. Any malignancy in the body, if it comes to the ovary and the ovary becomes enlarged, we say it's a Krukenberg tumor. And mostly this secondary is coming from a primary in the stomach. So, see a stomach sending metastasis to the ovary. These are bilateral ovarian tumors. They are 90% bilateral. They are large, firm tumors, and they have signet ring cells. If you cut the ovaries, look it under the microscope, you will see signet ring cells, the same which you see in CA stomach. So, this question comes in your MCI exams and in PG entrance, that what is the most common primary from which the metastasis comes to the ovary, and that is the CA stomach, but it can also come from CA breast. Now, what are the non-neoplastic ovarian cysts? Hot shot MCQs for the PG entrance exams, that a woman may be having a normal function of her ovaries. She is an absolutely normal woman, but her ovaries become cystic. Now, when the ovaries become cystic, without any new growth, that's why I'm telling you it's a non-neoplastic. That means there's no new growth. Dekho, tumors can be benign, they can be malignant. All of us have seen many examples. But sometimes a woman is simply making a follicle like she makes every month. And you know about follicular monitoring, isn't it? So you're doing the ultrasound, you're seeing a follicle growing bigger and bigger. It becomes 16, 20, 22, and then it ruptures. So that is what is follicular monitoring. But sometimes, let's say the follicle doesn't rupture. It goes to 3 centimeters and 30 millimeters, that is, and it doesn't rupture. So if it doesn't rupture, then beyond 3 centimeters, we call it a cyst. So is that a cancer? No, it is just a follicular cyst. So don't get very upset if you see a clear looking cyst and it's around 3 to 4 centimeter size and not increasing beyond that size. Don't go ahead and jump to a surgery. You don't go ahead and post for a surgery and remove the ovary of this poor woman. Follicular cyst, corpus luteal cyst, hemorrhagic cyst, and theca lutein cyst. These are all non-neoplastic. The woman is all right. She's functioning normally. She's got no new growth. So that's why all these, don't do any surgery. These are all self-limiting, okay? They will get settled by themselves. And very important, these theca lutein cysts are seen in conditions where there are high HCGs. It's very clear when there are 2 babies, there will be 2 placentas, then there will be high HCG. So in twins, and also they'll be seen in molar pregnancies. Classically in molar pregnancy, we relate the prognosis of molar pregnancy with the size of theca lutein cyst. If the theca lutein cyst is more than 6 centimeters, we say that this molar pregnancy has a high chance of becoming a choriocarcinoma. So don't take this theca lutein cyst very lightly in your exams, I'm saying. It's a very important exam question, this theca lutein cyst. Of course, in the woman, this is not a malignancy. This is just a non-neoplastic ovarian cyst. Okay, that's why I'm not calling it a tumor. It is called a non-neoplastic ovarian cyst. It is not a tumor. All right. So once you understand what is the basic management of this non-neoplastic ovarian cyst, just leave them alone. treat the cause like in theca lutein cyst and they'll become all right. Now, what about the ovarian cysts in pregnancy? Ovarian cysts in pregnancy, if they are small and asymptomatic, leave them alone. Most women will have no problems with this ovarian cyst. But now, if they are large and still asymptomatic, let's say the uterus has a ovary which is, let's say, 3 into 2.5 into 3 centimeters in size. But on this size, she has ovary which is 10 centimeters. Now, this ovarian cyst, suppose it's a dermoid cyst, it can undergo a torsion at the pedicle. And with the torsion, there can be rupture of the ovary and there can be bleeding and there can be a serious morbidity in the woman's condition. So, we say that even if it is asymptomatic, see it is large, large means more than 8 centimeter in size, 8 and more. Ovarian tumors, we say large when they are 8 centimeters and more. So, this even asymptomatic, you will have to remove. Now, when do we remove it? That's a very simple favorite MCQ, that any surgery in pregnancy, it is safe to do in the second trimester. So, remove this tumor in the second trimester, even if it is asymptomatic. But yes, if it is diagnosed only in the third trimester, we are talking about asymptomatic so far. So, if it is small and asymptomatic, leave it. If it is large and asymptomatic, remove it in the second trimester. But if it is large and asymptomatic, but found only in the third trimester, woman comes to you only in the third trimester. So, now you don't operate. Wait for the woman to deliver, and in the week following the delivery, you can do the removal of 1 or 2 weeks after the delivery. Generally, they say as early as possible after the delivery. Why can't we wait till the end of the puerperium? Because there's a uterus, a large uterus, which is getting involuted, and as it is going to become smaller, it's going to pull the ovary along with it. So, ovarian pedicle, when it is pulled over the abdominal bowel and the abdominal contours, so it may undergo a torsion. So, as the uterus is going down in size, it may cause a torsion of this ovary, which is getting pulled with this involuting uterus. So, it's better you remove this within the first week of surgery. And after the delivery has happened, you don't have to do a big laparotomy. You can remove it by a laparoscopy also. So, that's why we say, if it is asymptomatic, diagnosed in the third trimester, this was a PG entrance question, remove within 1 week of the delivery. But yes, if you end up doing a cesarean for some reason, don't do a cesarean just because there's ovarian cyst. No, a lot of women deliver normally with an ovarian cyst. So, suppose the woman has a cesarean, let's say she's a transverse lie in labor, and then you have to do cesarean primarily obstetric reason. So, while you're doing the cesarean, it makes good sense to remove the ovary also, ovarian tumor also at that time. Okay, so if it is diagnosed in the third trimester, remove in the first week afterwards. But if there's a cesarean going for any reason, remove along with that. All right. Now, after discussing these 3 cancers, say cervix, say endometrium, and say ovary, now let us put all these 3 stagings together and compare them. If you want, you can take a picture of this, because this is something which is going to be very frequently asked in exams, these 3 cancers. Now, they don't ask you the stagings per se, obviously, but they'll ask you 3 organs which are commonly involved. In all these 3 cancers, and also in say vulva, what they generally ask you: involvement of the bladder, involvement of the lymph nodes, and involvement of the vagina. These 3, in all these 3 cancers, you should know. I mean, they can ask you what is vaginal involvement in CA cervix. So, upper vagina and lower vagina, like I told you. Okay, upper vagina is 2A, lower 1/3 vagina is 3A. Like in endometrial cancer, what is vaginal involvement? Then I say stage 3B. So, like that, this vaginal involvement, you must remember in all these 3 cancers. Then, what is the inguinal lymph node involvement? In CA ovary, okay, inguinal lymph node involvement in stage 4B. In CA endometrium, inguinal lymph node involvement is again stage 4B. But in CA cervix, look, inguinal lymph node is not involved. I've already told you, it's an anatomy question and a gynae question, that which of the following group of lymph nodes is not draining the cervix? That is the inguinal group of lymph nodes. Now, other thing they ask you, that if CA endometrium spreads to the cervix, what is the stage? Then that is stage 2. CA endometrium going to the cervix is stage 2. But what happens when CA cervix goes to the endometrium or to the uterus? See, that is not mentioned also here. Please be very careful that when CA cervix spreads to the uterus, it is considered as a natural extension of disease, and it does not change the staging. So that's why in CS cervix, they'll always tell you any spread to the uterus is disregarded in the staging. Okay. So CA endometrium going to the cervix is stage 2. CA cervix going to the uterus does not change the staging. Based on that, they've asked you questions also in your exams. All right. So the other one which has come in exams is the bladder involvement. Now, bladder involvement in CA cervix is stage 4A, bladder and bowel, and CA endometrium also it is stage 4A. And by habit, if I ask you what is the bladder and bowel involvement in CA ovary, so bladder involvement you tend to again say 4A. So I've already warned you in the chapter of CA ovary that bladder involvement comes in the stage 2B, other pelvic organs. Now, this is that stage which PG entrance questions have been asked many times. Pelvic lymph node involvement, like I told you, bladder involvement and rectum involvement, all of that will come in stage 2B. All right. So please be careful about these stagings. On the uterus, we discussed that when there is follicular stimulating hormone, it acts on the ovary to make a follicle, and the follicle converts the androgens to estrogens by aromatization, and this follicle makes estrogen, and that acts on the uterus to cause the proliferation. Then, when we discussed LH, it acts on the same follicle and it ruptures the follicle to release the oocyte, and then it becomes a corpus luteum, which makes progesterone, and that progesterone acts on this uterus to make this endometrium secretory. Basics once more. Now, in this chain of events, let me just do one interference. Let me do a game where I am going to give her tablets of estrogens from outside. Now, when I give tablets of estrogen from outside, please remember the basics which I have taught you, that what is the purpose of FSH in the body? The purpose of the FSH is to act on the ovary and make estrogens. So, when FSH is acted on the ovary, estrogen is made. Now, if I give this woman tablets of estrogen from outside, now this estrogen is going to give a feedback to the brain and tell the brain that there is enough estrogen, so the FSH is going to reduce. So when the FSH stops, there will be no recruitment of a follicle and there will be no production of estrogen from this follicle. Just to complicate things for this patient and to you students, let us give this patient some tablets of progesterones also. So when I give progesterone tablets, what is going to happen in the body? Now, again, another principle. What is the purpose of LH? LH acts on the ovary to rupture the follicle, release the oocyte and make a corpus luteum. Corpus luteum makes progesterone. So if I give progesterone from outside, so when you give this progesterone tablets, you know that progesterone will give a feedback to the brain and tell the brain there is enough progesterone. So purpose of LH was what? To make progesterone. So brain now thinks there is enough progesterone. It stops the release of LH from the brain. And if there was a follicle ready in the body to rupture, that follicle will not get the LH. So there will not be any rupture of follicle, no progesterone production, and there will be no secretion on the endometrium now. So what is happening when I give estrogen and progesterone to a patient? She is going to become anovulatory. And if she is anovulatory and she has intercourse, she will not conceive. So she achieves contraception. Yes. This is the topic which we are discussing now. Yes, we are talking about combined oral contraceptive pills. And a very basic principle of that is, so when we give combined oral contraceptive pills, as simple as that, estrogen inhibits FSH, progesterone inhibits LH, no FSH, no LH, no follicular growth, no follicular rupture, and there is no ovulation. So we achieve contraception. Now that is the main benefit of giving combined oral contraceptive pills. Now when you give combined oral contraceptive pills, the cycle is anovulatory, so the periods are painless. So dysmenorrhea is also taken care of because anovulatory cycles are painless. Then what will happen to the menstruation? Will this lady have menstruation? Yes or no? Now, be very careful. You've given estrogen, so the FSH is not there. There's no follicle, no estrogen production. When you give progesterone, there's no LH, there's no corpus luteum, there's no progesterone. There's no estrogen, there's no progesterone. How will this woman have periods? So when a woman is on combined oral contraceptive pills, will she have periods or not? Now be very careful. When you give estrogen progesterone tablets from outside, you stop the pituitary from working. The pituitary is sleeping. Okay, FS and LH has stopped. So the ovary is also sleeping. Follicle and corpus luteum is not made. So
estrogen and progesterone from the ovary is not made. But what are you giving from outside? You're giving estrogen and progesterone from outside. This estrogen will now go and cause proliferation, and this progesterone will go and cause the secretion. And when you stop this tablet after 21 days, that's the usual time when we give combined pills. When you stop this tablet after 21 days, this patient will have periods. So yes, she will have menstruation, but that menstruation will be because of the pill which you're giving. So that's why we call it a artificial period. Yes, of course, I call it an artificial period. That's not mentioned in the books, but for you to understand, we call it an artificial period. The period is not her own estrogen and progesterone. She's going to get periods because of the pill which you're giving. Please remember this line. It's an artificial period because of the pills which we are giving. Estrogen causes proliferation, the progesterone causes secretion, and because of my pill which I'm giving, she's having menstruation. And how long I give this pill? I give this for 21 days. And when I stop, she gets periods. Wait a minute. 21, stop, periods. 21, stop, periods. 21, stop, periods. Sounds very regular, right? Yes. Two things now. She's going to have a period because of my pill, and now she's going to have regular cycles because of my pill. That is what you have to understand. So dysmenorrhea is less, and she's going to get a pill period, or like I said, an artificial period. Now, when this is an artificial period, this is going to come once we stop the tablet. So that is like 21 days you give the tablet. She's going to get a withdrawal of the progesterone. She's going to start bleeding around 27, 28 day. So she gets a very regular cycle. So that is another benefit of the combined oral contraceptive pills. So painless cycles, regular cycles, and she achieves contraception. All right. So yes, now we know that she's not making estrogen and progesterone from the body. The estrogen and progesterone from the pill is giving her the menstruation. So now, what are the tablets which we are giving to this woman? We're giving tablets of ethinyl estradiol, which is generally 0.03 milligrams, which is 30 micrograms. This is the usual dose which we give, but we can give something like 0.02 milligrams, 20 micrograms, or we can give 0.01 milligram, which is 10 micrograms. So as low as 10 micrograms also we can give. So what did I say? As low as? Yes. When we're giving 30, 20 or 10 microgram tablets, is it a high dose given to the patient? No. We are giving low dose pills. These are all low dose pills. Please, once more, when I'm giving this estrogen progesterone tablets from outside, they have stopped the ovary from working. So when the ovary is not working, there is no estrogen progesterone from the body of the patient. The only estrogen and progesterone in this patient is because of my pill. My pill is the estrogen progesterone in this body. So when I'm giving her the pill, I'm giving a low dose pill. So the net amount of estrogen in this patient, is it high or low? Please be careful. When I give combined oral contraceptive pills, the net amount of estrogen in the body is low because I'm giving low dose pills, and that is the only estrogen production or the maximum estrogen production from the body is in the ovary, which is not happening. So the maximum estrogen in the body is now due to the pill which I'm giving. So the net amount of estrogen in this patient which we are giving, it is low. All right. Remember this. Combined oral contraceptive pill is the low estrogenic state. All right. Now, once we understood that, what is the other tablet which you give? Yes, we know. The other thing we give is tablet levonorgestrel, and that is generally 0.15 milligrams. All right. That is Himalayan preparation which we know. So what I want to stress now is that when the body has low amount of estrogen, then endometrial proliferation will be more or less. Very simple. Proliferation of the endometrium is less. So when proliferation is less, shedding also will be less. That means bleeding also will be less. Anemia in patients will be less. So yes, there is less proliferation, less bleeding, and there is less anemia in women who are on long-term combined pills. Less proliferation also means lesser hyperplasia of the endometrium and lesser CA endometrium. This also means that there is lesser fibroids and there are lesser endometriosis. It also means that the patient will have lesser ovarian cancer because she's going to ovulate less, and less ovulation means lesser injuries on the ovary and lesser ovarian cancer. And she'll also have lesser ovarian cysts because there's no proliferation from the pituitary. There's no FSH and LH, so there's no follicular growth. So some follicles become big and make cysts in the ovary. So she'll have lesser cysts, and there will be lesser colonic cancer. Now, this colonic cancer is lesser because combined pills are known to reduce the net amount of bile acids which are present in the colon, and also that these pills are known to reduce the growth of colonic cancer cells when we've seen in vitro, also when we've seen in studies. Now, this combined pill is also known to reduce benign breast diseases. We'll discuss about CA breast a little while later. And it also reduces pelvic inflammatory disease because the congestion in the uterus is lesser. So probably that's the reason why there is lesser amount of infections. Now, these are the benefits which we see, and these are significant benefits which generally in your PSM book also they're given the whole list of benefits. Now, I think you can derive these benefits rather than just marking them up. Then, what are the things which can increase when you give combined oral contraceptive pills? So the last thing which I taught you was there is lesser PID, but there is increase in chlamydial PID. Chlamydia is increased. Now, chlamydial PID is classically known as symptomless or indolent PID. Symptomless or indolent PID. There is increase in cancer cervix. Now, hold your guns. Don't just think that, okay, it's going to increase CA cervix, then ban this drug. Please, this increases CA cervix of the adenocarcinoma type. Okay, and these are very rare side effects in the first place. And that too, extremely few cases have been seen of CA cervix, that too of the adenocarcinoma type. See, when we spoke about CA cervix in our discussion, I've told you that the most common genital cancer of women in India is CA cervix, and that is the squamous cell carcinoma. This adenocarcinoma increases, and that too very rarely. Now, there is also increase in gallstones, but these are the smooth type of gallstones, okay? And that's why not gallbladder cancer. Yes, there is no increase in gallbladder cancer. Don't relate that there is more gallstones, so there will be more gallbladder cancer. Gallstones of the pigment type and the mixed type, they may be related with gallbladder cancer. But OCPs do not cause gallbladder cancer. So they can cause gallstones, but not gallbladder cancer. They can increase hepatic adenomas, but not hepatocellular cancer. That also does not increase with combined pills. All right. So these are the few things which may increase with combined pills, but not very regularly. Now, what is the relation of combined pills with CA breast? I know that there are some studies which say that there might be some increased incidence of CA breast, but please remember, CA breast total incidence and the direct relation with combined pills has not been established. Even the latest Williams obstetrics says that there is no definite information which tells us that there is more CA breast. So yes, what I can tell you right now, that combined pills effect of CA breast. So CA breast incidence with combined pills intake is unchanged. Okay. I'm definitely not saying that combined pills reduces the incidence of CA breast, but yes, it does not even increase it. So we will conclude saying that CA breast does not increase definitely, but it also does not reduce. Now, what are the contraindications of giving combined pills? We can't give in a pregnant woman. or we can't also give when a woman is breastfeeding her child, because high amount of estrogens will cause the failure of lactation. And then liver disorders, why we can't give, like cirrhosis and hepatitis. Why we can't give? Because estrogens are metabolized in the liver. So if the liver is not functioning properly, the estrogens won't be broken down and there'll be continuously high amount of estrogen in the bodies and cause rather side effects. Okay. So can't give when the liver is not working well. These combined pills have a direct incidence of increasing, not very regularly, of course, very rarely increasing the incidence of deep venous thrombosis, and can also cause thromboembolic disease, but that is rare. Please remember, the estrogen component is known to cause the arterial thrombosis and the progesterone component is known to cause the venous thrombosis. All right. Then hypertension, if a person has, then don't give a combined pills if the blood pressure is more than 160/100, and don't give combined pills to smokers, especially after 35 years. Smokers can take combined pills till 35 years. After 35 years, especially after 35 years, don't give to smokers. Also, there's a well understood kind of phenomena that don't give combined pills to people who are beyond 40 years. So we generally give combined pills only till 40 years. But if a person is a smoker, then we stop the combined pills around 35 years itself. Active breast cancer is a contraindication. Uncontrolled diabetes mellitus, especially with neuropathy and nephropathy, we won't give. And coronary artery disease, very important. A known case of coronary artery disease, don't give any estrogens, even if it is low dose estrogens. And migraine is a contraindication, especially the women who are having migraine with an aura. All right. Now, there is no contraindication when we're using for conditions like STD, HIV and PID. These are no contraindications. People with these can easily take oral contraceptives as protection against pregnancy. Now, what are the types of pills which we have seen? The pills are classified according to the progesterones used. So these are based on the types of progesterone. So the first generation, second generation is based on these progesterones. So first generation having the norethindrone, linezolid and norethistron. Second generation having norgestrel, etonorgestrel. Third generation with desogestrel, gestodine, norgestodine. And the fourth generation, the one which is very commonly and very favorably used these days, are the ones having drospirenone. So drospirenone is a progesterone, but it also has anti-mineralocorticoid activity and it also has anti-androgenic properties. So these drugs, like for example, there's a trade name Yasmin. This is a very famous drug as a combined pill which is given to young girls who are having PCOS, so they get regular cycles because of this combination, which is estrogen and drospirenone, and they also get anti-androgen action, so good effect on acne and hirsutism. That's why these the fourth generation pills are in vogue these days. Then, what are the pills which we see in our country? The Mala N is one which is very easily available in the public sector. Government gives this free to the patients in government hospitals, and this is having ethinyl estradiol of 30 micrograms and levonorgestrel of 0.15 milligrams, and it's a pack of 30 pills. And all of us know that the first 21 days is the active principle, and 21 to the next 8-9 days it is the iron tablets which are given. So the patient does not have to stop in 21 days. There are arrows in the marked in the pills, so that the patient knows that first take the black pills, which are the ones having the drugs, and then take the red pills, which are having the iron. And when she's taking the iron tablets, she gets a periods, and the next pack is started the moment these previous pills stop. So it's a very easy method by which the government is giving even to people who don't understand how to take the pills. Just keep taking this one pill every day. So that's a very good method of giving pills in our country. Now, how and when you start these combined pills? What is the protocol of starting these tablets? So when a woman is having regular cycles, in the first 5 days of the periods, when she starts bleeding, the day of bleeding to the 5 days, these 5 days she can start the tablet anytime. My ideal method, what I do for my patients is that any girl who's requiring combined pill, I start on the second or the third day. I generally feel that they should shed off their endometrial lining properly and then restart growing with the combined pill. So that's what I feel as a gynecologist, but anytime from the day 1 to day 5, you can start. So that is what is one ideal method. Now, when a woman is breastfeeding, she's just delivered and she's breastfeeding a child, do not give combined pills. It's a contraindication. But she wants to start combined pills eventually. So we can wait for 6 months of exclusive breastfeeding and then tell her to start the combined pill. Now, those patients who have just not delivered, but they choose not to breastfeed the child for whatever reason, when can we start the combined pill? Even these patients don't start the combined pill the next day of delivery. Don't do that. She is delivered tonight. Now, let the endometrium lining, the decidua as we call, let it shed off, let the plastinal site heal. She'll have lochia, rubra, serosa, alba, like that she'll be having. So let that lochia finish. It'll take around 15-16 days. Lochia can go up to around 30-35 days also. So wait for the endometrium to totally get empty and get back to a normal size. Around 4 to 6 weeks, it becomes a normal size after delivery. We know that. And then we can start the combined pill. So after delivery and not breastfeeding, so around 4 weeks after the delivery, we can start the combined pill. And if she's aborted, suppose we've done an MTP, we can start the pill immediately or up to 7 days. Suppose you do the MTP today, tomorrow morning, you can start the pill, or you can wait up to 7 days. It is all perfect. There's no problem in doing that. Then after emergency conception, suppose she had unprotected coitus yesterday and today, suppose you give the levonorgestrel pill as emergency contraceptive pill, 1.5 milligrams, one tablet we give. That's a favorite emergency contraceptive pill. So you do the levonorgestrel treatment and the same day you can start the combined oral contraceptive pill. She does not have to wait for her next period. Yeah, so she does not have to wait for the next period to start the combined oral contraceptive pill. The same day as she takes the emergency pill, she can start the combined oral contraceptive pill regimen. All right. Now let's see something about emergency conception. Now, when we say if a woman wants contraception, like she's having, she's just got married and she does not want to have any children, then we give her contraception. All right. Like we can give her a combined oral contraceptive pill, or we can give her an IUCD. And there's a woman who wants, another type of woman who has 2 children, and she says that, sir, I don't want to get any more children and somehow I'm pregnant. So can you take care of this situation? So that kind of woman, I do a medical termination of pregnancy. So these are the 2 events which we generally handle in our outpatient departments. But now there's another third type of event which comes in our OPD, and that is a woman had intercourse, but she did not take any contraception. Like she had intercourse yesterday and today she comes and says, sir, I don't want to get pregnant. Please save me. Now she had intercourse yesterday and she had no contraception. And today when she's come to me, after having intercourse yesterday, today when she's come to me, she's obviously not pregnant, because when does the pregnancy happen earliest? Even if it was the 14th day of the menstrual cycle yesterday, when she had intercourse and she had no protection, and that can cause a pregnancy earliest on which day? When does the implantation takes place? The 6th day after the ovulation. So even if she had ovulated yesterday and she had intercourse without protection, earliest she is going to get pregnant is on the 6th day after that intercourse. So today, can I do an abortion for her? No, she is too early for an abortion. So yes, some women, when they have intercourse without protection, they have not taken contraception. So they are too late for a contraception. And if they've come to me, it is too early for an abortion. All right. So that woman is the ideal situation where I can give her interception of a pregnancy or emergency contraception. All right. So here itself, we have understood that she's had intercourse yesterday, and today if I want to prevent a pregnancy, I cannot give her a contraception. It's too late for that. I cannot give her a abortion. It's too early for that. All she can have is a emergency contraception. All right. So this also tells me that aborting is not a method of emergency contraception. First thing in the chapter, already you've understood that abortion of an early embryo is not a method of emergency contraception. So what is emergency contraception? Within 72 hours. Within 72 hours of unprotected intercourse. I mean, there's no such short form. I'm just holding back some lines here. Unprotected intercourse. All right. So within 72 hours of unprotected intercourse, if we do some method by which we can prevent a pregnancy, that is what is known as a emergency conception. 3 days or 72 hours. All right. Now,
What do we do when we want to give emergency contraception? The common drugs which we can use are drugs like levonorgestrel. Levonorgestrel, is a progesterone. We give 1.5 milligrams, one tablet. How does this work? Now, since this is a progesterone, and if you give it, let's say if she comes to me in the time when she's before ovulation, she had intercourse yesterday, today she comes to me, let's say it's the 12th day of the menstrual cycle. So if I give a high dose of progesterone, purpose of LH is to release progesterone. So if I give her tablets of progesterone today, high dose like 1.5 milligram, it'll go in the circulation, tell the brain that there is enough progesterone, so the LH surge won't happen. So even if she had intercourse on the 11th day, sperms will be living in the body for 3 more days. But the progesterone tablet which I'm going to give is going to give a feedback to the brain and reduce the LH. No LH surge, no ovulation. So if it is given before ovulation, then it prevents ovulation. If it is given after ovulation, then let's say she had intercourse on the 14th day of the menstrual cycle and today she comes to me. So the sperms have already gone in her body. She's already made an embryo because she's ovulated. Embryo will form in 6 to 8 hours. So when fertilization at least will happen, and that we cannot prevent now. She's come to me after the day of ovulation. What can I do today? I can prevent an implantation. So if I give high dose of progesterone like this, it makes the endometrium too much secretory than required. We call it out of phase. So it makes a out of phase endometrium. It is too secretory for an implantation to happen, more than the required. So out of phase endometrium, and it also reduces tubal motility. So if the embryo is not coming in time into the uterus, then also implantation doesn't happen. And if it takes too much time to come, it will also get degenerated. So 2 things can happen. 1, that the endometrium will be out of phase, and 2, it will reduce the tubal motility. So it prevents implantation. So given after ovulation, this reduces implantation. So that is the drug which is levonorgestrel. Now, when we talk about levonorgestrel, so this is what I have tried to explain you, that we know the LH surge will cause ovulation. So if I give a high dose of progesterone tablets, it's going to give a feedback to the brain, and the brain gets enough message that there is progesterone in the body. So there will be no LH, so there will be no ovulation. Now, what are the other drugs? Other drugs can be drugs like mifepristone. Mifepristone, is an antiprogestin. It's given in a dose of 10 to 50 milligrams, and that reduces implantation. It's one of my favorite drugs for the patients who come for emergency contraception, but it is my favorite prescription, not the drug of choice. All right. Then there's another drug which we can give, that is the USP regime. USP regime is the one using combined oral contraceptive pill, and these can be given. If it is a 50 microgram tablet, we can give 2 now, and after 12 hours, we can give another 2 tablets. If it is a 30 microgram pill, we can give 4 now, and after 12 hours, another 4 tablets we can give. Now, this, is going to reduce the ovulation, and it's also going to reduce the implantation. So that is the USP regime, not again the drug of choice. Then we also have drugs now like ulipristal acetate. Ulipristal acetate is a selective progesterone receptor modulator. It reduces implantation. Now, ulipristal acetate is given in a dose of 30 milligrams as 1 tablet, and that is sold as the name of Ella, E-L-L-A, as Ella. Now, this Ella, okay, it is called, the drug has a trade name called Ella. All right, so 1 tablet is enough, and the selective progesterone receptor modulator action means that on some places it's progestation, some places it is anti-progestation. So the
action on the endometrium is that it prevents implantation. We need progesterone for implantation, and anti-progesterone action on the uterus will prevent implantation. So ulipristal acetate is that one drug which can be used up to 5 days very effectively. 5 days. All right. Now this can be given up to 5 days. Ulipristal acetate. It is a good drug because it is equally effective for the 5 days, because implantation happens earliest on the 6th day. So if you give ulipristal acetate up to 5 days, it prevents an implantation. But the problem with this drug is that it is still not been approved by the government of India as a drug for emergency conception. So don't say that this is the drug of choice. It is not approved by the government of India so far. Another method of emergency conception is the usage of intrauterine contraceptive device. Now this, reduces implantation. And you know that even up to 5 days, if I insert this device into a woman's uterus, it will prevent an implantation. So it is equally effective till 5 days after unprotected intercourse. So what is the meaning of that? That when I give, let's say, levonorgestrel pill, or I give, let's say, mifepristone tablet, the day she comes to me, the first day when she comes to me, it is more than 95% effective, these drugs. Second day, it reduces to around 80-85%. Third day, it reduces to around 65%. So effectiveness is not the same with levonorgestrel for the full 3 days, that definition of emergency conception. It is not effective for the 3 days in the same rate. But when I give IUCD, it will prevent implantation more than 95% of cases up to 5 days, equally in these 5 days. That's why this IUCD is known as the most effective, please mark my words, most effective emergency contraceptive drug. I did not say drug of choice, please. Now there is a difference. The most effective method does not have to be the drug of choice also. Why? Now that's a confusion which is there in some guides I've seen, that IUCD has been told as the best method of emergency conception. No, it is not. It is the most effective method. Yes, emergency conception is not just for people who had unplanned sex. It is also for the girl who's got raped. All right. So when a person comes to me for emergency conception, I must prevent a pregnancy very, very easily for her without her having too much of discomfort. IUCD requires a prescription by the doctor. It requires a doctor to do the sounding of the cervix and then put in a device inside. All of that requires an expertise. Emergency contraception, now I'm going to tell you, emergency contraception by definition is over-the-counter prescription, over-the-counter drug. Emergency conception is a over-the-counter drug. It does not require any prescription. Now, that is the basic of emergency contraception. So, if a woman had intercourse and she takes a tablet all by herself, let's say like levonorgestrel, now she will be protected more than 95%. If she's not protected, what is the worst that's going to happen? At most, she's going to get pregnant. So that's why it is not a drug which requires a prescription emergency conception. So that's the principle. But now when I say intrauterine contraceptive device, this will require a prescription by a gynecologist. It will require insertion by a trained person, at least a person who is a doctor who has been putting IUCD devices. There are a lot of, medical officers who put, even they are not gynecologists, they do this. And that's a backbone of a IUCD device insertion program. So yes, at least they're doctors. So doctors are required for putting in IUCD. So this is not the best method of emergency conception because it requires a doctor. It is the most effective. That I will agree. Sometimes a woman might come to me after 3 days. That is, she comes on the 4th day or the 5th day after unprotected intercourse. She was not very comfortable talking. Then finally she decides that she wants some prevention against pregnancy. She comes to me on the 4th day after unprotected intercourse. So the only method I can give at that day is a IUCD like a copper T. All right. So it is the most effective,
but not the drug of choice. Please remember that. Okay, so what is then the drug of choice for emergency conception? So yes, this question came in INICT December 2021, I think November 2021, that what is the drug of choice of emergency conception in India? So that's why ulipristal, which has not been approved so far, so we'll have to say levonorgestrel pill, okay, LNG 1.5 milligrams is the method of choice of emergency conception. All right. Now let us see about the permanent method of sterilizations, which are tubectomy and vasectomy. So when we're doing a permanent sterilization of a woman, we call it a tubectomy. So what are the timings of doing a tubectomy? Now, the usual timing of doing a tubectomy in our country is when women deliver, and next day onwards. You know, the first 2-3 days are actually very nice because the uterus has just not delivered and it is at the level of umbilicus after delivery. So next few days, the uterus is in the abdomen. It becomes a pelvic organ in how many weeks? 2 weeks. So it becomes a pelvic organ in 2 weeks. So after delivery, up to 2 weeks is a good time. So we say puerperal sterilization up to 7 to 10 days we can do. Best time is 2 to 3 days after delivery, because in these days the uterus is a abdominal organ. Till the time the uterus is an abdominal organ, you can easily do a tubectomy. So the woman has just not delivered. This is the pelvis. Here, the normal uterus is here. But now she is a woman who is just not delivered. So uterus is at or just below the level of umbilicus. These are the fallopian tubes. You can make a small incision on the abdomen. Where you feel the uterus through the abdominal wall. You can make an incision, go inside the abdominal cavity with the same one incision. You can do the ligation of the tube on both the sides. So puerperal sterilization or postpartum sterilization, like we say, is best done in the first 2-3 days. It can be done up to 7 to 10 days. Now, why can't it be done beyond this time? Because the uterus becomes a pelvic organ. It comes in the pelvis in 2 weeks. It becomes a pelvic organ. It becomes a normal organ, a normal uterus in 4 to 6 weeks. So that's why puerperal sterilization in the first 2 to 3 days, maximum 7 to 10 days. Now, this is actually the most common sterilization even now in our country. Another method of doing sterilization is interval. Interval means after 6 weeks of delivery. If you do a sterilization, that is known as interval sterilization. It is usually by laparoscopic methods because uterus is a pelvic organ. And what is concurrent? Concurrent is along with some surgery. Like you're doing a cesarean and along with that you did a tubectomy, or you did a ectopic surgery, and on the other tube you did a tubectomy along with, or known as concurrent sterilization. All right. Now, how we enter the abdomen? We can enter the abdomen for doing the surgery by a laparotomy or by a laparoscopy. All right. Now, when we say laparotomy, it is basically a mini laparotomy which we have to do. A mini lap, because we make a small incision which is 1.5 to 2 inches only. Sometimes even as small as 1 inches, and we are able to enter the abdomen and ligate both the tubes easily. So mini lap is a very common method. In fact, the most common method of entry in India is even now is mini laparotomy. Now, laparoscopic entry and doing a sterilization is on the rise, and for the last 15-20 years, a lot of laparoscopic work is being done in our country, but it is still not as much as the mini laparotomy. Okay. Now, next, what is the site of ligation of the fallopian tube when we're doing a sterilization? So, if you see the fallopian tube and the parts of the fallopian tube, which part do you think you want to ligate? So, we always want to do a isthmic ligature, because when we do a isthmic ligature, we do this keeping in mind that who knows that this woman may want a re-anastomosis of this fallopian tube. Unfortunately, if she loses her children, or she she has a separation from her husband, and the husband gets the custody of the children. So in those conditions, she would want to have a reanastomosis of this fallopian tube. So keeping that in mind, we do a isthmic ligature, because the cut ends, if you see this one, these cut ends are uniform. So a reanastomosis, if at all required, will be much easier. A isthmo-isthmic reanastomosis is up to 80% successful. That's why we do a isthmo-isthmic reanastomosis. How we can make sure that we can do a isthmo-isthmic? We must always do a sterilization always at the isthmus. All right. Now, what are the techniques of ligation which are commonly employed? So the most common technique done in our country is the modified Pomeroy's technique, in which when we make a loop of the fallopian tube like this, then we ligate both the tubes together with a stitch, and then we cut above. So at the end of the surgery, both the cut ends are together. Now, if the cut ends are together, then there is a theoretical risk of a spontaneous reanastomosis, a spontaneous recanalization. That is a theoretical risk. It's not, I've seen only a few cases which happen. I mean, that is including all the cases which have happened in the hospitals where I worked. Maybe personally, I must have seen one case of a spontaneous reanastomosis. So I have, decided not to do the Pomeroy's too much. My favorite technique now is the Parklands. Anyway, modified Pomeroy's is still the method of choice by which most sterilizations are done in the country, and both the tubes are ligated together and cut above. Now, when we do the Parkland sterilization, this tube which is made into a loop, here we ligate them separately and then cut above. So the cut ends are separate from the day of surgery itself. So that's why this will have lesser chances of spontaneous reanastomosis. Then what is the Irving's technique? Irving's technique, we bury the tubal cut ends. It's a surgery which requires burying the cut ends. So when we cut the fallopian tube, one end of the fallopian tube is cut and buried into the uterine muscle, and the other end is buried into the mesosalpinx. So this is the mesosalpinx where you bury it. So one cut end is in the uterine muscle, one cut end is in the mesosalpinx, Irving's. Madeliner's is just crushing the fallopian tube, crushing only and no ligation. So this fallopian tube we crush with the artery forceps like this, and needless to say, you can understand that if you only crush the fallopian tube, then it can have a much higher chance of spontaneous recanalization. Now, Kroner's goes by the name of a fimbriectomy. It's a method rather, fimbriectomy. In this fimbriectomy, we just slice off the fimbria. So when you slice off the fimbria, and if you have this patient coming back to you for a reanastomosis, so there's no fimbria, and this cut end of the fallopian tube is like this now. Generally, it has a fimbria like this. Now, this cut end would be like this. So you will have to do a neofimbriostomy, and that has a success as high as only 5%. So that's why Madeliner's procedure and Kroner's fimbriectomy, both of these are mentioned only to be condemned. We generally don't do these procedures because of the problems associated. Okay, so the most common is Pomeroy's. Now, we also have laparoscopic methods of sterilization. So in techniques of sterilization, now we are discussing the laparoscopic methods, and we can do by rings, applying rings. So what rings we use? We use the Fallop rings. These are the Fallop rings, and we have instruments by which we will push this Fallop ring over the fallopian tube. So if this is the fallopian tube which we make into a loop, this fallopian tube, can you see this hole? Through this hole, we push these rings over the fallopian tube. So when we do this, this fallopian tube, this part of the segment will get ischemic, and in a day or two, it will slough off and fall off. So we have a laparocator, laparoscopic ring applicator, to apply these rings, and these rings will cause ischemia and necrosis of this end of the tube, which is beyond the ring, and that will slough off. All right. So this is the laprocator. If you see, this is the laparoscopic ring applicator. The rings are applied here on this outer cylinder. The rings are applied. So what we do, these prongs which go out, they hold the fallopian tube and pull the tube into the cylinder, and this ring is slipped over the fallopian tube. So that's the method by which we use the fallope rings. Now, what else we can do? We can do laparoscopic sterilization by using clips also. So the clips which we use are the Filshie clips, which are the plain clips which are flat, and the Hulka clips which have teeth. So my method of remembering is that Hulka U, there's a, I mean, you can remember it even otherwise, but Hulka clip has teeth, and the Filshie clip is flat, and these are used, you know, the clamp is like this. This is the clamp. All right. So the tube is here. You apply this over the tubes and do the ligation. So Hulka clips and Filshie clips are the methods of laparoscopic ligation. Beyond that, we also have methods of doing hysteroscopic sterilization. Now, hysteroscopic sterilization using the Essure coil. This came as an exam question around 3 years back, and it is mentioned in your Williams. So anything which is mentioned in your Williams can become your MCQ, especially in the NEET exam. So Essure coil is a hysteroscopic procedure by which we put a coil which is made up of a nitinol. Nitinol, it's a alloy made up of nickel and titanium. Nickel titanium alloy, and that is, can you see this? This one, it is inserted already on the left fallopian tube in this patient, and now they're in the process of inserting this into the right fallopian tube. So this nickel titanium alloy, this coil which is hysteroscopically inserted, will cause the fibrosis of the fallopian tube in 3 months. So once we apply this, 3 months later, do a hysterosalpingography, and after doing the hysterosalpingography, we will check if the tube is now totally blocked, because fibrosis takes place in 3 months. Now, if the tube is blocked, then only we can give the woman the assurance that she can have sexual intercourse without protection. So for these 3 months, she uses some alternative methods. Alternate methods meanwhile for 3 months. So what is the meaning of this procedure? That once you apply this, it is done hysteroscopically, and immediately she's not sterile for next 3 months. She will still use some alternate method of contraception, and only after 3 months she is rendered sterile. Okay. Now this is a very cumbersome method. That's the disadvantage, that it requires a hysteroscopic placement. You require fitness for surgery. Then there's a wait period of 3 months, and after 3 months also there's another procedure which has to be done under at least some IV sedation or mild GA, that is hysterosalpingography. So not many people are very happy getting this done. And now after the Essure coil, let us see what is the success of a reanastomosis. So I already told you that reanastomosis is best if it is done at the isthmic site, because we do ligation at the isthmus. So isthmo-isthmic, see, uniform cut end. So the reanastomosis is best at this site. Now what is the success? Up to 80%. That we've already discussed. So what are we discussing now? Which technique has the best reanastomosis? So reanastomosis best success is in those tubectomies which are done by laparoscopic clips. That is the best success. And worst success is when a reanastomosis is done for a tube which was ligated by cauterization. If you cauterize a tube, then the reanastomosis success is worse. All right. So best is laparoscopic clips and worst is cauterization. Now, what are the side effects of a tubectomy? Now, tubectomy side effects are the side effects of the surgery, like infection at the site of the entry and hematoma formation, peritonitis and bleeding and bowel injury, blood injury. All those lists are huge lists. We are not generally bothered about those side effects. Yes, in the exam, we are definitely bothered about those side effects. When we're doing the surgery, we are very careful about that. But in the exam, we generally ask you, what are the structures wrongly ligated while doing a tubectomy? So if you want to understand this, now let us look at the anatomy from the laparoscopic view so that we understand it better. So if you see the laparoscopic anatomy of the pelvis, can you see the right adnexa which I'm trying to show? This is the pouch of Douglas with the uterocircles, and this is the right adnexa. Now in this right adnexa, you will see that from the uterus, this is the ovarian ligament and this is the ovary here, and then these are the fallopian tubes and this is the round ligament. So these are the lateral relation of the uterus. So if you see this, now I'm tracing the round ligament here. Another side, on the left side, I'm showing you. So this is the round ligament, and this is the round ligament which is going from the uterus to the deep inguinal ring, which then travels into the inguinal canal. Now, if you see the lateral relation, that is what I want to tell you. The lateral relation, this is the round ligament, this is the fallopian tube, and this is the ovarian ligament. So when I'm trying to do the tubectomy here, the tube, the commonest thing which I can hold and ligate by mistake, whether I'm doing a laparotomy or a laparoscopy, is the round ligament. All right, round ligament I can pick up and ligate by mistake, or maybe the ovarian ligament, or maybe the small bowel if I'm really bad at my surgery. So that is those are the few things which I can ligate by mistake. But please keep in mind, the commonest thing I can ligate by mistake is the round ligament, but I can never ligate the ureter by mistake. Please note, that is what a lot of people keep answering in the exams. See, the uterus is not even seen in this whole laparoscopic video which I've shown you, because ureter is a retroperitoneal structure. It is not in the peritoneal cavity. It is a retroperitoneal structure. So even if you want to ligate the ureter, you cannot ligate it while doing a tubectomy, especially when you're going through a mini laparotomy and trying to catch the fallopian tube with a lot of difficulty in the first place. So the last thing you can ever ligate is the ureter, and the commonest thing you can probably ligate is the round ligament. Keep it in mind. All right. Now let us see about the male sterilization or the vasectomy. Now when we say vasectomy, nowadays we do the NSV, non-scalpel vasectomy. And this is a very simple procedure. Under local anesthesia, we give a block around the vas where the nerve plexus is, and that will give pain relief for the surgery. And when we give the local anesthesia, after that, we have this instrument. This is a very sharp artery. The tip of the artery is very sharp. It's used as a stabbing forceps. So we give the anesthesia and we just make a stab at the scrotum. So one stab incision, that's all it's going to be. It's not going to be more than that. So one stab incision, and through that stab incision, we catch the left vas, and the same stab incision, since the the scrotum, the dartos is very movable. So we will now go with the same stab incision into the other side, and we catch the vas of the right side. So how do we do the stab? With this sharp artery, and we hold the vas also with the sharp artery and pull it out. Once we pull it out, we stabilize the vas with this ring forceps. This is the ring forceps which is used to stabilize the vas. This frequently comes as an image-based question. Mind you, now I'm going to tell you the instrument which is used in a tubectomy for a female sterilization. In a male sterilization, we use the ring forceps. In the female sterilization, which we had just now discussed, there, if I want to handle the tube, there I'm using the Babcock's. The Babcock's forceps, okay, that has a protective cage that is different from this ring forceps. Just now I'll show you. So the Babcock forceps looks like this, and this is used for the tubectomy. I'm telling this now because I want you to know the difference between the instruments used for a tubectomy for a lady and a vasectomy for a man. So vasectomy is by the ring forceps, tubectomy is by the Babcock's. It has got this protective cage. All right. Now, when you're doing this vasectomy, this is a much more simpler procedure. It requires only local anesthesia. It is done in 5 to 7 minutes, and the patient can walk out of the surgery, and there is just a small band-aid which we apply on the scrotum, and you don't even see the incision, does not require any stitches. And versus this tubectomy. Tubectomy requires a mini laparotomy or a laparoscopy, and that can be even a threat to the patient's life. It has significant morbidity and mortality, at least as compared to a vasectomy. It's a much simpler procedure of vasectomy, but because of the taboo around the vasectomy, that it can cause loss of strength and loss of libido and inability to do any work and all those the so-called taboos in the society. That's the reason why which vasectomy is not much done in a country. So the government gives a lot of support for vasectomy. Suppose somebody gets a tubectomy done, she gets only 500 rupees. But when a man gets a vasectomy, he gets 1300 rupees. In fact, the man who gets a vasectomy, he gets 1100 rupees. The motivator who brings this man for this vasectomy, he gets 200 rupees. So government has allotted 1300 rupees for a vasectomy and 500 rupees for a tubectomy. So we try to encourage and try to tell men that this is a much safer surgery than your wife's tubectomy. But then you know very well that it is less than 1% the vasectomy as compared to the tubectomy in the country. So when a person gets a vasectomy done, what you have to keep in mind that after you do the vasectomy, I'm making a shortcut picture here. So the vas, suppose you're ligating the vas here. Please remember the part distal to the vas. This part of the vas will still have sperms. So that's why we say after a vasectomy, a man is not sterile for the time this part gets totally emptied of the sperms. So yes, post vasectomy, 3 months or 20 ejaculates. 3 months or 20 ejaculates, whichever is earlier, should pass before this man is given the go-ahead to have intercourse without any protection. So 3 months or 20 ejaculates. 3 months or 20 ejaculates later, we do a semen analysis and we confirm a azoospermia. And then only we say that this man is sterile. In fact, this semen analysis to confirm azoospermia should be actually done twice with a gap of 1 month. So yes, this also is one of the factors because of which a lot of men they don't want to take the hassle of getting so much of visits to the hospital and come and discuss with the doctor so many times and get these investigations done. So that's also one limitation for the vasectomy. But it's a very good, safe procedure, and it can be much better and much safer procedures versus a tubectomy. Now, what are the side effects? Local, any surgical site infection, hematoma formation, and spermatic cyst. Another side effect which can happen is the anti-sperm antibodies. Anti-sperm antibodies can form because the breakage of the blood testis barrier because of the surgery, and anti-sperm antibodies can make these sperms ineffective and even if they are formed. So reanastomosis success, that's why even if you do a good surgery for a reanastomosis, the success of a vasectomy reversal is not much more than 35%. Some books claim around 40% or even 50%, but most books say that it is only around 35% versus a tubectomy reversal, which is up to 80%. So these side effects can be there. But what is not a side effect? What I told you, loss of libido and loss of strength, inability to work, and mental side effects, and all of this will not happen if a vasectomy is done. It is a much safer procedure versus a tubectomy. So yes, we agree that the reanastomosis rate versus a tubectomy is much lesser in a vasectomy, but the bottom line is that it is a much safer surgery versus a tubectomy. So pap smear is 47 to 62% sensitive in picking up CS cervix, and it reduces mortality by CS cervix by 70%. But yes, what is the most cost effective? Now that is one question which came in the MSI exam. Most cost effective method of CS cervix screening is visual inspection under acetic acid. Now, this has come even in your Shaw's Gynecology, and it has been mentioned in your PARC also. So yes, if I say best method of screening for CA cervix, it is PAPS, and the cost-effective method is visual inspection under acetic acid. We'll talk about that a little bit later. Now, when we're doing the Pap smear, how do we do it? We do the Pap smear. Method of doing the Pap smear quickly, often an exam question. So it is from the transformation zone. Why from the transformation zone? Because it's the first site where CA cervix starts. Where CA starts, I'm writing. And now this is located 1.7 to 2.3 centimeters from external os, and we can use a Ayer spatula, or we can use a cyto brush, or we can use a cyto broom to take the sample. So when we're taking the sample from this cervix, if you see the cervix like this is the transmission zone here. And suppose I'm using the Ayer spatula, long head and a short head, or a cyto brush or the cyto broom. Then when I take the sample, this spatula or the cyto brush or the broom, when I put it on the cervix, I just turn it once 360 degrees. Please don't go into the cervix and rotate the Ayer spatula 3-4 times like this. Some people have a habit of doing this. So if you keep on repeatedly turning it like that, it's going to injure the cervix and it's going to bleed, and blood is going to obscure the anatomy of the cells, which you're going to smear and see under the slide. But remember, when you're taking this Pap smear, don't keep turning the Ayer spatula on the cervix many times. 360 degrees just once, because if you keep rotating it many times, you're going to injure the cervix, it's going to bleed, and the blood is going to obscure the anatomy of the cells, which you're going to see under the microscope, isn't it? So, rotate once 360 degrees, whichever instrument you're using, and smear cells on slide and fix immediately. No drying, please. Drying will obscure the anatomy again. So fix it immediately. Where do you fix it in? You fix it in 95% alcohol. All of these are MCQs, all right? Then, when you fix it in 95% alcohol, it is stored in the Coplin's jar. And that is what is having the 95% alcohol, and then you transport this to the path lab, where it is smeared on the slide and stained with the Papenculo stain. Papenculo stain contents you must read, all right? And this, when it is stained, we will do the interpretation. But before I tell you the interpretation, even better than doing this Pap smear with the Ayer spatula, cyto brush or the cyto broom, even better than this is the liquid-based cytology. Yes, best method of cytology. I know I'll be speaking out of the limitation of my subject, but I can easily say the best method of doing cytology anywhere is liquid-based cytology these days. So what is liquid-based cytology? Why it is supposed to be the best? Because when I take the smear, when I take the Pap smear and plate it on the slide, I may lose some cells. Some cells on the back of the Ayer spatula may not come on the slide. So to prevent cell loss, we don't smear it on a slide. We take the sample, and now wash it in media, and that media is poured into a test tube, and the test tube is centrifuged. Now that centrifuge will put the cells into the sediment, and that sediment has the cells which is going to be plated on the slides. So you do not lose many cells. Complete sample is available for analysis. So liquid-based cytology, why it is best? Because it prevents sample loss. That's why it is the best method of doing cytology now. So that's how we do a Pap smear. Now, what is the interpretation of the Pap smear? Now, I have taken a smear from a woman who is asymptomatic but at risk. I've got these cells which are on this slide. I'm just arbitrarily making some circular looking cells. By the way, the cells of the cervix are polygonal cells, and they have a clear cytoplasm and a nucleus, but the cytoplasm is clear. Now what happens that when we are doing a smear, in this we have taken the smear from the epithelium of the cervix. The woman was not symptomatic. In fact, this woman came for a, let's say, a headache to the medicine OPD, and the medicine consultant said that go to the gynae OPD, they're doing a free pap smear camp. And she was asymptomatic. She was just sexually active, and she was sent to me for doing a pap smear. When I did a pap smear, I looked at the cervix first, and the cervix was absolutely healthy. Then only I do a screening test. If there is a growth on the cervix, I'll do a biopsy. So if there was a normal looking cervix, I did the screening test, the pap smear. Now, what did that show me? These cells, polygonal cells with clear cytoplasm, perfect smear. Maybe some women will show that the nucleus of this cell is very, very big. Now, these are new cells on the cervix, new cells on the epithelium of the cervix. So these new cells on the epithelium of the cervix, these are not naturally, normally not seen on the cervix, and we say that in the epithelium of the cervix, there are new cells, neoplasia in the cervical epithelium. So that's why we call it intraepithelial neoplasia of the cervix. So cervical intraepithelial neoplasia. Now, there are various grades of this. If there are less than 1/3 cells, if atypical or abnormal, let's say, we can write that, then we say it is CIN1. If more than 1/3 to 2/3 cells are abnormal, we call it CIN2. And if more than 2/3 cells are abnormal, we call it CIN3. And if all are abnormal, then we say that yes, in the epithelium of the cervix, see what we've done? The uterus and the cervix. Cervix looks normal to me. I've taken a smear. Under the microscope, the smear is showing me all abnormal cells. So in the epithelium of the cervix, all the cells are abnormal. That means on the epithelium, there's a cancer sitting just on the epithelium. So far, I've assessed only the epithelium. So carcinoma in situ. So this is what is known as the dysplasia classification. But we also have a Bethesda classification, and Bethesda classification is that we call this low-grade squamous intraepithelial lesion, this CIN1, and CIN2 and 3 is known as high-grade squamous intraepithelial lesion. So yes, CIN1 is low-grade and CIN2 and 3 are indeed high-grade. So CIN1 is low-grade, CIN2 and CIN3 is high-grade squamous intraepithelial lesion. So we can ask you either dysplasia or the Bethesda classification. MCI, mostly they'll ask you dysplasia. PG entrance guys, they are going to ask you the Bethesda classification. And when we talk about the classification, either way, they're going to mostly ask you about CIN3 treatment. But never mind, let's see what is the significance of CIN1, 2 and 3. So when we talk about CIN1, I know it is low grade, but yes, this is the one which is going to become a CIN3 in 5 years. And a CIN3 will become a CS cervix in 10 years. So do not disregard a CIN1. So if it is a CIN1, then you're going to be a little bit more vigilant than other women whom you're regularly doing a pap smear. So in this CIN1, I'm going to do a frequent pap smear. A frequent paps, maybe yearly or 6 monthly. And then I'm going to assess the HPV DNA this patient is having, whether it is the high risk or the low risk. If it is high risk HPV DNA, I'm going to be still more vigilant. Now, CIN3, what is the treatment? Before doing the treatment, confirm if it's only CIN3 or has it become invasive already. Now, this is the part which comes in your exam. If it is CIN3, see what happens in CIN1. It may become a CIN3 and a CIN3 may become a CS cervix. Do not get misunderstood that if a person has CIN1, she's going to definitely end up in CS cervix. Please don't get that idea. If it is CIN1, it may become a CIN3. What happens in CIN3? I'll tell you in a little while. But remember, if it is CIN3, more than 60% will spontaneously regress. More than 60% of them. It's a viral problem. And so many viral diseases, they come and go. But some of us get very sick of viral diseases, and some of us can even die because of viral diseases, right? Like influenza. Most of us will survive, but some of us can become very sick. So just like that, CIN1 also will get totally cured by itself in more than 60% of patients. Some of them, it may become a CIN3, and some it may progress to even CS cervix. So now, when we talk about CIN3, now this is that exam question, and let's concentrate on this. Even if it is rapid revision, we must understand this properly, that confirm that it is CIN3 only, and it has not become a cancer cervix already. In other words, see, this is the uterus, this is the cervix, and I've done a smear on the cervix. The smear is showing me more than 2/3 abnormal cells. That means if more than 2/3 abnormal cells on the surface of the cervix, who knows that some cells are already invading into the stroma. If they're invading into the stroma, it becomes an invasive cancer of cervix. All right. So before I treat CIN3, I rule out invasion. I rule out an invasive CS cervix. Please understand this part. Okay. So yes, CIN3, which you also told me is known as high-grade squamous intraepithelial lesion. So rule out invasive CA cervix. Okay, let me show you with a diagram. These cells are abnormal on the surface, the transmission zone, the first site where CA cervix starts. So are they having any invasion into the stroma like this? If this invasion is there or not, this is what I want to check. So rule out invasive cancer of the cervix. Now, how do I know there is invasion or not? I will have to take a biopsy. Now, how will I take a biopsy when the cervix, remember this patient was asymptomatic, she came to me for a screening test. When I look at the cervix, when I looked at the cervix was totally normal. The smear showed me CIN3. So now, in the normal looking cervix, microscopically it's a CIN3. Now you have to rule out if it is invading already or not. How do you rule out? By taking a biopsy. How do you take a biopsy? Now that's the question. How do you take a biopsy when the cervix is looking absolutely normal? Now this is where colposcopy comes in. If it is looking normal to you, but you must take a biopsy, then your vision won't be enough. Magnify your vision 15 to 40 times. Yes, colposcopy, 15 to 40 times is the magnification. And under that magnification with bright illumination, you look at the cervix and look for abnormal areas. And under abnormal area only there will be invasion. Sometimes you will not see any abnormal area. Good for the patient. There might not be any invasion. If there are abnormal areas, you will take a biopsy on that side. So yes, rule out invasive CS cervix by doing a colposcopic biopsy. All right. Now, colposcopic biopsy is 15 to 40 times magnification, and 15 to 40 times magnification, and it is under bright illumination. All right. And when we do this biopsy, sometimes just the colposcopy might not show us anything. Then you may use some highlighters. Yes, the highlighters which we can use for colposcopy can be acetic acid. Yes, it shows estrovite epithelium, which is the area which is rapidly dividing. So estrovite epithelium, you will take a biopsy. Or you can use the iodine. You can use the Lugol's iodine, or you can use the Schiller iodine. So that will give us brown areas in the normal cervix, and in the rapidly dividing area, it will be colorless. So you should know the basis behind that estro-white area is where the cells are rapidly dividing. When you put acetic acid, those areas will get coagulated by the acid. So those are rapidly dividing areas. Invasion will be, if at all, it will be under those areas. Estro-white areas you biopsy. Now when you give Lugol's iodine will stain the glycogen-rich cells. They will stain the glycogen-rich cells brown in color. But the areas which are rapidly dividing, they will be eating up this glycogen. Okay, so those areas will be colorless. So colorless areas you will biopsy. So estro-white areas you will biopsy in acetic acid, and in Lugol's iodine or Schiller's iodine you will biopsy the uncolored areas. And this colposcopy will also be held by a green filter. MCI question 2 years back. A green filter will show us the vascular patterns of the cervix much better. So you can use a green filter, Schiller iodine and acetic acid to do highlighting for a colposcopic biopsy, and that biopsy is to rule out if there's an invasion or not. So far we've just discussed how to take a biopsy. Now let us revise what all I've told you so far. For CIN3 or high-grade squamous intraepithelial lesion, you're going to do a colposcopic biopsy to rule out invasion, and that can be assisted by acetic acid, Schiller's iodine or Lugol's iodine, and green filter. Now, when we are in a setup where we don't have a colposcope, then the acetic acid and the Schiller iodine can be applied, and the reading we can't do with a colposcope since we don't have it. Then you can use your eyes. So yes, look into the cervix after applying acetic acid, and you can actually see the estro-white areas with your naked eyes also. So that is what is known as the visual inspection under acetic acid or visual inspection under Lugol's iodine. So it is mostly called VIA. All right, visual inspection under acetic acid, visual inspection under Lugol's iodine. That is a kind of a jugaad. All right, jugaad is like a Indian word for saying an adjustment. All right, it's a jugaad that if you don't have acetic acid, you don't have an iodine, then you can use these other methods by which you can visually assess the acetic acid and the Lugol's iodine effect on the cervix and take the biopsies. So once you've done the biopsies, what do you do next? After taking the biopsies, like suppose this is the transmission zone where you've taken the biopsies. Then once you've done the biopsy here, what all you can see? So in one biopsy you see that this cells on the cervix are invading into the stroma. So if they're invading into the stroma, then that becomes a invasive CA cervix if it is invading. So yes, this is that invasion which you could not see with your naked eye. Obviously, when the patient came to you, the cervix was all right, and you did a pap smear as a screening test. Screening test came CIN3. You did a biopsy. Biopsy showed you invasion. So yes, what kind of cancer is this? This is that very early type of cancer. This is that CA cervix stage 1 and 1A, which is microscopic cancer. So yes, invasive CA cervix, and the treatment is a radical hysterectomy. Now, if you do a biopsy and it comes as CIN3 only, look, I'll draw that and show you. You've done a biopsy, they have normal cells on the surface, and now they are not invading. One biopsy showed us invasion. Now this biopsy is not showing you any invasion. So this is now a biopsy proven. It's a biopsy proven CIN3. If it is a biopsy proven CIN3, the treatment is a loop electrosurgical excision procedure. Loop electrosurgical excision procedure. What do? You go to this area, this cervix, which is having this abnormal cells. On this cervix, this transmission zone, which is the abnormal area, that area you scrape it off. So this transmission zone, all right, these cells are taken out with the loop, with a wire which is there on a handle. That wire is a high resistance wire. It becomes red hot when you pass current, and with that wire you go and you scrape off this area. So that is what is known as the large loop excision of the transmission zone. But these days we call it the loop electrosurgical excision procedure. Earlier it used to be called the LLETZ. This terminology is not used now. Large loop excision of the transmission zone. I used to like that terminology more because it was involving that transmission zone word there. But now we call it the loop electrosurgical excision procedure. You can also do a laser conization of that area. Laser is more expensive and more difficult to master. You can also do a conization, especially if women is beyond 35-40 years. Now, if you take out just a cone of cervix, this much of cone of cervix you take out. Now, if a woman is young, let's say she's 30 odd years, 32 odd years, and she's got only one child, she wants to have more pregnancies, then this conization will cause the cervix to become very short. And short cervix causes incompetence os, which will cause abortions, and can also cause a stenosis of the cervix, which causes infertility. So conization generally only after 35 years of age. We can also offer a hysterectomy. Now, that is not offered for young people. That is after generally 40 years of age. So we can offer these treatments, but the best treatment, please don't forget this part. Whatever we discussed so far, don't forget the best treatment of CIN3 is loop electrosurgical excision procedure. All right. So if it is an invasive CA cervix or if it is CIN3 only, you started this discussion, this part of the discussion with CIN3. It turned out to be a biopsy proven CIN3. You do a LEEP. All right. So this is very important. The gist of all of this, if you thought that this was a little cumbersome, even in a rapid revision, I took some time. Let me tell you that all you have to know is that CIN3, which is high grade squamous intraepithelial lesion, do a colposcopic biopsy, and after that do a LEEP. If you don't want to know anything what we have discussed so far, at least this much you should know. All right. Now, what are the symptoms of CA cervix? The most common, when we talk about symptoms of CA cervix, most common is postcoital bleeding. Please remember, it can also be postmenopausal bleeding. Postmenopausal bleeding, it can be a pyometra causing a dirty, foul-smelling discharge. DC I'm writing for that. All of that, it can also be there. But the most common is postcoital bleeding. There can also be uremia. Uremia, in fact, is the most common cause of death of CA cervix is uremia. Must write that. And then it can also cause a cancer cachexia. Please be careful. Cancer cachexia, loss of weight, loss of appetite, inability to thrive. All of these symptoms are seen in CA cervix, but in CA endometrium, generally these are not seen. CA endometrium is a cancer of women who are very, well-to-do. They are, obese and they are diabetic and they are from affluent families. All right. So loss of weight, loss of appetite is not the first thing you'll think in terms of CA endometrium, but yes, definitely in case of CA cervix. So what are the types of CA cervix? Invasive CA cervix is most commonly squamous cell carcinoma, and that is the keratinizing type. Because the second most common, this also came in the exam, second most common is the squamous cell carcinoma, non-keratinizing type. And there's another variety which is the small cell carcinoma. All right. Let's talk about genital malignancies. And the most common genital malignancy is CA cervix in India. But when I ask you about most common tumors of women, don't get confused because tumors means benign and malignant as well. So yes, most common tumor, that is fibroid. It is benign most of the times, we know that. Now, most common malignancy of women, that is CA breast. And the second most common malignancy of women is CA cervix. Needless to say that when you're reading for PG entrance and I'm taking your class, we're going to talk only about Indian figures. And in exam also, they ask you only Indian figures. Don't get confused about that part also. So yes, the most common genital malignancy is CA cervix. Let's see about CA cervix in this chapter first. So CA cervix is all because of 99% at least due to human papilloma virus. You know, CA cervix starts in the transmission zone. And how does it get to the transmission zone in the cervix? It's all about sex. It's all because of sex. So early sex, sex with people who are having many partners, sex with people who are having sexually transmitted diseases. There is association with HIV and herpes simplex virus. And then sex with people who are having multiple sexual partners themselves. So when people are having that kind of sexual activity, they are more likely to have human papillomavirus entering into the bodies and causing the changes which cause, say, cervix. Now, there is also association with low socioeconomic status and with smoking women. But yes, the most common association is with sex. Of course, that kind of adventurous sex causes CA cervix. We all know that. But unfortunately, it also happens rarely to women who are in a monogamous relation. That's the unfortunate part. But most of the time, it is because of the etiology which I just told you. You must write all that. Okay. So yes, now human papillomavirus, what does it do? It has these E6 and E7 viral proteins. Now, these viral proteins will inhibit the tumor suppressor genes. The body has tumor suppressor genes to inhibit tumor growth. So those tumor suppressor genes like the P53 gene and the RB gene, these are tumor suppressor genes, and E6 inhibits P53 and E7 inhibits the RB tumor suppressor gene. So when there is inhibition of these tumor suppressor genes, there is unchecked proliferation of cells, which is known to cause the cancers. So that is the action of human papillomavirus. Now, when there is human papillomavirus, we already have a vaccine which can take care of that. But be very careful when I tell you about the use of this vaccine. Now, Gardasil 9. Gardasil 9, a nonavalent vaccine. I'll write VAX for vaccine. Now, this nonavalent vaccine is active against 9 serotypes like the name 6, 11, 16, 18, 31, 33, 45 and 52 and 58. These are the 9 serotypes. And when we are talking about these 9, these are only 9 against which the vaccine works. Human papillomavirus of over 50 serotypes. Over 50 serotypes causes CA cervix and 15 are high risk varieties. Alright. So don't think that if you give Gardasil 9, you're going to inhibit cancer cervix occurrence altogether. You are going to give some benefit, which is better than nothing, but it is not total benefit. So yes, when you give Gardasil 9, the schedule, all of you know, is to all women from 9 to 45 years and men also, because men are the ones who are putting the human papillomavirus into the women, isn't it? So all women and men 9 to 45 years, some books says 9 to 25, but please go with 9 to 45 years of age of women, and it is given on the 0 day, on the 2nd month after the 0 day, and on the 6th month after the 0 day. Now, when this vaccine is given this way, it is going to inhibit the occurrence of CA cervix. You know, the prevention is 90% if given before exposure and 40% if given after exposure. What do you mean by exposure? Exposure is sexual activity with a man who is having human papillomavirus. So it is going to prevent 90% and 40%, like I told you, only against these 9 serotypes. Please don't think it's going to give a guarantee of preventing CA cervix against all the serotypes. Now that is where people get misunderstood. Only against these 9 serotypes, it is effective 90% if it given before sexual activity with an infected person, and 40% if it is given after sexual activity with an infected person. Okay, so that's about the Gardasil 9. So if you give this vaccine, the screening still continues. Screening continues. All right. Now that's the vaccine information which I wanted to give you. But I'm not so averse to use of this vaccine. Yes, I have my own thoughts and use of this vaccine in my patients. But yes, I believe what the SAGE guidelines came, they were very informative and they were very practical, because this guideline says that you should give at least one vaccine to girls between 9 to 14 years so that there is some protection against CA cervix. And they say that it's if you give 1 or 2 vaccines rather than giving the full 3 doses, even giving 1 or 2 vaccines is just as good as giving 3. So the SAGE guidelines, this was your MCQ in NEET 2022. SAGE guidelines, Strategic Advisory Group of Experts on Immunization. So this is a WHO group, and SAGE guideline says that give 1 or 2 vaccines to all girls 9 to 14 years of age. So that is the SAGE guideline which came into exam, Strategic Advisory Group of Experts on Immunization. Now, when we talk about the screening of CA cervix, we know that screening is known to prevent CA cervix by 70%. All right. So that's why it is important that we screen all women who are sexually active for CA cervix. So when do you start screening? Don't say after 21 years. That's an American standard because women are sexually active much earlier in America and in the Western Hemisphere. We say in our country that start screening 3 years after sexual activity starts, because human papillomavirus takes at least 3 years for its effects to start exhibiting. So yes, screening for CA cervix, obviously you'll do it on asymptomatic women who are at risk of CA cervix. Why are they at risk of CA cervix? Because they're sexually active. So yes, after 3 years of sexual activity, you'll start the screening, and we'll do it once in 3 years till 30 years of age, and once in 5 years after 30 years of age if co-test is negative. Now, what is a co-test? Co-test is human papillomavirus DNA and the pap smear. So after 30 years, this co-test comes into the discussion. So co-test is when we're taking a pap smear from the cervix. We'll be talking about this a little bit. So when we're taking this pap smear, this smear, I plate it on the slide, but some fluid from the cervix, I also send it for the DNA assessment. Now, if the woman is pap smear negative, good news. And the fluid which I've sent for DNA assessment, that is also negative. That means 2 things are negative. Co-test, 2 things together, papillomavirus DNA and the pap smear, both are negative. Then don't come to me in 3 years, come to me after 5 years for a pap smear. But yes, after 30 years, if only PAPS is done, then do in 3 years itself, like before 30 years. All right. Like before 30 years, do the pap smear once in 3 years. Now, after 65 years, no more pap smear. All right, because after 65 years, the chances of CA cervix starting is virtually negligible. That's why. So when we're talking about pap smear, now what is the management of post-coital bleeding? That question always comes in your exams. So when I say post-coital bleeding, it is generally for women who are, we'll give you a story like a woman is around 35 years of age. She has 2 children. Recently, she's seen that every time after intercourse, she's having some bleeding. So post-coital bleeding, first thing, always examine, rule out any local lesions, vulval, vaginal, cervical lesions. If there are any gross lesion, rule them out. But if there is no gross lesion and the woman complains of post-coital bleeding, is she symptomatic or asymptomatic? She is symptomatic. So symptomatic people, you do a screening test or a diagnostic test. You do a diagnostics test. So yes, post-coital bleeding, don't say pap smear. I know all of you are going to say pap smear. At least most of you are going to say pap smear. Please, post-coital bleeding, we always say examine. If there's a local lesion, take a biopsy. But if there's no local lesion on the cervix, do a colposcopic biopsy. All right. So yes, now this whole equation will finish that post-coital bleeding and even carcinoma in situ. All of these, I will do a colposcopic biopsy. All right. So don't do a mistake of saying post-coital bleeding, do a pap smear. Okay. So these are the symptoms we've discussed. Now let us see what is the staging of CA cervix. So when we say staging of CA cervix is done clinically. All cancers in gynae are staged surgically except CA cervix, which is staged clinically. So what all we do for the staging of CA cervix? We do a per-vaginal examination, a per-rectal examination for the parametrium, and we do a cystoscopy for the bladder, a proctosigmoidoscopy for the rectal and lower gut involvement, and then we also now do imaging. Please mind it, ever since 2018, this modification has come in CA cervix staging, that now we do imaging. What imaging? Ultrasound, MRI, CT scan, or best PET CT to see if there is pelvic or para-aortic lymph node involvement. So yes, imaging is now required for the staging of CA cervix along with clinical examination. Do write that. Now, when we talk about CA cervix, the staging, it is done clinically, and let's see. I've written the staging already for you. See here. The cancer has started in the transmission zone. And how did you know that it has started in the transmission zone? Because you did a biopsy and the biopsy showed you invasion, like we saw in the example earlier. So that time it was limited onto the cervix. And it started invading into the stroma. How did you know there was invasion? I could know an invasion only after a biopsy. I did a colposcopic biopsy like in the example I told you, and with that I showed that there was some invasion. So how did I know? Microscopically. So what is stage 1? See, stage 1 is limited to the cervix, and stage 1A is microscopic cancer. And in microscopic cancer, 1A1 is invasion less than 3 millimeters. 1A2 is invasion 3 to 5 millimeter. Now, when the invasion is more than 5 millimeter, then you can imagine if there's a cancer on the cervix, which is more than 5 millimeter. Let's say I can draw and show you. See, from the surface of the cancer, from the surface of the cervix, the cancer has spread around 5 millimeter into the cervix. Can you see that black dot on my fingers? Yes. Now it has gone beyond 5 millimeter. If it has gone beyond 5 millimeter, then you can easily see with your naked eye also. So when it has gone beyond 5 millimeters, you can see with your eyes. It is 6 or 7 millimeters. So it's the size of a peanut, isn't it? So when you can see with your eye, then it's a clinically obvious cancer. So yes, when it is more than 5 millimeter, then we say it is clinically obvious. So that is stage 1B1. All right. See, the cancer now has spread, which is now more than 5 millimeter deep. So that is what is now stage 1B. So 1B1 is 5 millimeter depth to 2 centimeters, and 1B2 is 2 to 4 centimeters, and 1B3 is more than 4 centimeters, but it is still limited to the cervix. All right. So 1A, this is 1A is microscopic cancer, and 1B is clinical clinically obvious cancer. All right. In that you have 1B1, 1B2 and 1B3. Now, what is the next stage of cancers? That from the cervix it is going to the vagina and the parametrium. So now when the cancer is going from the cervix to the vagina, see, the cancer is now involved the upper vagina. So that is 2A. But when it involves the lower 1/3 vagina, that is 3A. All right. Don't say 2A and 2B. I've given you the color coding. Blue is vaginal involvement. 2A is upper vagina and 3 is lower 1/3 vagina. Now from the vagina, it can go to the area beyond the vagina, that is beyond the uterus and the vagina, which is known as the parametrium. There I've given you the red code. Now when the growth from the cervix goes to the vagina and then to the area next to it, we say it is a parametrial involvement. Now when it is involving the parametrium, see, this is the uterus and the endometrium here. This is the uterine muscle. So myometrium, next to the uterus, parametrium. So when it is involving the parametrium, it is 2B. All right. But when it is involving the parametrium, see, from the uterus, the cancer, from the cervix, the cancer has gone to the vagina and to the parametrium. But now it is gone till the level of the pelvic side wall. When it goes till the level of the pelvic side wall, now it is known as 3B. So 2B is parametrium short of pelvic side wall and 3B is parametrium till the pelvic side wall. Now when it is coming till the level of the pelvic side wall, so what happens here? Then there is no cancer-free area. There is no cancer-free area from between the cervix and the pelvic side wall. So the ureters which are coming like this, these ureters will get compressed in this, and that will cause a hydronephrosis of the kidney. So hydronephrosis of kidney is stage 3B. So upper vagina 2A, lower vagina 3A, parametrium shorter wall 2B, parametrium till the side wall 3B. Now this is the most common stage, all right, most common stage with which Indian women present to the OPD. CS cervix, they'll be having all symptoms, all dirty, foul smelling discharge and post-menopausal bleeding, post-coital bleeding, everything will be happening, but they'll sit and not complain. But one fine day, when the cancer grows till the level of the pelvic side wall, it causes severe pain, and that pain will bring the woman to the OPD. Most common stage of presentation of CS cervix in India is stage 3B. That's why they ask you also treatment of stage 3B. Now, when we say 3C, now that is the new stage. 3C is pelvic lymph node C1 and paraortic lymph node C2. Same as in C endometrium. This is that new stage which has come in 2018, the stage 3C. Okay, for this you need the imaging. Now I was telling you imaging is required to know pelvic and paraortic lymph nodes. You cannot do it clinically. So ultrasound, MRI, or best imaging, PET CT for pelvic and paraortic lymph nodes. All right. And 4A is bladder and bowel. 4B is distant metastasis. All right. That's the staging of CS cervix. Now remember, in the staging of CS cervix, inguinal lymph nodes are not the draining lymph node for cervix. So this is an anatomy question, also a gynae question, that inguinal lymph nodes not involved in CS cervix. So what are the lymph nodes involved? The interiliac, the extrailiac, the obturator, pelvic group of lymph nodes are involved. So what is the sentinel lymph node of cervix? So first group of lymph node, the major group of lymph nodes involved is the external iliac group of lymph nodes and also the obturator, one of these. But yes, earlier we used to classically say that the obturator lymph nodes are the sentinel for cervix. But yes, extrailiac now is what is mentioned in NOACS, that this is the more common group of lymph nodes which is involved, extrailiac, and then the obturator which are sentinel for cervix. Now, cervical lymph nodes. Now, so when we talk about the treatment of CS cervix, we say that from stage 1 to 2A1, that is upper vagina involvement, is stage 2A, but if the growth is less than 4 centimeters is 2A1. If it is more than 4 centimeters, it is 2A2. Any growth more than 4 centimeters, even in early cancer of cervix, surgical management is not adequate. All right, keep that in your mind. So when we talk about CA cervix stage 1 to 2A1, a radical hysterectomy is mostly adequate treatment. In India, we generally do the type 2 radical hysterectomy, which is known as Wertheim's. Type 3 is known as the Meeks. So we do the type 2 radical hysterectomy, also known as the modified radical hysterectomy. And from the stage of 2A2, we give chemotherapy and radiotherapy together. So we say chemoradiation. So yes, beyond 2A2, chemotherapy and radiotherapy is excellent treatment even in such advanced cancer, especially when women come to you with stage 3B commonly in our country. So please remember, what is the most common stage with which CA cervix presents to you in the OPD? Mostly stage 3B. And what is the treatment of that? Chemotherapy and radiotherapy together. Mind you, I did not say do surgery and along with that give chemo radiation. No, I didn't say that. I said till 2A1, radical hysterectomy is enough. Beyond stage 2A2 and beyond, surgery won't be adequate. So give chemotherapy and radiotherapy together. But I'm not saying do surgery and chemoradiation. Just chemoradiation should be your answer. All right. Now, all of this etiology, which is because of high estrogens, and this is going to cause endometrial cancer. So what does it do? It causes hyperplasias. Now, what are the types of hyperplasias? It can be simple endometrial hyperplasia without atypia. Now, when this hyperplasia is seen, it causes CA endometrium in 1% cases only. It can be complex endometrial hyperplasia without atypia, and that causes endometrium in 3% of cases. And it can be simple endometrial hyperplasia with atypia, which causes endometrium in 8% cases, and complex endometrial hyperplasia with atypical cells causing endometrial cancer in 29% of cases. Now, this study is the Hackers study of 1970s and 80s, and this data is still relevant, and these figures are asked in PG entrance exams quite regularly. In fact, the simple endometrial hyperplasia, I beg your pardon, the complex endometrial hyperplasia with 29% chance of endometrial cancer is a frequent MCQ. Now, what do we do with this? Please remember, when there is no atypia, without atypia, the chance of endometrial cancer is lesser. So, when this woman who is around 45 to 50 years is having hyperplasia, but not much chance of causing a cancer, so we can treat this by giving progesterone therapy. Very common MCQ, progesterone therapy. But if the patient is having simple or complex adenomatous hyperplasia of the endometrium and the cancer is 8% to 29%, then the woman should have a hysterectomy. All right. So that's the treatment of the hyperplasias. Now, what are the symptoms of CA endometrium? Patients with CA endometrium, classically, I told you in the beginning of the chapter itself, it is irregular acyclic bleeding with diabetes mellitus, hypertension, and obesity. So this irregular acyclic bleeding is also known as menometorrhagia. Okay. So menometorrhagia in a woman with diabetes mellitus, hypertension, obesity is equal to CA endometrium. Very, very common MCQ in all exams in our country. Now, cyclic bleeding beyond the age of menopause is another symptom, and post-menopausal bleeding is also one of the symptoms. Please remember, the most common presentation is irregular acyclic bleeding. This is most common. Don't say post-menopausal bleeding is the most common presentation. See, post-menopausal bleeding can happen, but that is not the most common presentation of CA endometrium. And they can also be pyometra. You know, the endometrium is having a cancer, and this cancer which is there in the lining can make its own secretions, and that can collect here inside the uterus, and that can become pus and come out as pus discharge can come out. So that is a pyometra. Pus in the uterus is pyometra, blood in the uterus is hematometra. So pyometra can be a presentation which causes dirty, foul smelling vaginal discharge also. Now, what is not seen in endometrium? loss of weight, loss of appetite, and cancer cachexia, classical symptoms of any cancers. These are not seen in CA endometrium, all right? This is a cancer of women who are well-to-do and too much to eat and too much of appetite and too much of weight, okay? This is not the common presentation of cancer of endometrium. Even CA endometrium causing cancer pain, even cancer pain is a late presentation, if at all, in CA endometrium. Now let's talk about CA endometrium. When we talk about this, remember, this is that cancer which is not common in our country. We all know that CA cervix is the common genital cancer of women in our country. But CA endometrium is that common MCQ which comes in your exam because of its peculiar presentation, like a woman around 45 to 50 years of age, diabetes mellitus, hypertension, obesity with irregular bleeding per vaginum. What is the first thing you're going to do? Which is an endometrial biopsy in the OPD. Or what is the more likely cancer, which is CA endometrium. Remember this story which I gave you the presentation. It's a very common MCQ both in PG exam and in MCA exam. So when we talk about CA endometrium, the most common type of CA endometrium is the adenocarcinoma. And in adenocarcinoma, the most common variety is the endometrioid variety. There's another variety which is the serous and another one which is the clear cell. Now, serous and clear cell are less than 10% of the varieties, but these are the worst prognosis. They account for the most deaths. More than 50% of deaths of CA endometrium are because of these two varieties, the serous and the clear cell variety, although they are not the most common. The most common is the endometrioid variety. Now, CA endometrium are two types, the 45-55 age group which I told you. This 45 to 55 age group generally have this type 1 endometrial cancer. Type 1 endometrial cancer is the one which is classically because of the unopposed estrogens. You know, too much of estrogen, too much of hyperplasia of the endometrium, and that hyperplasia can cause CA endometrium later on. So, unopposed estrogens can be because of hormone replacement therapy. And, you know, if you don't monitor the hormone replacement therapy, it can cause hyperplasia and cancers. Then early menarche, late menopause, more exposure to estrogens. And tamoxifen therapy, we know we give tamoxifen for the follow-up of CA breast. But if a person has CA breast, then we want to suppress the CA breast. So tamoxifen is a selective estrogen receptor modulator. And this tamoxifen is going to suppress the estrogen receptors on the breast. But on the uterus, tamoxifen is estrogenic. So you know that SERMs are estrogenic and anti-estrogenic action. Some places estrogenic, some places anti-estrogenic. So tamoxifen, when it is anti-estrogenic, this action we want. It is desirable that on the CA breast follow-up, I don't want the estrogen action to be now exhibited. So I give tamoxifen to suppress that CA breast recurrence. But on the uterus, it is estrogenic. Now, if I give tamoxifen therapy, always keep an eye on the endometrial proliferation. Now, next is estrogen producing ovarian tumors. What are those? Like the granulosa cell tumors of the ovary. Granulosa cells makes estrogen, granulosa cell tumors make more estrogen, can cause hyperplasias. Now, anovulatory conditions. Yes, all of you know the famous topic which keeps coming in exam. PCOS is anovulatory condition, no ovulation, no progesterone, and only estrogen is high in amount in the circulation of this woman. So that causes a lot of hyperplasia. Now, obesity. Why obesity is a problem? Because fat is the factory which converts the androgens to estrogens. So that is by the aromatase, AR I'm writing here. So that is because of the aromatase enzyme, and more fat means more estrogens and hyperplasia. Now, what is the corpus cancer syndrome? So if you see the uterus, the uterine body, yes, this body of the uterus, this is also known as the corpus. This body, what is body? Body is also known as corpus. So corpus cancer syndrome, uterine body ka cancer, that's how we say. So corpus cancer syndrome, where do you see more uterine body cancers? So corpus cancer syndrome is diabetes mellitus plus hypertension plus obesity. So that is the corpus cancer syndrome. Women with this will have more endometrial cancer or cancer of the body of the uterus, corpus cancer syndrome. Now, there is also a predisposition when there is abnormal liver function test. You know, estrogens are metabolized in the liver. So when estrogens are metabolized in the liver and the liver is not working properly, then estrogens will be circulating for a longer time, more hyperplasia. Links to syndrome, yes, association with hereditary non-polyposis colonic cancer, hereditary non-polyposis colonic cancer syndrome. So there is association of C endometrium with HNPCC also. Familial predisposition. Now, please, this is very important. Familial predisposition, we know that if a woman has CA breast or CA endometrium or CA ovary, then the first degree female relatives can have either of these cancers. Now, what is the meaning of this? Suppose a woman has CA breast, then her sister, her daughter, or even her mother, sister, daughter, mother, first degree female relatives can have CA breast, but she can also have CA endometrium or CA ovary, familial cancer syndrome. Remember, it is important. We'll come to CA ovary next. And again, I'll mention this to you. And also when your surgery teachers are teaching you about CA breast, remember about familial predisposition. And then nulliparity. Nulliparity is very simple. No break from estrogen action. What is the meaning of this? Meaning that when a woman is pregnant, she does not menstruate for 9 months, then she's breastfeeding the child, then again she's not breastfeeding, and exclusive breastfeeding is 6 months. And we know Indian women will breastfeed children for almost a year or sometimes even 2 years. So roughly we can easily say that one pregnancy gives relief from menstruation for 2 years. That means Indian women who have 3 children or even 4 children, they have a break from menstruation for 6 to 8 years. Now, 8 years is like a menstrual vacation. I mean, women hardly menstruate. So when they do not menstruate, endometrial hyperplasia chances will be much lesser because estrogen action is not there for this 6 to 8 years of break from menstruation. So that's why we say that C endometrium is a common MCI, MCQ and a common PG entrance MCQ. But it is not a most common cancer in the society. Most common cancer again is CA cervix, because nulliparity is not a problem in a country. Multiparity is a problem in a country. Okay. So yes, CA endometrium is classically associated with nulliparity, and that nulliparity means no break from menstrual activity and estrogen exposure every month, and that causes hyperplasias. Now, what else? There is another type of CA endometrium, which is type 2. What I discussed with you so far, this was the type 1. Type 1 is the 75 to 80% of endometrial cancer is the type 1. But type 2 is the endometrial cancer which is seen in older women, thinner women, and they're not associated with estrogens. All right. So after taking the biopsy shows us endometrial cancer and endometrioid type most commonly. Now, how do you do the staging? So like I said, all cancers in gynae are staged surgically. CA endometrium is staged surgically. Of course, CA cervix is staged clinically, like we also saw in the previous chapter. Now, when we're doing CA endometrium surgical staging, what do? We have done a hysterectomy, and along with the hysterectomy, we have also taken out the pelvic and parotid lymph node samplings. So we now say that if the uterus is involved, we take it to the path lab and see from the endometrium how much is gone to the myometrium, to the cervix, to the serosa, or how much has it gone to the local lymph nodes, the pelvic lymph nodes, or to the parotid lymph nodes. So that's what is the surgical staging of CA endometrium. So let's see if we can see that here. Okay. This is the endometrium here. Now, the cancer stage 1 is limited to the uterus, and stage 1A is the endometrium is having the cancer cells. Then stage 1A also can be involving less than half of the myometrium. So this is the less than half of the myometrium here. Then from the myometrium, it can go more than half of the myometrium also. So here, more than half of the myometrium. So that is stage 1B. From the endometrium, myometrium, the cancer can go to the cervix. Now, when it goes to the cervix, we only have stage 2. We don't have stage 2A and 2B. So, when it goes to the cervix, it is called stage 2. Remember, glandular involvement of the cervix. See, this is cervical stroma. Cervical glandular involvement is stage 1. Cervical glands. So, I'm writing here itself. That is in stage 1. But that is not mentioned in the staging. So what is not mentioned in the staging sometimes becomes a PG entrance question. When cervical glands only are involved with C endometrium, what is the staging of C endometrium? That is stage 1. Okay. Now, when it is involving the cervical stroma, it is stage 2. Now, from the uterus and the cervix, if it goes to the serosa, see the surface of the uterus. When it goes to the surface of the uterus, the serosa, and the adnexa means the tubes and the ovaries. Now, from the serosa, next it can go to the vagina. Now, when it is involving the vagina, that is one part of C endometrium which comes as MCQ. That is vaginal and parametrial involvement. Okay, parametrium are these areas next to the uterus, like in cervix also we discussed. Vagina and parametrial involvement is stage 3B. Vaginal involvement, very important. Then stage 3C is pelvic and para-aortic lymph nodes. So C1 is pelvic lymph nodes, C2 is para-aortic lymph nodes, and stage 4A is bladder and bowel, and stage 4 is distant metastasis, including inguinal lymph nodes involvement. Now, how do inguinal lymph nodes get involved? Please remember that the round ligaments, which we discussed, that these round ligaments will have the lymphatics going from along the round ligaments to the labia. So, you know, the round ligament goes from the top of the uterus through the inguinal canal till the labia majora in front. So, lymphatics along with this can go to the inguinal lymph nodes. So, yes, if the inguinal lymph nodes are involved in CA endometrium, it is stage 4B. Now, we should also read the grading of the tumors. So, what is the grading of the tumors? Now, grading of CA endometrium. See, I have told you the staging. When we see the endometrium from the uterus, we scrape the endometrium, look at it under the microscope, we say it is adenocarcinoma. Okay, fine. That is the diagnosis. Now, what is the grading? Grading is how many cancer cells are seen per slide. How many cancer cells are, crowding the slide. So, when there are too many cells, you see one cell, it is showing us cancer, my diagnosis is already there, that it is adenocarcinoma. So, what is the grading? The number of cancer cells on a slide. Let me try and explain you this here. So, if you see the slide, and these are these, I'm just trying to draw some circular cells. These are, of course, glands, but I'm just saying, like, suppose these are the cancer cells, and you know that all these cells are having a big nucleus. So that's why these are large mitotic figures, and I know that this is a cancer cell. Now, my diagnosis of endometrium is done here already. But in this slide, I see one corner with so many more cancer cells which are clumped together. So when these cancer cells are so many and they are clumped together, they are giving a solid pattern in the slide. So if these kind of areas are many in a slide, then it is worse prognosis. So these solid or non-morular areas, like we call. So the solid areas on the slide, if they are less than 5%, then it is a grade 1 tumor. And if it is 5 to 50% of the slide, it is grade 2. And if it is more than 50% of the slide, it is grade 3 tumor. All right. So that is a grading, and grading also has a significant prognostic effect. Okay. What is the most prognostic feature of endometrium? That is the staging. But grading has also got significant effect on the prognosis. All right. Now, what is the workup or management of this woman who's come with irregular acyclic bleeding, and she's around 45-50 years of age? First thing, rule out any local lesions. So yes, of course, you do the general physical examination first. After the physical examination, look at the perineum, look at the vulva, open the vagina with the speculum and see the vaginal canal, look at the cervix. If all of this is fine, no local lesions, then what can be the cause of bleeding? It could be in the uterus or in the endometrium. So yes, local examination rule out local lesions. And then first thing in the OPD, what to do? This question has come many times. Then we do a office endometrial biopsy. Why do we call it office endometrial biopsy? Basically, the place where I work, the OPD is known as my office. So I say OPD endometrial biopsy or the office endometrial biopsy using a PIPPEL. PIPPEL is a plastic curette which we can use very simply to take a biopsy in the OPD, and it's very easy also. Most women don't have much discomfort while we're doing this procedure in the OPD. It's a plastic curette type of instrument. So we put inside the uterus, and through the uterus, like this, you go into the uterus in the OPD and take a scrape of tissue. When you take the scrape of tissue, how sensitive it is. That is, suppose the woman has endometrial cancer, then this PIPPEL biopsy, how sensitive it is to pick up this endometrial cancer. This is up to 90% sensitive. That's why it is a good thing to do in the outpatient department. So PIPPEL endometrial biopsy is the first step, and don't say ultrasound is the first step. That is the wrong answer. You've been giving that answer in many of the forums where I met you. Now, what is the next thing you can do? Even better than the PIPPEL endometrial biopsy is the fractional curettage. That is, when we do a PIPPEL biopsy, it is up to 80 to 90% sensitive. Now, when I do endometrial aspiration by PIPPEL, then I'm just taking one strip of tissue. But what is better, that I take one strip from the anterior wall, one strip from the posterior wall, right wall, left wall, fundus of the uterus, isthmus, and the endocervix. So this way, all the fractions of the uterus are assessed. So that is what is known as a fractional curettage, which is almost synonymously used as DNC. So if you say DNC, it's good enough for your exams. All right. So we can do a fractional curettage or a DNC, which is 95 to 99% sensitive in picking up endometrial cancer, or we can do a hysteroscopic biopsy. Get into the uterus, put a scope into the uterus and look inside the uterus for abnormal lining and take a biopsy. So if there is endometrial cancer, then this is 100% sensitive. This is the best method. So if they ask you the best method to assess the endometrium, always say hysteroscopy. Then you can do a transvaginal sonography. It's a good adjunctive procedure. It's a good adjunctive procedure for the assessment of the uterus and the endometrium. Don't say it is the first step to be done. All right, TVS. And please make sure that post-menopausal women, if they ask you, the endometrium should be less than or equal to 4 millimeter. In post-menopausal women, of course, you have been asked this question so many times. So what is the endometrial lining beyond which you'll assess a post-menopausal woman? 5 and more. Okay. That is the endometrial lining beyond which you are worried about the post-menopausal uterus. All right. Now, completing the treatment of endometrium, we've already done the hysterectomy. That's how we did the staging. And now, after doing the hysterectomy, we get to know that it is stage 1. So if it is stage 1, let us see. If it is not involving the mammary, that is stage 1, not involving the mammary, and it is only just grade 1 kind of histopathology, then we have no more treatment to do in this patient. The hysterectomy was enough. But if it is involving the mammary and it is less than half of mammary with grade 1 or grade 2 histopathology, then we have to give vaginal irradiation. And if the mammary is involved more than half, especially with a grade 3 lesion, then we'll have to give a pelvic irradiation. So that is what is the stage 1. Now, if it is stage 2, then we have to give, that is cervical stromal involvement, we have to give whole abdominal radiation. Now, like I said, treatment of CA endometrium, they won't ask you much, but what is generally asked, I've already told you. And stage 3 and stage 4 is rarely asked. I've not yet seen a question because, you may say that you want to give chemotherapy for stage 3 and stage 4. I'll say that I'll give radiotherapy. And both of us are basically correct. and we are not going to give her much relief because the disease is quite advanced. So stage 3 and stage 4 is individualized treatment. It could consist of a chemotherapy or a radiotherapy or a surgical therapy. We could do some resections, some palliative surgery also can be done, or we can do hormonal therapy. You know the hormone progesterone can be given for C. endometrium management. Yes, especially if there is a recurrence of C. endometrium. What is the most common site of recurrence of C. endometrium? Yes, that has also come as MCQ once. So this, if you've done the hysterectomy, if you take out the uterus, then this part of the vagina which stays back, you will suture this together. This is known as the vault of the vagina. Now, this is the most common site of recurrence. Now, when this is the most common site of recurrence, the first line treatment of recurrence, that is progesterone therapy. Okay, so first line treatment of recurrence is progesterone. Of course, for recurrence, we can give radiation as best treatment so that the disease, vaginal recurrence. When we talk about diabetes and hypertension, let me give you an overview before we go into the individual topics. Now, what we must understand that a woman who is pregnant can have diabetes for the first time in her pregnancy. Similarly, a woman who is pregnant can have hypertension for the first time in pregnancy. So when hypertension happens for the first time in pregnancy, we call it gestational hypertension. Similarly, when diabetes happens for the first time in pregnancy and never having diabetes before this, that is known as gestational diabetes. Now, how is this defined? Gestational hypertension is hypertension more than 140/90 after 20 weeks of gestation. And similarly, gestation diabetes is high sugars in a pregnant lady, which is after 24 weeks. So understand this now itself. We'll talk about them individually, but understand that first time hypertension, first time diabetes known as gestation hypertension and gestation diabetes happens at these weeks. Understand this basic. Now, hypertension can be there in a young girl who is, let's say, 15 and now she gets pregnant. She's been hypertensive ever since she was 15 and now she's, let's say, she's come to us at 30 years of age and she's pregnant, and in the first trimester itself her blood pressure is high. So that is chronic hypertension presenting in pregnancy. So that could be because of, let's say, she's essential hypertensive, she's got a renal artery stenosis or many other myriad reasons of hypertension in humans. Now, a diabetes also can present like this in pregnancy, that a young girl who was, let's say, 10 years and she was diabetic ever since her childhood. Now she's pregnant at 30 years. In the first trimester itself, when she comes to us, she's got pre-existing diabetes, or we call it overt diabetes mellitus. All right, I'll write that here, overt diabetes mellitus, and now she's pregnant. So in the first trimester itself, the sugars are high. Now, each one of these, we must understand the management is almost the same. What we give in hypertension, you know the drug of choice is labetalol. What we give in diabetes, you know the drug of choice is insulin. But the severity of disease in both of these is more if it is a pre-existing hypertension or a pre-existing diabetes. So let's see about these things individually now. Let us talk about hypertension in pregnancy first. When we say hypertension in pregnancy, that can be gestational or pre-existing, like I told you. Now, when we talk about gestational hypertension, that is blood pressure more than 140/90 after 20 weeks of gestation on more than 2 occasions, which are 6 hours apart. And this woman never had hypertension before this. She was previously normotensive. When gestational hypertension is coupled with proteinuria, suppose she has proteinuria, which is more than 300 milligrams in 24 hours of urine. 24 hours urine is collected. And in that, if it is more than 300 milligrams, then it is known as preeclampsia, which was also known as the pre-eclamptic toxemia, which was still earlier known as the PIH. Nowadays, we call it the preeclampsia syndrome. Then, along with preeclampsia, if the patient has tonic-clonic convulsions. So, tonic-clonic, the full body is having clonic action like this. First, there will be a lot of tone, and then she'll have clonic actions all over the body. So tonic-clonic convulsion along with this is known as the eclampsia. So that is what is gestational hypertension, and the worst form of that is the eclampsia. Now, let us look at chronic hypertension. Chronic hypertension in a patient is a hypertensive even before she got pregnant. And now she's coming in early pregnancy with high blood pressure. Now that could be because of essential hypertension, renal artery stenosis, a pheochromocytoma, many other reasons. There can also be another condition which presents in pregnancy, and that is acute on chronic hypertension. PG entrance students, this has come twice as exam question for you. What do you mean by acute on chronic? A woman is a hypertensive when she gets pregnant. From the first trimester itself, she has high blood pressure. Now, after 20 weeks, she gets a superimposed preeclampsia or superimposed gestational hypertension. So, acute on chronic. She is a known case of hypertension. After 20 weeks, she gets gestational hypertension also. So, how do you diagnose that? The blood pressure starts getting to worsen. There is new onset proteinuria. The liver enzymes will increase and the platelets will be lesser than 100,000. If the platelets are lesser than 100,000, that is suggestive of acute on chronic. Now, how do you understand that there is new onset proteinuria, platelets are less than this, and liver enzymes are raised? Why am I using this as a criteria for diagnosing a gestational hypertension over a chronic hypertension? Why is there a superimposed gestational hypertension? So try and understand, you and me, if we get hypertension, for us to get proteinuria, liver enzymes raised, and hemolysis and platelets getting destroyed, all that is going to take a long time. Much chronic disease will cause all of this to us. Whereas pregnant women, when they get hypertension in pregnancy, the gestational hypertension, then these things happen very early. So, how do we understand that this woman who was a chronic hypertensive, now she's become acute on chronic, that is, she's got superimposed gestational hypertension. She was a hypertensive patient and she had none of these problems when she was pregnant. She had chronic hypertension. Now, around 12, 13, 14, 20 weeks, she was fine. Around 23, 24 weeks, when you check her blood pressure, it is increasing. Her urine is showing proteinuria, and there are lesser platelets, increased enzymes. The creatinine levels is more than 1.1. When all of this starts happening, we know it is an acute on chronic hypertension. So these are the criteria. So they had asked once that which of these is not the criteria. They had written platelets less than 75,000. Platelets less than 1 lakh is diagnosis of acute on chronic. Now, what is delta hypertension? Now, let me tell you, delta hypertension is that situation where a patient had normal blood pressure throughout her pregnancy. She had no problems with the blood pressure, and the blood pressure was, let's say, 100/70 throughout the early pregnancy. Later half of the pregnancy, let's say around the third trimester, the blood pressure became 130/86. Is this hypertension? No. 130/86 is perfectly normal blood pressure by all standards. But a patient who had low normal blood pressure and later in pregnancy she gets a high normal blood pressure, this change, this increase, all that is less than 140/90, this itself can cause the patient to have proteinuria, and some of these have actually had some convulsions also. So low normal blood pressure, later she starts having high normal blood pressure in pregnancy. That is what is known as a delta hypertension. PG entrance question once. Now, let us move and see what is the course of these disease. I mean, when we talk about hypertension in pregnancy, I want you to understand some basics upfront, that blood pressure is high. Let's say around 25, 26 weeks, we say it is gestational hypertension. Now, I don't want you to have proteinuria later and get a preeclampsia. So take care of your blood pressure. Now, she comes to the OPD, I give her, let's say, labetalol, and she goes home. 2 weeks later, she comes to me and I check her blood pressure. It is still high. And now in the urine, there is proteinuria. How do you know it is proteinuria? More than 300 milligrams in 24 hours or 1+ on the dipstick. Now she's got preeclampsia. What happens with preeclampsia? I admit her. I increase my tablets, or I add another tablet to control the blood pressure. And I want to monitor her very closely so that she should not get into eclampsia. Maybe she's in the hospital now and I'm doing a very, regular checkup of the patient and I'm giving her good drugs. But in spite of all these drugs, once in the hospital, let's say around 33, 34 weeks, she throws a convulsion. Now she's gone into eclampsia. What will happen after eclampsia? You know, eclampsia, she's convulsing and she may go on convulsing 10-15 times in a day if you don't control it. Sometimes they are brought to us from a village and they are convulsing non-stop. So when eclampsia happens, when convulsions happen, she's not breathing during the convulsion, she's going to get a hypoxic brain injury, and the fetus may get a hypoxic brain injury, and the baby may be born with cerebral palsy or may have an intrauterine death. So that's why what happens after a patient has eclampsia? After a patient has eclampsia, there can be fetal problems. What can happen to the mother? The mother can have hemolysis, there can be increased liver enzymes, and there'll be lowering platelets, what we call it as the HELP syndrome. She may have worsening of her kidney function test. She may get a pulmonary edema, cortical venous thrombosis. The brain may have thrombosis in the cortical sinuses, and she may go into DIC and may even as much as die with eclampsia. So eclampsia, when happens, we are very, very worried. When eclampsia happens, we know that the patient is now getting into the phase where she may as much as die. So that's why we say, when a patient has eclampsia, what is your management? Look, I've not spoken about the etiology of PIH. I'm worried about you to understand what is the principle of this hypertension pregnancy. So when eclampsia happens, see, with this, you know, you will give hypertensive management drugs. You will give antihypertensive drugs. So when a patient has eclampsia, what are you going to do? The worst case scenario of hypertension pregnancy is that the patient has thrown a convulsion. So moment she convulses, yes, you know, the drug of choice is magnesium sulfate for the convulsion. You control the convulsion, and the drug of choice for the blood pressure. You know, we keep forgetting about the blood pressure. You know, if I ask you what is the drug of choice for hypertensive emergencies in pregnancy, you'll say IV labetalol. But here when I ask you what you give after max health, most of you will miss writing IV labetalol. So this is the place. Drug of choice for blood pressure control is labetalol IV. Now that is the hypertensive emergency which a obstetrician is worried about. The only hypertensive emergency which I am worried about, that is eclampsia. So drug of choice for the convulsion and for the hypertension is this. Now you've controlled the convulsion, you reduce the blood pressure. What next? Now this is where obstetrics comes in. So far you're talking pharmacology. What is obstetrics now? Patient has eclampsia. The worst case scenario of hypertension that she has had now eclampsia. So what do you do afterwards of this? Moment she has eclampsia, you give these drugs and do the delivery of the patient. Yes, you have to do the delivery of this patient because she's now going to get many severe complications and she may as much as die, like we discussed in the previous slide. So now we have to do the delivery. Eclampsia, this is the end of pregnancy. There is no management, no continuity of pregnancy after the patient throws a convulsion. Understand this basic. So this you understood, eclampsia, because all of this can happen. Now, there is another stage which is just before the stage of convulsion. That is the stage of imminent eclampsia or worsening of hypertension. Now, a patient may have nausea, vomiting, blurring of vision, headaches, loss of vision or blurring of vision, both can present, and she may have exaggerated knee jerks, and we'll have a reduced urinary output, a blood pressure which is more than 110 diastolic, and proteinuria which is now more than 2 grams in 24 hours. If it is more than 3.5 grams, we call it the nephrotic range. And along with that, she may have problems in the enzymes and she may have problems in the hemolysis. So all of this might be there. So when we see these things in a woman who's got hypertension and proteinuria, when she's having these features, then we know she's about to throw a convulsion. So when she's throwing a convulsion, this is your management. Now, when a patient is in the hospital, you should be able to catch a patient before she throws a convulsion because you're a physician. So when you are able to see that this woman is about to throw a convulsion, then what do you do next? So please be very careful. For eclampsia, this is the management. But if you are smart and you caught a patient in the state of imminent eclampsia, then the management is still the same. give magnesium sulfate to prevent a convulsion, give labetalol to control the blood pressure, and plan the delivery. Yes, mode of delivery depends. If she's in eclampsia or imminent eclampsia and she's in early labor, she will deliver even after 1 or 2 convulsions, she'll deliver. But suppose she's around 36 weeks or 35 weeks and the Bishop's is less than 5, which is not favorable, you may take a decision to do a cesarean section also. So mode of delivery is not important, delivery is important. All right. So once you understand this, now let's get into the more hotshot discussion about the hypertension in pregnancy. So what is the etopathogenesis of a patient who's having hypertension in pregnancy? Please remember, when we say hypertension in pregnancy, especially the gestational hypertension, which is happening after 20 weeks of pregnancy, it is poor placentation. And the second part of it is the maternal syndrome. So this is now split into a 2-part syndrome. The first part is the poor placentation, that the placental vessels don't form properly, and when the vessels don't form properly, the mother's blood pressure increases to overcome these bad blood vessels which are formed in the placenta. That's the basic of that. And then maternal syndrome is that there are some factors which promote the vasospasm of the blood vessels, and also some factors which inhibit proper angiogenesis in the placenta, proper vascular blood vessels formation in the placenta. So that is the gist of this 2-part syndrome, the etopathogenesis of hypertension in pregnancy or gestational hypertension. Now, what do you mean by the stage 1? Etopathogenesis, when we discussed, poor placentation was the first part. So from the maternal side, the blood lakes are going to form in which the villi of the fetus are going to invaginate, and they are going to take nourishment from the mother. No mother gives blood to the fetus. Fetus makes its own blood, but the mother gives nourishment. So across this villi, there is active transport, passive transport and all that. So for the baby to get good nourishment from the mother, these blood vessels, see the fetal villi, these blood vessels in the villi, they should have a good blood flow. So for that blood flow to be good, what happens? This is the formation of the villi in the early part of the pregnancy. Now, after 20 weeks, see this part, after 20 weeks, there is trophoblastic invasion and replacement of the muscle layer in the villi. So this muscle layer, can you see, is now replaced by trophoblast. I made it greenish, orangish in color for you to understand. So when trophoblast replaces the smooth muscle, there is no muscle to cause vasospasm anymore in the villi. So these vessels are dilated and they give more perfusion to the fetus and more exchange from the mother and good growth of the baby. Now, can you note here, when there is this kind of villi in the developing placenta, when there is this kind of villi in the developing placenta, where there is persistence of muscle layer, when there is persistence of the muscle layer, that means there is poor placentation. The placenta is not formed properly. So the first thing you should always understand, that the 2-part syndrome is known as, so you should understand in the etopathogenesis, the first part is poor placentation, and poor placentation, if you understand this part of the PIH etiology, the poor placentation means the blood vessels are persisting with the smooth muscle layer, which causes vasospasm. And to overcome this vasospasm, the mother increases the blood pressure. So let us try and understand it another way, that this is the diagram inspired from Williams obstetrics, that when you see the villi, the anchoring villi into the uterine muscles, you'll see that the villi which are forming, there is this syncytiotrophoblasts and these cells are the cytotrophoblasts. Now these cytotrophoblasts will come and start replacing the smooth muscle by the 3rd trimester, and by the 2nd trimester you can see, and the end of 3rd trimester, this muscle is totally replaced. So that's why you see the diameter of the vessel here and the diameter of the vessel here. So when there is muscle, the diameter is small, but as the pregnancy advances, the diameter of the vessels become bigger because the smooth muscle is replaced by the trophoblastic invasion. Same thing which I had drawn. This is a diagram inspired by Williams. Now let's move and see. Sometimes there is persistence of the smooth muscle. So that's what I'm showing you again, that there is no complete, the invasion of trophoblastic cells is not complete. So these kind of vessels are persisting. The spiral arteries are persisting with the muscle. So there is vasospasm. And to overcome this, the mother increases the blood pressure. Now, what is the second part? The maternal syndrome part. So in this maternal syndrome, we know that the first part is endothelial activation. The endothelial activation, because of the cytokines, causes vasospasm. Also, in addition to the endothelial activation, there are more vasopressors and there are reduction in the vasodilators. Vasopressors, like that is classical teaching of PIH. In addition to the poor placentation, these things are more vasopressors like angiotensin 2, thromboxane A2, endothelin 1. These cause vasospasm of the placental vasculature. Then there is reduction of the vasodilators like prostacyclin, PGI2. Prostacyclin is reduced, nitric oxide is reduced. So more vasopressors, more vasodilators causes ultimately more vasospasm. And one thing which came in the exams, and a very important fact, is that when these cytokines change, what happens to the ratio of prostaglandin and thromboxane A2? So prostaglandin I2, prostacyclin and thromboxane A2 ratio is reduced. So this ratio came in one of your exams, and this pathology has been the hub of the MCQs in obstetrics recently. So go through this properly in the regular app also. So when we see that there is lesser prostacyclin and more thromboxane and the ratio is now reduced, so we say that the patient is now getting into vasospasm, and to overcome that, the mother is going to increase the blood pressure. So that blood pressure increase is also because that high blood pressure is going to perfuse the baby. So the mother is increasing the blood pressure ultimately to perfuse the baby. So there is also one important part to understand this pathology. Yes, there is vasospasm. Yes, the mother increases the blood pressure, but the mother is increasing the blood pressure to ultimately to serve the baby, to give good blood supply to the baby. That's why the baby will get some nourishment at the cost of mother having a high blood pressure. That high blood pressure, although will serve the baby well, but will also cause problems in the mother. We'll see about that. Now, continuing our discussion on the E2 pathogenesis and the maternal syndrome part, there are two new factors which are now implicated in the E2 pathogenesis. And these are the soluble endoglin and the soluble FMS-like tyrosine kinase 1. Now, what happens about these factors? So, when we saw about the importance of angiogenesis and the good blood flow in the placental vessels, we have to understand that angiogenesis is brought about by some growth factors, and those growth factors like vascular endothelial growth factor and the transforming growth factor will help growth of these blood vessels through all these factors on the blood vessels. Now, this is what is normal, and blood vessels grows properly, and there is endothelial relaxation, which gives good blood pressure in the good blood flow, which gives good blood flow in the placental vasculature. What happens when soluble endoglin binds to the transforming growth factor? It inhibits transforming growth factors binding to these blood vessel factors. And when soluble FMS-like tyrosine kinase binds to the vascular endothelial growth factor, VEGF is inhibited to bind to these factors on the blood vessels. So when transforming growth factor and the vascular endothelial growth factor are not allowed to work on the growth of the blood vessels, these blood vessels don't form properly, and there is endothelial dysfunction and impaired relaxation, which ultimately again means that there is vasospasm and poor flow in the placenta, in effect, poor placentation. Now, such is the importance of these factors that these are already commercially available tests in the laboratories, and these are generally used for investigations of women whom we are suspect to have gestational hypertension. Now, when this blood pressure increases, this blood pressure is not high only in the placental vasculature. Mothers increase the blood pressure to give nourishment to the fetus. We know that. But this blood pressure is high all over the body. So when this high blood pressure goes to the kidney, there's a damage. High blood pressure, the flow to the liver, there's a damage. Similarly to the eyes and to the brain. So what all can happen? Because of this high blood pressure and the injury to the organs, there can be hemolysis. How do we know hemolysis? Increase in the LDH, reduce in haptoglobin, and schistocytosis. Okay, seeing these blood cells in the broken blood cells in the peripheral smear. Now, they can be elevated liver enzymes, they can be periportal hemorrhage, and this periportal hemorrhage, when it gets collected, can present as a subcapsular hematoma, and the patient has epigastric pain because of this subcapsular hematoma and the stretching of the liver capsule. Then they can be a very important function to understand that. Now, remember, in spite of all this liver damage and the increase in the enzymes, please understand the liver function is essentially normal. This is in contrast to what happens in patients with acute fatty liver or pregnancy, where the liver function is deranged. Here, the enzymes are high, but the liver function is essentially normal when a patient has liver injury in hypertensive disorders of pregnancy. Now, because of this high blood pressure in the CNS, there could be cortical and subcortical petechiae, intracerebral hemorrhages, and they can be headaches, cotomas, and blindness. Now, that is, blindness is because of the cortical blindness, because of the occipital lobe having some hemorrhages. So that is the reason why there could be blindness in this patient. They can also be papilledema because of the high blood pressure, which can also cause the blurring of vision. Now, what happens to the kidney? Kidney will have reduced glomerular filtration rate. There'll be reduced blood flow, and that is due to the afferents. The afferents to this glomeruli, these arteriolar afferents are having a narrow diameter, and because of that, there'll be reduced blood flow. And there is something which is very important, very peculiar to the hypertensive disorders in pregnancy, and that is glomerular endotheliosis. Very peculiar pathology which has come as your exam MCQ, that what is glomerular endotheliosis? Because of this, there is derangement of the kidney function. So let me explain this with a diagram to you. If you see the endothelium of the kidney, that where you see fenestrations in the blood vessels of the kidney, these kidneys will have endothelial swelling because of the hypertension. And that endothelial swelling, if you imagine my palm, I'm trying to show you the endothelium here. So this endothelium has fenestrations. Can you see? This fenestration help in the filtration. Now, because of the edema, because of the swollen endothelium, these edematous endothelial vessels, they will cause closure of this fenestra. Normally it is open like this, and when there is swelling of the endothelium, these fenestra will close. So because of the swelling, can you see these fenestrations which are required for the perfusion? These fenestrations start to become narrower in diameter because of the endothelial swelling. So this is what happens in preeclampsia, glomerular endotheliosis, which promotes to the reduced capillary filtration. All right. So that part of the pathology you must remember. Because of this glomerular endotheliosis, patient has reduced renal filtration, increase in creatinine, increase in uric acid, reduced serum calcium, proteinuria, which is very significant when it is more than 300 milligrams in 24 hours, and urine protein creatinine ratio, which increases more than 0.3. Now, urine protein and creatinine ratio, if it is 0.2 and lesser, it is normal. If it is increasing more than 0.3, we know that there is renal damage. So rather than doing a 24-hour urine protein, it's very cumbersome to collect urine for 24 hours. If you know this, then you know that the patient is having significant renal injury. So most people nowadays do the urine protein creatinine ratio rather than doing the 24-hour urine protein values. Now, what else can happen in a patient? That patient has hypertension in pregnancy. In addition to the poor placentation and the maternal syndrome, what else can be the reason of patient having PIH? There could be more PIH in patients who are primigravida, first time exposure to trophoblast, or patients who are pregnant for the 5th time and beyond, grand multigravidas, more exposure to the trophoblast. Then twins and molar pregnancies, again more exposure to the trophoblast. Anemia, malnutrition will predispose to hypertension in pregnancy. Genetic disorders, thrombophilias are known to cause patients to have microthrombi in blood vessels, and these blood vessels, when they start getting narrow because of these thrombus, the mother has to increase the blood pressure. So that's why thrombophilias and antiphospholipid antibody syndromes, these will make the blood vessels narrower and especially when the blood pressure increases around 24, 25 weeks, 28 weeks, that is many times attributed to the thrombophilias and the antiphospholipid antibody syndrome, especially the dysfunction of the methyl tetrahydrofluoride reductase and the factor V Leadin genes. So this will promote to the endothelial dysfunction because of the microthrombi causing blocks in these blood vessels. All right. Now, there could be also pre-existing endothelial damage, like in conditions of pre-existing renal diseases, patient having long-standing diabetes mellitus, and systemic lupus erythematosus. Right. Then, patients with gestational hypertension, what treatment we can give? All of you know the drug of choice is alpha and beta blocker, which is labetalol. We give in a dose of 100 to 200 milligrams 3 times a day, up to total dose of 2,400 milligrams in 24 hours. We have given even up to 3,600 milligrams, but what is recommended is up to 2,400. Then methyl-dopa, previous drug of choice. It's a pro-drug, and all of you know the pharmacology here. You must read about that individually. That methyl-dopa is a pro-drug. It goes and makes alpha-methyl norepinephrine, which cause the action. But methyl-dopa, remember, is given in a dose of 250 to 500 milligrams QID, and it takes around 48 hours to give the best results. Methyl-dopa is known to cause some amount of drowsiness and depression, and also indirect Coombs test positive. So you may falsely assume that the patient is having a hemolytic anemia. So those are the problems with methyl-dopa. Nifedipine also used to be a very regular drug, but not in much favor now. 5 to 10 milligrams. It's a calcium channel blocker. 5 to 10 milligrams 3 times a day. Up to 80 milligrams per day we can give in 24 hours. Now, prazosin is alpha blocker, and prazosin is given in a dose of 2.5 milligrams once or twice a day. Hydralazine is an arteriolar dilator. Used to be, my post-graduation days around 96 to 99. We used to give a lot of hydralazine because giving just 25 milligrams once or twice a day used to give a very good arteriolar vasodilation action, and that used to give a good blood pressure control when we used to combine drugs when blood pressure used to increase. And drugs which are contraindicated, all of us know ACE inhibitors, they will cause hypocalvaria. The calvarium is small, and they will cause renal agenesis in the fetus, and it can cause oligoamnios because of the renal problems. So that's why we say that ACE inhibitors are contraindicated. This is a very regular question. We all know this right from our MBBS days in pharmacology, that ACE inhibitors are contraindicated in pregnancy, but this still comes as an MCQ in your exams. Beta blockers and furosemide are also contraindicated. All of these three, individually, all of these three are known to cause intrauterine growth restriction. All right. Then the other part of the management is the treatment of the eclampsia itself. Now, eclampsia, like I told you in the beginning of the chapter, the drug of choice for eclampsia is magnesium sulfate, given by the Pritchard regime. The Pritchard regime is that we load the patient with 14 grams of glucose. See, I've highlighted this, that the dose is in grams. We give magnesium sulfate in a loading dose of 14 grams, in which 4 grams is given IV and 10 grams is given intramuscular. Those interns who are here watching this, you'll relate that you've been giving this also split 5 grams in one buttock and the 5 grams in the other buttock, because 5 grams comes in 10 ml of solution. So we will split into the 2 buttocks. Now the levels which are therapeutic for the magnesium sulfate are 4 to 7 milliequivalents per liter, the therapeutic level. And next thing which is important in the management of eclampsia is that you reduce the convulsion, but you must manage the patient's obstetrics, and that is to conduct the delivery. Either you do a cesarean or normal delivery, whichever is earlier and easier in that moment. The decision is left to the obstetrician depending on the condition of the patient. Now, this delivery is the most definitive management of eclampsia. Please remember, this came as an MCQ. What is the most definitive management of eclampsia? The delivery of the patient. Yes, control the convulsion, control the blood pressure, but start doing the delivery. Now, Remember, after the delivery, the blood pressure comes back to normal within 1 week in 90% of patients. Now, after the delivery of the baby, continue Maxel for 24 hours. The dose for continuation of Maxel is 5 grams 4-hourly for these 24 hours. So after delivery, 24 hours, or if she convulses again, then 24 hours after the convulsion. So when you give this 5 grams 4-hourly, we must monitor the respiratory rate, and it should be more than 14 per minute, the respiratory rate, and the knee jerk should be present. Why? Respiratory knee jerks are monitored because they are knee jerks are upper motor neuron reflexes, and the respiratory drive is also managed by the brain. So if you give so much of Maxel which is beyond the required dose, then that causes cerebral suppression, and loss of knee jerks and reduction of the respiratory rate is indication that there is Maxel toxicity. So if these are not correct, then we withhold the next dose. Also, urinary output should be more than 100 ml in these last 4 hours. Why it should be more than 100 ml? Because Maxel has a renal excretion. So the kidneys are throwing out enough urine, that means Maxel is getting cleared from the body. If the urinary output is lesser than 100, then again withhold the next dose. Now, magnesium sulfate toxicity. The first sign of magnesium sulfate toxicity is there is loss of knee jerks. Now, loss of knee jerks happens when the level is 8 to 10. So 8 to 10, there is loss of knee jerks, which is the first sign. And around 15, there is loss of the respiration. There can be respiratory arrest after 15 milliequivalents, and after 25 milliequivalents, there can be cardiac arrest. So that is magnesium sulfate toxicity, and all of us should know that the treatment of magnesium sulfate toxicity is to give calcium gluconate. Now, calcium gluconate also is in grams, 1 gram. Remember, magnesium sulfate is in grams. The treatment of that calcium gluconate is also in grams. 1 gram, which is there in 10 ml of solution, is given over 10 minutes. That is slow IV. All right. So 1 gram, which is in 10 ml, given over 10 minutes, slow IV. That is what is the treatment of magnesium sulfate toxicity. Now, when we are giving management of the eclampsia by magnesium sulfate, remember, to reduce the blood pressure, a patient who is convulsing, we cannot give oral drugs. So drug of choice here, like I reminded you in the beginning of the class, the drug of choice for the hypertensive emergency in pregnancy is labetalol, and this is that hypertensive emergency. So IV labetalol is given as 20 mg stat. If that doesn't work, then after 10 to 20 minutes, we see the blood pressure. If the blood pressure is still high, then we give 20 milligrams. We can repeat to 40 milligrams also, and we can go up to 80 milligrams IV dose to reduce the blood pressure. So how much can you give IV labetalol? So that can be given up to 220 milligrams to control the blood pressure. IV labetalol up to 220 milligrams is given. All right. Now, please remember, the maximum dose of tablet labetalol is 2,400 milligrams in 24 hours, and the IV labetalol is 220 milligrams in 24 hours. Then, how can you prevent hypertension in pregnancy? Nothing is beyond reasonable doubt, but these are time-tested techniques, and there are some reports which say that there might be some benefit if you give low-dose aspirin around 75 milligrams. Some books say 150 milligrams per day, calcium supplementation, and omega-3 fatty acids, which is seen in fish oils. So all of these are known to give some prevention of gestational hypertension. All right. Now, let us talk about diabetes in pregnancy. We've discussed that there could be gestation diabetes, which is sugars high after 24 weeks, and sugars which are high even before when the lady was pregnant, and now she's come to us with high sugars in early pregnancy, which is overt diabetes mellitus. So this classification of diabetes in pregnancy is the White's classification given by Dr. Priscilla White, a gastroenterologist. And when we talk about diabetes in pregnancy, the gestation diabetes is divided as A1 and A2. The diabetes which is controlled on diet is A1, not controlled on diet but on insulin is A2. Now, diabetes which is present before the lady got pregnant, that is overt diabetes mellitus when it presents in pregnancy. That could be type B, that is she's having sugars high for less than 10 years before she got pregnant. 10 to 19 years, it is type C. More than 20 years of diabetes before she got pregnant, which could be seriously associated with complications, is type C. And F is associated with nephropathy, R associated with retinopathy, and H associated with heart disease. Not many people are using this classification of diabetes in pregnancy, but at least we should know the difference between gestation diabetes and overt diabetes in pregnancy. That much classification we should understand. Now, when we talk about gestation diabetes mellitus etiology, remember, after 24 weeks, the sugars is high. Now, why does it increase after 24 weeks? After 24 weeks, there is increase in the insulin resistance in pregnancy, and there is insulin destruction, majorly due to the production of human placental lactogen. Human placental lactogen increases production from the placenta after 20 weeks, and that when it starts destroying insulin, sugars start increasing around 24 weeks and beyond. So when sugars are high after 24 weeks, all of us know that is what is GDM, after 24 weeks. Now, this insulin is also destroyed by the increasing growth hormone and increasing cortisol. So increase in human placental lactogen is the main insulin destroying agent, but also the growth hormone and cortisol. Now, when sugars are high after 24 weeks, we call it gestation diabetes mellitus. So all pregnant women who are coming to us in the antenatal OPD after 24 weeks, they undergo a screening test, and that is now the one-step test. That is, the same test is for screening, and if the values are high, then that test will give us diagnosis also. So we call it the one-step test, and that is the glucose tolerance test with 75 grams of glucose. So when the patient comes fasting, the sugar should be less than 92. Then 75 grams of glucose is given. 1 hour value should be less than 180, and 2 hour value should be less than 153. And any one abnormal value is equal to GDM diagnosis. So when we talk about diagnosis and screening, it is done both in one step. That's why it is called the one-step test these days. Now, all those tests like 50 grams of glucose challenge test and then the 100 grams of glucose tolerance test, all those may be done some places, but they are not the ones asked in the exam. This is the American Diabetic Association recommendations, and not all American recommendations are used, but these are the ones which are coming in your exams. For the last 6 years from the AIIMS exam and the NEET exam, these are the values which are coming. So remember the one-step test. Now, there are also these DIPSI guidelines, that is the Diabetes in Pregnancy Study Group of India. Now, they say that patient need not come fasting, and you just give her 75 grams of glucose, and after 2 hours of that 75 grams of glucose, if the values are more than 140, then that is diagnostic of diabetes. So DIPSI guidelines are not the ones which are coming in exams. Mostly we ask you the ADA values, which is a regular feature in the exams. Now, what is the pre-gestation diabetes? Like I told you, she's a diabetic before she got pregnant. Now, is screening required in the first trimester for all pregnant patients for overt diabetes? Will you do screening for all pregnant ladies in the first trimester for pre-existing diabetes? I mean, of course, if the parents are diabetic, if the grandparents are diabetic, if the relatives are diabetic, then you may think of doing a screening. Or if there's a previous abortion, you may think of screening. But will you do screening for absolutely normal girls also, that they are young girls of let's say 24, 25, they've conceived and they've never had diabetes? Will you do screening for pre-existing diabetes in this first trimester of pregnancy? Yes or no? Well, most of you will answer yes, we should do screening for high sugars in the first trimester. But can you tell me why should you do that? Please remember, it's extremely important to screen for diabetes which is overt diabetes in the first trimester of pregnancy, because high sugars in the first trimester, high sugars are directly proportional to the anomalies in the fetus. So yes, all patients who are pregnant, They are screened for pre-existing diabetes in the early pregnancy, and then they are screened for gestation diabetes after 24 weeks. All the pregnant patients. Now, why should we screen for pre-gestation diabetes or over diabetes to all patients? Because first trimester high sugars. Why? Because first trimester is the time when the organogenesis is happening. Till 12 weeks, the organogenesis is happening. And in that organogenesis, if there is high sugars, that causes free radical injury. And the time when the brachial arcs are fusing and the gut is rotating and the diaphragm is forming and the brain is forming, all of that time, if the sugars are high, it can cause anomalies. So please do screening for pre-gestation diabetes in all pregnancies. And glycosylated hemoglobin should be less than 6.5. Serum fructosamine is also one method, and that should be 258 to 288 millimoles. Remember, this can be done even for patients with abnormal hemoglobin types like thalassemia and sickle cell anemia. Otherwise, glycosylated hemoglobin is the standard. We can use fasting glucose also. Any value less than 95 is good, but these are the better tests, and glycosylated hemoglobin is the ideal method for screening for over diabetes in the first trimester. Now I've told you that first trimester high sugars cause anomalies. Please remember, GDM does not cause anomalies. Okay, GDM, no anomalies. So in the beginning of the chapter itself, I'm telling you, please understand the basic difference between these two. Eventually, both these patients have high sugars. The drug of choice is insulin, and the management is to take care of the fetus so that the fetus does not have intrauterine death. That is the outright basis of diabetes. But please remember, GDM does not cause anomalies. Over diabetes causes anomalies in pregnancy. This question has come many times in your exams. Right. Then, what are the problems of diabetes in pregnancy? Common problems. Rest, everything I told you is common. Only that anomalies are not seen in GDM. So what are the problems of diabetes in pregnancy? What are the maternal problems? A large baby is there, then that could cause more cesarean sections, more forceps, and more vacuum deliveries, and more cesarean sections. There could be more postpartum hemorrhage, and there could be more shoulder dystocia. Now, shoulder dystocia, all of you know, is that when the head of the baby has come out, but the anterior shoulder, that when you're trying to take out the shoulder, the anterior shoulder is stuck because the shoulders are very broad in this baby. So when the shoulders are stuck, then that is what is known as shoulder dystocia. Now, what else can happen when a patient has diabetes in pregnancy? There could be associated PIH in 25% of cases, MCQ. There could be polyhydramnios because of diabetes, high sugars in the baby. Baby will cause to have this high sugars will cause the baby to have polyuria, which will cause polyhydramnios, and polyhydramnios can go on to cause premature rupture of membranes. There could be infections because of the rupture of membranes, that is chorioamnionitis. Infections in pregnancy is not called PID, it is called chorioamnionitis. And there could be abortions and puerperal sepsis, but the very important problem in diabetes in pregnancy is sudden intrauterine death of the fetus. Sudden intrauterine death of the fetus at term. This is that one condition which is, the reason why obstetricians are very, very nervous about high sugars in pregnancies in their pregnant patients. Now, neonatal problems which are seen in diabetes, both kind of diabetes again, is that the neonate may have hypoglycemia, hypocalcemia, hypomagnesemia, but increased blood viscosity, polycythemia. There's an erythroid response because of high sugars. The bone marrow has erythroid response because of the high sugars, and that's what causes the baby to have more blood cells and polycythemia and increased blood viscosity, like we say. Polycythemia will also cause more breakdown of the hemoglobin and hyperbilirubinemia, and cataracts can be seen in the newborn. But what are the anomalies? Again, I have written anomalies not in GDM. So what are the most common group of anomalies? Cardiac group is the most common, and in that the most common is transposition of great arteries, then the ventricular septal defects, and the patent ductus arteriosus. There can be structural defects like facial clefts, and they can be problems of the head like anencephaly. They can be abdominal wall defects. Abdominal wall defects can be like gastroschisis and omphalocele, but very peculiar structural defect is the sacral agenesis, or the caudal regression syndrome. Now, when we talk about the anomalies of a newborn because of overt diabetes in pregnancy, we ask you which are the common group of defects, cardiac. Now, what are the specific defects in a newborn because of diabetes in the mother? So yes, ventricular septal defect can be there because of diabetes in the mother, but it can be also because of phenytoin ingestion, can be because of rubella in the mother, it can be because of so many other things. But if a newborn baby has transmission of great arteries, that is specifically because of diabetes in the mother. So what are the specific defects? So specific defects, all right, transmission of great arteries and sacral agenesis. Now, these are the specific two defects in a baby because of diabetes in the mother. But when we talk about specific defects, please remember, transmission of great arteries and sacral agenesis are specific. Which one of these two is more common? That exam question also came once. That out of the specific defects, like transmission of great arteries and sacral agenesis, which is more common in the baby of a diabetic mother? So, transmission of great arteries is more common than the sacral agenesis as the specific defect. All right. Now, what is the management of diabetes in pregnancy? Management of diabetes, both the type is the same. So, first is the medical nutrition therapy. Please remember, we'll give a diet to the patient to control the high sugars by diet. Most of the times, GDM does respond. But yes, patients who got over diabetes may not respond to diet too well. They may have to get into insulin a little earlier. So, medical nutrition therapy, normal women, if you remember, normal women, we give something like 35 to 40 kilocalories per kg per day. In a patient who's got diabetes, we will give around 24 kilocalories per kg per day if it is controlled sugars, and we can reduce it to 20 kilocalories per kg per day if it is uncontrolled sugars. So this is the diet, and of course always the diet is split into carbohydrates 50%, proteins 30%, and fat 20%. And we also give a lot of roughage in patients who got diabetes. So monitor the sugars. We'll monitor the sugars fasting 4 times, that is fasting, then 2 hours post breakfast, 2 hours post lunch, and 2 hours post dinner. And we'll continue doing this till the sugars are controlled. Once the sugars are controlled, the patient can be sent home. And then we do it once in a week. So this profile of sugars is done in the hospital, as we keep doing it till the patient is controlled either with the diet or with the drugs. So monitor the sugars. The fasting sugars should always be less than 95, and the postprandial, whether it is post lunch or post dinner or post breakfast, should be always less than 120. More than 120, we start thinking in terms of treatment. Okay. Now monitor the fetus. Surveillance of the fetus, very important. I've been telling you repeatedly, antepartum surveillance, that is the most important chapter in obstetrics, and then intrapartum surveillance. Please read about that. So diabetes, hypertension, and fevers in pregnancy, heart disease in pregnancy, always think of the fetus. So monitor the fetus surveillance. That of course includes the non-stress test and the biophysical profile and the Doppler, etc., etc. That is surveillance. And give steroids for the lung maturity. A lot of books says that babies will have a immature lung even if a baby is born at term with diabetes. So whenever you're planning a delivery, even at term, give steroids to the mother. Of course, when you're giving steroids to the mother for the lung maturity of the fetus, the steroids will increase the sugars in the mother. So give the steroids to the mother when the patient is admitted, and we monitor her sugars in the hospital and keep the sugars under control. All right. During the time of giving steroids, the sugars may increase significantly and may require higher doses of the insulin than she's getting regularly. Now that is the monitoring. Along with that, what is the drug of choice? Drugs which we give, drug of choice is insulin for diabetes, both type of diabetes in pregnancy. Approved oral hypoglycemic agents now are drugs like glyburide. Glyburide is also known as glibenclamide, but Americans call it glyburide. and Indians, Britishers, we all call it glibenclamide. Also approved now is metformin as a drug for sugar control in pregnancy. Fundus examination to rule out retinopathy. Remember, most common type is the background. The background retinopathy is there in 80% of the retinopathies. I'm not saying 80% diabetic mothers have retinopathies. I'm saying of the retinopathies, background retinopathy is the more common one, and the proliferative retinopathy is 20%. That is having neovascularization. So if there is proliferative retinopathy, please remember, we don't give normal delivery. No normal labor, because proliferative retinopathy is neovascularization, and during labor the intraocular pressure will increase and may cause some retinal detachment. Now that is classical thinking and classical teaching, but your ophthalmologist teachers may differ from that. But classical teaching is avoid normal delivery when a patient has proliferative retinopathy. All right. So what is the timing of delivery? When we say a patient has gestation diabetes mellitus, which is well controlled on diet, we can go as close as to term as possible. More than 39 weeks, we can go even up to 40 weeks. But when GDM is controlled on drugs, then don't go beyond 39 weeks. 38 to 39 weeks, we must deliver. Now, overt diabetes mellitus, which is controlled on insulin, not beyond 37 weeks much. Moment she completes 37 weeks, in that next 1 week, plan her delivery or a cesarean, whatever is appropriate, because macrosomia is a problem. All of us know that. What is the criteria of macrosomia in India? More than 4 kgs baby is macrosomia. Now, when a patient has overt diabetes mellitus, which is uncontrolled, whatever drugs you're giving and the sugars are not well controlled, then that patient, we will not even wait till 37. Beyond 34 weeks, we'll do the delivery, because 34 weeks, we know the lung is mature. On top of that, we also may chance to give the patient some steroids to accelerate the lung maturity, and then we will do a delivery around 34 weeks and beyond itself. So that's the timing of delivery of patients with diabetes. Please remember, lung maturity in diabetes is classically delayed. Lung maturity in PIH is classically early. IUGR, PIH, twins.
The disorder is almost the same, but there are some differences nevertheless. We know that endometriosis is the endometrium from the uterus finding its way through the tube into the pelvis, first on the ovary, then it may be on the ligaments, and then on the bowel. This is what we've been discussing just now. But yes, adenomyosis is basically this endometrium breaking the endometrial barrier and getting into the muscle here. You will see lakes of myometrium in the uterine muscle. You see these lakes on the ultrasonography. So this adenomyosis is basically called endometriosis interna. So when we say endometriosis, is basically endometrium from the uterus finding its way outside into the pelvis, ovary, pouch of Douglas. But if the endometrium finds its way into the uterine muscle, we call it endometriosis interna, or more appropriately, adenomyosis. This is characterized by hyperplasia of the uterine muscle. This muscle, which is surrounding the cavity, actually starts becoming more and more hypertrophied. So this hypertrophy of the uterus, this is very, very characteristic of the adenomyosis, hypertrophy of the uterine muscle. So basically, when you do an ultrasound and even on a per vaginal examination, you will see a bulky uterus. Classically, you say a bulky uterus. So yes, adenomyosis is classically seen in older women, not the endometriosis age group, the 25 to the 35. But yes, I don't mean older by saying older. I don't mean the women who are beyond 50 or 60. I mean to say older reproductive age women. All these disorders which are associated with endometrium going from the uterus to the pelvis or uterus to the muscle, obviously will stay only as long as the woman is menstruating, isn't it? So yes, the older menstruating woman, okay? So around the 40-45 years, woman presents with adenomyosis, she is having menorrhagia. Menorrhagia is a problem and so is the dysmenorrhea and the dyspareunia. And they can also present with infertility in younger women. Yes, I have seen many women who have adenomyosis and they come with infertility around 30-35 years of age also. But mostly, please don't misunderstand, mostly adenomyosis is a disorder of multiparous women. Multiparous women, and very important to remember that the size of the uterus is never more than 14 centimeters. It is never bigger than 14 centimeters. Now this part comes in many of your exams. This size of the uterus, they will give you, there was this question that a woman has a large mass in the abdomen around 20 centimeters size and she's come with menorrhagia, and what is the most likely diagnosis? So the problem comes in between fibroids and adenomyosis. Adenomyosis is never more than 14 centimeters. It's a bulky uterus but not a huge uterus. Whereas a fibroid uterus can go all over into the abdomen and can be till the umbilicus, can be even above that so many times. So a fibroid can be a huge size. Adenomyosis always less than 14 centimeters. Now what is the management of adenomyosis? Just like endometriosis, we can give progesterones for relief. We can give NSAIDs for the pain relief and tranexamic acid for the bleeding reduction. And we can give GnRH and LOX to reduce the size of this muscle and the stimulus to the endometrial glands which are there in the uterine lining. All of this can be reduced by the GnRH and LOX also. But yes, the most definitive treatment of adenomyosis is the hysterectomy. Alright, so if a woman has too much of pain and too much of discomfort and the bleeding is not responding to the hormonal treatment, we have to think in terms of hysterectomy. That's the most definitive treatment. And one more thing they ask you about adenomyosis is, how do you see this adenomyosis for sure? Ultrasound, especially transvaginal ultrasonography, is excellent. But the best way is to see by the MRI. Yes, by the MRI. So this diagnosis also can be made by the magnetic resonance imaging. What you have to understand that this endometrium, normally this cavity, it's seen something like this. You see a triple layered endometrium when the endometrium is around day 12, 13, 14. But this endometrium, beyond this endometrium, when you come to the myometrium, this muscle layer here, this subendometrial layer, this zone of muscle will be very thick. This junctional zone, yes, this thickening of the junctional zone is the diagnostic criteria on the MRI. And more than 15 millimeters. A junction zone of more than 15 millimeters on the MRI is diagnostic of the adenomyosis. If you really want to know it slightly more refined, sometimes it is not such a uniform kind of adenomyosis. Sometimes it's a localized form. So yes, if I take this out and show you that sometimes it can be a little different. This is the cavity and there is just a focal adenomyosis. What I showed you in the previous diagram was that it was a generalized adenomyosis. But if it is a focal adenomyosis just in one zone, then this of more than 12 millimeters, this thickness of more than 12 millimeters alone is diagnostic of adenomyosis. So in a non-uniform adenomyosis, then 12 millimeters and more is enough. But yes, I think mostly they're going to ask you about junction zone thickness of more than 15 millimeters on MRI is the diagnostic criteria for the adenomyosis. So this is how the adenomyosis looks like. This is a hysterectomy specimen, and this is a uterus which has been split into half. So this is a uterus which has been taken out. We made a cut section of this, and there's the cavity. See, there's the cavity, and we've opened it like that. So when you open this up, when you open the uterus like this cavity is split into two. I'm trying to show you an opened up uterus. The cavity is here and here. Now see, from the cavity till the end, can you see this is the thickness of the uterine muscle? So there is a lot of myohyperplasia in the uterine muscle, and these are those lakes which I was telling you, the adenomyotic lakes. These are those lakes in which the blood has seeped through the cavity. It is seeped through the cavity, and on the ultrasound you see lakes of endometrial blood or adenomyotic lakes. And these deposits in the muscle, when you cut this uterus and see, these deposits are like those red blebs. you make an incision on them in the uterine hysterectomy specimen. When you make an incision on them, you will see some blood spurting out, and that blood will be actually tarry blood, endometrial blood, or menstrual blood kind of thing will come out of these deposits. So it's very interesting when you see this specimen. It is just like we are telling you, myohyperplasia within the muscles having adenomyotic deposits having endometrial blood. All right.
Let's see that fibroids, how do they start? Fibroids are monoclonal tumors. They are monoclonal smooth muscle tumors. One smooth muscle starts behaving in a monoclonal manner and start dividing and making whorls of smooth muscle cells, and it always starts intramural. And these whorls of tissues are mostly surrounded by a pseudo capsule. Now, with the contractions of the uterus, it can be pushed to the surface, and it is called subserous. And if it is pushed inwards with the contraction, it is called submucous fibroids. Now, because of this, there is a good classification given by Figo. It's a new thing, but it is generally asked in exams nowadays. So what is the Figo classifications of fibroids? So these fibroids, they invariably start in the intramural area. So that's why always remember the type 4, it is starting intramural. Now, with the contractions of the uterus, it may move towards the uterine cavity or go away from the cavity. So see, from the 4, if it comes and touches the endometrial cavity, see, it is just touching here, so it becomes a 3. If it is mostly in the muscle, see, it's mostly in the muscle but partly in the cavity, then it becomes a 2. And if it is mostly in the cavity, just touching the muscle, mostly in the cavity, it's a 1. And if it is totally in the cavity and just hanging from the endometrium, it's a 0. So yes, start from the 4 to remember. From the 4, it comes inwards, it becomes 3. 3 is 100% intramural, but it is just touching the cavity, then becomes a 2, bulging into the cavity, and 1, mostly in the cavity, just touching the muscle, and 0 is just totally hanging in the cavity and no endometrial involvement. Now, if it goes the other way around, from the 4, if it goes outwards, it becomes a 5. That is, it is mostly in the muscle, but part of it is in the serosa already. It's a 5. Then it becomes a 6. That is, it is mostly outside. See, the majority of the fibroid is outside, but part of it is still in the muscle. So 6 is mostly subserosal, and 7 is completely subserosal. There's a type 8 also. All of this which I've shown you is written here. There's a type 8, which are the other fibroids which are not shown here, which are either in the cervix or they have detached. Suppose this 7 detaches from here and is found lodged into the omentum or stuck under the diaphragm somewhere. So that is what is called a parasitic fibroid. And there can also be a very important derivation of these fibroids, that one fibroid may have 2 allocations. That is, the example given here is classically the 2-5 fibroid. So what is this 2-5 fibroid? The 2-5 fibroid is that one part of the fibroid is close to the mucosal area and one part of the fibroid is in the serosal area. So based on these, what part is, how much it is in the submucosal area, we see it is just partly coming into the submucosal area. So that is like the type 2, and it is just partly coming to the serosal area. So that is like the 5. So we call it a 2-5 fibroid. It is a type of a hybrid fibroid. And in a hybrid fibroid where there are 2 allocations, we always mention in the nomenclature, we always mention the submucosal part first. So yes, the submucosal part is 2 here and the serosal part is 5 here. So we call it a 2-5 fibroid. So this classification by FIGO, okay, Federation of International Gynecologists and Obstetricians, and this is telling us about the classification of fibroids. And these fibroids are mostly starting because of increased estrogens in the etiology and increased progesterones. Both will contribute. And of course, there are genetic factors, like they could be in 40% of cases, it is because of a 12 to 14 translocation or a deletion of 7 or a trisomy of 12. It can be because of the increased growth factors like transforming growth factor beta and the vascular endothelial growth factor, basic fibroblast growth factor, etc., etc. Insulin-like growth factor also. So a lot of growth factors also contribute. It is seen more in black women than in the Caucasian women. It is also more associated in red meat eaters, those who are very obese. It is more commonly seen in them. But remember, it is the single most common tumor of the uterus, the most common tumor of the uterus, and it is the most common cause of hysterectomies in the world. It is the most common cause of hysterectomies. Up to 30% to 35% of all women have fibroids, small or large, and it is if you understand that suppose you're doing a hysterectomy not only just for a fibroid, suppose you're doing it for abnormal uterine bleeding, you end up doing a hysterectomy. All the hysterectomy specimens put together, 70% may actually have a fibroid. All right. So that's the incidence of fibroids is fairly common. All right. And these fibroids, what are the symptoms they can cause? The fibroid symptoms classically, I mean, there are many symptoms which are important, but classically, menorrhagia, pain, and infertility. Of course, these are the major symptoms. Of course, the bowel and bladder symptoms are also important, and the symptoms because of compression and compaction. So yes, fibroids can have many symptoms, but the more commonly are my acronym is the PBI, pain, bleeding, infertility. So menorrhagia, all of us know, is because of the increased surface area of the fibroid. Why is there menorrhagia? It's a frequently asked question. That yes, it is because of the endometrium which is growing over the cavity here, but also all over the fibroid surface. So what happens? There is more endometrium and there is poor, because this fibroid coming in the way of the uterus, there is poor contractility of the uterus and increased vasodilator prostaglandins. So this is the cause of the menorrhagia, frequently asked question. And of course, what is the cause of the pain? It is basically because of the uterus contracting over the fibroid to push it outwards or inwards. And of course, the pressure symptom of a large fibroid sometimes, and infertility because of the tubal occlusion or because the uterus contracting over the fibroid and trying to dislodge the embryo which comes and implants. It can be dislodged or even prevent implantation of an embryo. So yes, fibroids, mostly what we try to do the medical management by reducing the bleeding using the NSAIDs. I've told you the management of bleeding already. So NSAIDs and the tranexamic acid are used, and then the hormonal management which I told you is used. The injections of depomedroxyprogesterone acetate, the combined oral contraceptive pills, all can be used for the management of bleeding. We can reduce the bleeding plus the size of the fibroid. If you use the GnRH analogues and the GnRH antagonists, this can also, these are used for suppression of the pituitary. GnRH analogues if given in a depot form, and GnRH antagonists directly antagonizing the action of GnRH. So yes, the drugs like cetrorelix and ganirelix, we've discussed in the chapter of pharmacology in obstetrics and gynae, that these drugs will directly inhibit the GnRH and give us quick results. So yes, reduction of bleeding can be done by that, plus reduction of the size can be achieved by these drugs. Of course, in medical management, we also include the levonorgestrel IUCDs, which can be used for reducing the bleeding very, very effectively. Of course, they don't affect the size. And we can also do the uterine artery embolization. Yes, this can all reduce the size and of course the bleeding amount also. So what is the surgical management of a fibroid? The treatment of the fibroid by surgery can be, of course, a myomectomy if it is a young patient who wants to preserve her uterus and the fertility function, or it can be a hysterectomy also if it's an older woman rather, who is beyond 40 and has completed a family and is troubled by the menorrhagia or by the pain. So yes, myomectomy can be done by a laparoscopic method for the uterine fibroids which are on the surface, or they are in the serosa, or they are in the intramural areas. And you can also do a hysteroscopic myomectomy for the submucosal fibroids. And yes, you can do hysterectomy. You can do it a laparoscopic hysterectomy, or you can do by a laparotomy. And please remember, they keep asking you the criteria for laparoscopic myomectomy many times, that trying to do a myomectomy or open technique itself can cause a lot of bleeding and a lot of risk to the woman's life. So yes, an open myomectomy or a laparoscopic myomectomy requires a lot of skill, more skill required with the laparoscopic myomectomy and laparoscopic suturing. So that's why we say for laparoscopic myomectomy, we should try and do it only for the size of fibroid should be 5 centimeter or lesser, and 3 to 4 such fibroids, or one fibroid which is less than equal to 15 centimeters. So 3 to 4 fibroids of 5 centimeter or lesser size, or one fibroid of 15 or lesser centimeter in size. So this is the criteria which is still used for the laparoscopic myomectomy decision making. And remember one thing, that when we are doing myomectomy, we want the blood loss to be reduced. So we always have some plans to make the blood loss reduce. So we can use these drugs pre-operatively to reduce the size and also to reduce the bleeding intraoperative, because these drugs will reduce the vascularity, the same drugs which I told you. And of course, intraoperatively, we can use drugs like vasopressin. That is, this drug comes as a name of pitocin. This can be given intrafibroid. You can give this. It will reduce the vascularity, so that when we do the dissection around this, the blood vessels evolve vasoconstricted, the blood loss is much lesser, and that's why vasopressin is one of the best drugs we use. We can also use a favorite drug called methyl ergometrin. Yes, this will also cause uterine contractions and help. We can try even prostaglandins. Intramyometrial prostaglandins can be used for reduction of the blood loss intraoperatively. Of course, these are the drugs, but we can also use some techniques like uterine artery clamping, and we can also use a tourniquet. We can apply a tourniquet kind of thing over the uterine arteries to reduce the blood supply, and we can try hypotensive anesthesia. I'm sure the anesthetist will explain you excellent techniques to keep the patient at a lower blood pressure, so that whenever we make incisions for the myomectomy, the blood loss is much controlled. But please remember, whenever you're doing myomectomy, keep a few things in your mind, that in the prerequisites, there are many prerequisites. Please keep in your mind that when we're doing a myomectomy, we're mostly trying to save the uterus. And why are we trying to save the uterus? Because the patient wants to maintain her fertility and she probably wants to have children. And also the fibroids may be the cause of the infertility in the first place. So when we're trying to do a myomectomy, open or laparoscopic, the semen analysis should be good. Then only a myomectomy can be fruitful. Of course, the hemoglobin should be more than at least more than equal to at least more than 10 gram%. And yes, we should have the patient minimal incisions. So the technique should be sound, minimal incisions on uterus and minimal or no handling of the fallopian tubes. Of course, you should also be abreast with the knowledge of reducing the intraoperative blood loss, like I told you just before. But yes, most of the times the decision making about doing a myomectomy or trying to preserve the uterus or just conservatively managing is based on the location and the symptoms. So yes, a very rough way of doing this is that if it's a small and an asymptomatic fibroid of less than equal to 5 centimeter, there is no treatment required. And if it is a small but symptomatic, like pain, bleeding, infertility, if one of these or all of these are present, small around 5 centimeters with symptoms, you must treat it medical or surgical management. Large, you must with symptoms, pain, bleeding, infertility, you must treat this patient. But even if it is large and asymptomatic, very important to understand, large asymptomatic also should be treated. Why? Because these large can undergo a lot of degenerations. These large can cause compression and compaction, and they can cause bowel and bladder symptoms. So that's why the large should be treated even if they are not presenting with a symptom. Suppose you have a chance finding on an ultrasonography, or you're doing a per abdomen examination of a woman who's probably got some diarrhea, she's come to you in the medicine OPD, you feel a fibroid, ask the gynecologist to do an ultrasound and you see that there's a fibroid. She did not have any symptoms, but you must remove it because eventually they'll have symptoms. So large asymptomatic also you must treat because they can undergo the degeneration also. So degenerations of the fibroid, the most commonly are the hyaline degeneration, and the most common in pregnancy is the red degeneration, is basically because of the infarction, and this red degeneration happens in the second trimester most of the time. And we know that the patient who is pregnant with the fibroid and having some pain or discomfort because of red degeneration, the treatment is conservative with painkillers and rest. We don't have to do a myomectomy in pregnancy. Please don't even dream of it because the bleeding would be torrential. So yes, most common in pregnancy is the red degeneration. Then there can be lipoid degeneration and calcific degeneration, such a fibroid which becomes so calcific that it is called a womb stone. And it can also be because of a degeneration of the sarcomatous type. Now, this is the rarest form of degeneration. Less than 0.5% of cases of fibroids will have the sarcomatous degeneration. All right. So, these are the salient features of fibroids which are generally asked in the exam. Please remember, nulliparity is a factor which will predispose to more fibroid uterus. So, a patient who is pregnant will have lesser fibroid because the uterus has had an action where estrogenic action is less and the progesterone action is more. But yes, there is a lot of saying that the fibroids can also be because of progesterones. But yes, we always say that classically women who have delivered 2 or more children will have much lesser chances of fibroids as compared to women who are nulliparous. So please remember that. And the parting statement I want to give, that in addition to giving the drugs like danazol or GnRH analogs or GnRH antagonists to reduce the size of the fibroids, we can also give drugs like mifepristone. It's a progesterone antagonist, and mifepristone is classically known to reduce the progesterone action. It's a progesterone antagonist, and this will help the patient have much lesser progesterone stimulation, and the rate of growth of fibroid is reduced. So in addition to all those drugs, I wanted to give you a parting statement that mifepristone also can be used because both estrogen and progesterone are known to contribute to the size of the fibroid, and also that the fibroids are more classically associated with nulliparous women as compared to multiparous women. The classical teaching used to be that when women do not have pregnancy, the uterus consoles itself by making a fibroid. Of course, that's just a saying. It's also a very important finding that nulliparous women have more fibroids as compared to multiparous women. All right. So let us see what are the causes of the abnormal uterine bleeding. Any bleeding which is away from the normal. We know the normal periods are lasting for around 2 to 7 days, and they're coming once in around 21 to 35 days of time, and the bleeding should not be more than around 30 to 35 ml, and if it is more than 80 ml, we know it is menorrhagia. So these are the basic definitions of the abnormal bleeding. We know them well. Anything apart from this is abnormal. Now we know that bleeding more than 80 ml is menorrhagia, but if the bleeding is less than 10 ml, is hypomenorrhea. It is less than 2 days is hypomenorrhea. I mean, if it is too less also, it is abnormal. Please don't think that women will come to you with abnormal bleeding only saying that they have excess bleeding. The bleeding can be very less, and that's abnormal for a woman. Don't, I mean, boys especially in the audience, wherever you guys are, you tend to think that if the bleeding is less, then why is the woman complaining? It's not like that. Bleeding is a very, very important physiological completion of a woman's life, and if she's having normal bleeding and appropriate bleeding which she's always getting and the right number of days, then she's happy. If it is too much, she'll come to you. If it is too less, she'll come to you. Like in tuberculosis and in PCOS, periods come delayed. They come very less. Patients are always with us, and sometimes the parents of these PCOS women they are so disturbed with their girls having abnormal cycles and having less bleeding. So those are things which will bring these patients to you. All right. So let's see what is the management of abnormal uterine bleeding. So yes, the first line management of excessive bleeding. Suppose a woman has menorrhagia, then the first line management are the NSAIDs. Yes, NSAIDs, we know that in a woman bleeding too much, there are a lot of vasodilator prostaglandins, and that's why the NSAIDs will inhibit them. When they inhibit this, it causes vasoconstrictions, so bleeding reduces. And of course, the tranexamic acid. Tranexamic acid, you know, will reduce the fibrinolysis. Fibrin products can undergo fibrinolysis and cause bleeding again from the sites where the fibrin plugs have been formed, and that will prevent the bleeding from happening. So this fibrin can undergo fibrinolysis and cause rebleeding. So this fibrinolysis, this fibrin degradation, it is inhibited by the tranexamic acid. So tranexamic acid inhibits the fibrin degradation and the rebleeding does not happen. So yes, the two very, very important first line drugs for abnormal bleeding are the NSAIDs, this is first line, and tranexamic acid, this is again first line. Okay, these are the first two drugs which I will give if a woman is having any bleeding. And yes, most of the times, you know, this is enough for the abnormal bleeding. You would also know by, you know, if you're most of your interns, that if a young girl, suppose a class 11 girl came to you with dysmenorrhea and you gave her a tablet of ibuprofen for the pain, she'll come and tell you after 3-4 days that the pain was reduced, but the bleeding also reduced drastically. That's the advantage of giving NSAIDs as the first line of drug in abnormal bleeding. I'm talking abnormal bleeding from the uterus, all right? Please don't try it for any bleeding in the body. Don't say that NSAIDs are given for abnormal bleeding anywhere in the body. Please, it's only for the uterine bleeding that we are discussing here today. So what are the hormones which can be used for the management of abnormal bleeding? So hormones, we all know the first drug we can try are the progesterone tablets. And the progesterones can be given like the medroxyprogesterone acetate. You can give it around 5 milligrams to 10 milligram tablets, and twice to thrice in a day for 10-15 days till the we can wait for the bleeding to stop. Let's say most of the times when you're giving these drugs, the bleeding will stop in 2 to 3 days, but then we give the support to the endometrium for around 15 days. Sometimes we give for 21 days, so that once after 21 days you stop the tablet, she gets a period just like she gets in a normal cycle. 21 days you give the progesterone, you stop, she gets period around the 27-28 day. It'll at least give her the break of 1 month between period, which she's used to normally. So we can give progesterones, and if this does not work, we can give estrogen tablets, or injectable estrogens, and we can give the conjugated equine estrogens or the estradiol tablets we can give, and these are given if the progesterones don't work. Remember, we've always discussed that the first line drugs to be given are generally the progesterones because they stabilize the existing endometrium, but estrogens will make new glands. It will replace the degenerating glands which are bleeding and build up a new endometrium. That new endometrium will eventually shed and bleed more than normal. So that's why we say preferable to use progesterones, otherwise use estrogens if the emergency is there. So yes, this question has come many times that yes, we can give tablets of estrogen for the control. We can give also IV estrogens like 25 to 40 milligrams of intravenous estrogen productions are there. So those 25 to 40 milligrams of estrogen when we give IV, it'll stop any bleeding from the uterus. Yes, it is given for menorrhagia emergencies. If there's a young girl who's got too much of bleeding and it's not stopping with anything, then we will give IV estrogens. But remember, the estrogen withdrawal is always heavier than a progesterone withdrawal. That's why we don't preferably give estrogens. It is used mostly for emergency management. So yes, we can give progesterones and estrogen individually, or what we can do, we can give a combined oral contraceptive pill. Now, this is a different mode of action. If you give progesterone alone, it causes stabilization. If you give estrogen alone, it causes proliferation of new glands, and that will replace the old endometrium and stop the bleeding. Combined pill, like we've discussed, it is estrogen and progesterone. So let's go back to the basics that I have discussed with you, that the FSH is given. FSH comes from the brain to make the estrogens, and the LH comes from the brain to make the progesterones. So in combined oral contraceptive pills, there is estrogen and there is progesterone, isn't it? So this estrogen progesterone, which given in the form of OCP, will give a feedback. You know, the estrogen component will give feedback to the FSH and the progesterone component will give feedback to the LH. So LH and FSH from the pituitary will stop. That means there is no LH-FSH stimulating the ovary. That means there is no follicle growing in the ovary. That means the woman becomes anovulatory. And that cycle is not happening from the body anymore. The pituitary is sleeping, the ovary is sleeping. And what makes the endometrium grow and have menstruation now? This tablet which you're giving, isn't it? So yes, this is all of this LH, FSH business and making estrogen progesterone with the OCP. It is stopped. So FSH and LH is not coming from the pituitary, and estrogen progesterone production is not happening from the ovary. The estrogen progesterone in the woman is coming from the pill which I'm giving. Okay, this is discussed well in the video lecture of the OCP pills. Please go back and revise. But please remember, OCPs, the estrogen progesterone we're giving, are the low dose estrogens. You know how much of estrogen we give? Yes, 0.03 milligrams only, or 30 micrograms only. So yes, the amount of estrogen in the body is actually less. So how do we use it for menorrhagia management? What we do, we give, if a woman is bleeding too much, we give 2 tablets in the morning, we give 2 tablets in the evening. Suppose the bleeding is not getting a response from the progesterones, I give the combined pill, 2 in the morning, 2 in the evening. I give it till the bleeding stops, let's say for 3 days. And then after that, I make it 1 tablet in the morning and 1 tablet in the evening for another 5 days. And then I can make it just 1 tablet in a day for rest around, let's say this is 8 days, then I can give for around 13 days. So this is just a random protocol I made just in front of you. This is not that in the textbook you'll see such protocols. It is just that a woman is coming and bleeding too much, and I tried my progesterones, it's not working. So what do? Okay, I resuscitate her, give her IV fluids. I give her blood if she's having anemia now, and I start the iron tablets also. All of this is done. But what do you do for the bleeding? It's a young girl of 25 years. What do? You give her combined pill. So for stopping the bleeding, you see the bleeding is too much and you don't want to give estrogens because estrogen alone will make a lot of very tall endometrium. So you give the low dose OC pills. It will prevent the bleeding by doing what? It will stop the pituitary from working, it will stop the ovary from working, and it will give minimal stimulation to the uterus to grow. So what happens? 2 in the morning, 2 in the evening for 3 days will stop the bleeding. Then you can maintain it by giving once in the morning, once in the evening for 5 days, and then you can make it for 13 days. So what happens? 8 plus 13, 21 days. You give her artificial stimulation for 21 days, you stop, she gets a period. So that's how you stop the bleeding and then make her bleed eventually only after 1 month of stopping the bleeding. So she feels she's got a normal period. Okay, so yes, we can give the combined pills and that will stop the bleeding. But in hormones, we can also go and cause atrophy of the endometrium by giving danazol. We know that's a very giving danazol or testosterone tablets, mostly injections we use, danazol or testosterone. All of these drugs, what do? They will atrophy the endometrium. So if sometimes the bleeding does not stop by working on the hormones which cause suppression of the endometrium or limiting of the endometrium, if those don't work, then we make the endometrium totally atrophic. Remember, danazol is given for causing atrophy of the endometriosis. We discussed in chapter of endometriosis, isn't it? So yes, we can give these drugs to stop the endometrium from proliferating at all and causing an atrophy. That stops the bleeding. Or you can then give the depomedroxyprogesterone acetate 150 milligrams once in 3 months. This can also cause stabilization of the endometrium. Too much of progesterone it is, isn't it? It's a high dose of progesterones. So there is too much of progesterone and the endometrium totally gets stabilized, and in another 1 month or 2 months of use, the endometrium gets so stabilized it doesn't grow at all because of the high progesterone. The estrogens cannot act at all. So yes, the endometrium gets atrophy again. So that stops bleeding. Or you can give GnRH analogs. This will also cause the suppression of the pituitary. We remember that it causes down regulation of the pituitary, and the bleeding stops because the ovary does not make any follicles, does not make any estrogen progesterones, so the endometrium does not get any hormonal stimulation to cause any growth of the glands. So yes, these are the next step of management in hormones. Basically, we manage by progesterones and estrogens. Doesn't work, we give ocipils. Otherwise, we can use these drugs also. Yes, similarly, there's an exciting new method which is regularly asked of you people in the exams, the levonorgestrel IUCD, the Mirena, isn't it? We give high dose of progesterones in the uterus by this device. So this is impregnated with the progesterones, and this progesterone will act locally to the endometrium and make the endometrium atrophic eventually. It may take 1 or 2 months to give the best action. So yes, the woman has come with a non-bleeding and she's around 35-40 years and she's saying that every time I get periods, they're heavy. So I control the acute episode with tranexamic acid or NSAIDs, or if I have to use the hormones, I use that. But yes, eventually what do I say? That yes, if you want to take so many tablets every month to stop the bleeding, and the tablets you have to take every month for 3-4 months, it's better what we do. We put a device into your body, and that local progesterones will start acting on the endometrium and cause it to become atrophic. So yes, levonorgestrel IUCD is also excellent method for long-term benefit of bleeding control of a woman who's having menorrhagia. And if nothing works, then we get to the favorite methods of bleeding management of gynecological surgeons, and that surgical method of bleeding control is the dilatation and curettage, which is actually called the therapeutic curettage in better terms. So what do we do in this? The endometrium which is bleeding too much, this endometrium we scrape it off. So if you see the uterus and the glands which are bleeding too much, these glands, so we take a curette inside and we scrape these glands and take them out. So if there are no glands, then obviously there will be no bleeding. So yes, a curettage, a dilatation and curettage is a almost a layman kind of term, but then yes, this is what is going to be asked of you. A woman undergoes DNC and this is the histopathology report. If a woman is having a baby to abort, do a DNC. If a woman is having too much of bleeding, do a DNC. Actually, all of these have different names in gynecological parlance, but then MBBS students writing a PG entrance exam, DNC generally means going inside the uterus and curettage and take it out. So yes, surgical method is a DNC, which basically is also known as a therapeutic curettage. That will stop the bleeding. Or you can do a uterine artery embolization. The blood supply which is coming to the uterus with the uterine artery,
You can embolize it by polyvinyl alcohol particles, PVA particles. If you embolize this here and here and here, yes, you can do a catheterization of the femorals, and when you get inside, you go and embolize these arteries, both the sides, and the bleeding stops. In acute emergencies, you must do that, uterine artery embolization. Or you can do a tamponade of the uterine cavity. Yes, you can do it for PPH. Remember, in PPH, we say that we put a big balloon in menorrhagia of a normal size uterus. Also, we can put in a tamponade. You know, it's a conical uterine body shaped kind of a device, and it is attached to a small catheter like this. Then you fill it up with fluid. Mostly we use saline, and this, if it is filled up and it gets distended like this will be full of saline, and this will give compression to the endometrium which is bleeding. So that compression will stop the bleeding. So you can give a tamponade, or uterine compression by a tamponade, and if nothing works, then you can do endometrial ablation. The endometrial cavity you can burn. You can burn the endometrial cavity like this with the microwave, you know, just like the microwave, cooks the food in your house. It will cook up the endometrium from inside, you know. It's a controlled energy, obviously, you know, you're not giving stray microwave like that. You know, you're just putting a probe which has got the microwave head, and then you roll it into the uterine cavity for around 8 to 10 minutes, and that will burn the endometrium from inside. And burning the endometrium will eventually lead on to scarring of the uterine lining. So yes, this causes scarring. Obviously, if you scar the uterine lining, she'll never bleed again. So yes, you will cause a permanent amenorrhea. So that's why this is not done for young girls. It is done for people who are around 35 and more years in age. They have completed their families, they don't want children anymore, and they don't mind not having periods, you know. A lot of people are a little upset that the periods have stopped, although they are young and they are around 35-40 years of age, but you burn the endometrium from inside. So this uterine lining is not going to grow glands anymore, and she's not going to bleed for the rest of her life. So she'll actually feel that she's gone into menopause. No, it's not a menopause. Menopause means the ovaries are not working. But what you've done, you've surgically caused the uterine lining to get fibrosed, and that scarring of the glands will prevent any more new glands to form. That's why the woman doesn't bleed. So it's a good thing to prevent bleeding without doing a hysterectomy, isn't it? Because if this doesn't work, and if none of the methods which I told you work, then what are you going to do next? You're going to do the last option. The last option is always the hysterectomy. So if you're going to do a hysterectomy, that is going to stop the abnormal bleeding for a lot of patients. The final answer to a lot of these gynecological problems is to do a hysterectomy, isn't it? But if you're doing a hysterectomy, it's a major surgery. It requires admission, and it requires blood transfusion so many times, and the complications can be a wound dehiscence to infection to deep venous thrombosis, and also to death of the patient. That the worst case scenario is even that. But endometrial ablation is a very safe procedure, and most of the time you can do it in the OPD setting, and then it gives you very good results. Of course, when you burn the endometrium, it doesn't stop bleeding overnight, you know. The endometrium is burned, and the scarring will take almost around 20-25 days to show effects. But yes, with this endometrial ablation, you're preventing the last option, which was hysterectomy. So yes, you can avoid a hysterectomy by ablation, but yes, if nothing works, a hysterectomy is the option which you have to follow. So yes, what are the causes of abnormal bleeding? Now that becomes not a question sometimes, but it is something of general knowledge which you should know, that why women bleed abnormally. If a woman bleeds abnormally, I've told you all the lines of defense. You can start the tranexamic acid or the NSAIDs, or you can give the hormones. If that doesn't work, you go for surgeries. So I've given you all the methods of stopping the bleeding, but why would women bleed abnormally? Why do they have more bleeding or less bleeding sometimes? So yes, I would always give you my acronym here, that is tumors, infection, pregnancy, systemic disorders, and coagulation defects, and drugs. So yes, tumors will cause abnormal bleeding, like this CA cervix and this CA endometrium, and CA vagina, and tumors like the fibroid. All of this will cause abnormal bleeding, isn't it? So please remember, abnormal bleeding can be because of tumors of any part of the genital tract. Even sometimes, ovarian tumors like the granulosa cell tumors can cause abnormal bleeding, and of course, CA vulva can cause abnormal bleeding. So yes, the patient says, I've got abnormal bleeding. It's for you to find out with a PV or with an ultrasound that she's got a fibroid which is causing the menorrhagia. So tumors, then infections like PID and vulvovaginitis, and vaginitis with trichomoniasis and with candidiasis. There could be some inflammation, and little bit stretching of the vagina also can cause some spotting and bleeding to happen. Remember, the bleeding doesn't have to be in loads of blood loss. No, it can be some spotting in between cycles. So that is also abnormal bleeding. Okay, don't always think abnormal bleeding means too much of bleeding, like I told you in the beginning of this topic. Okay, so tumors, infections, and pregnancy related causes. Most of the times in your internship, you would have seen that if a woman came with abnormal bleeding and she's in the 12 to the 50 years of age bracket, what do your residents do? They always do the pregnancy test first. Rule out pregnancy related causes. Is it a threatened abortion, incomplete abortion, or a missed abortion, or inevitable abortion, or she's got an ectopic pregnancy? Remember, ectopic pregnancies also can cause vaginal bleeding because of shedding of the desceral cast. The baby is in the tube, but the endometrium was ready for the baby to come. Now the baby becomes too big in the tube, baby dies, and the corpuscle will die because the HCG from the baby is not coming. So the baby dies, HCG stops, corpuscle dies. Corpuscle dies, progesterone reduces. Moment progesterone reduces, endometrium sheds. All right. So any pregnancy, the abortions can be the cause and can be because of secondary PPH, and it can be because of ectopic pregnancies, abnormal bleeding, and there can be systemic disorders like hypothyroidism, or it can be hyperprolactinemia. Abnormal bleeding can happen because of that. Coagulation defects like idiopathic thrombocytopenic purpura and von Willebrand's disease, and drugs like she's on heparin for a deep venous thrombosis prophylaxis, or she's had an artificial valve which is replaced and you're giving her a heparin, and of course irregular OCP intake, and of course an IUCD can also cause abnormal bleeding. It comes under drugs, isn't it? What is the most common side effect of IUCD insertion? Yes, for first 3-4 cycles the periods are heavy. So these are most of the causes. When a woman comes with abnormal bleeding, I want you to run this acronym in your mind. Tumors, infection, pregnancy, systemic disorders, coagulation defects, and drugs, and most of your causes come in this. But of course, the more fancy and the more well-known acronym across the world is the palm coin classification, isn't it? All of you have heard of this, and this is what your teachers have taught you also. The palm coin, actually, the E is extra here. So yes, the tumors, the cause of abnormal bleeding can be the tumors like the polyp, adenomyosis, leiomyoma, malignancy. So that comes in palm, PALM. But actually, if you see my acronym, the tumors alone, T alone was enough for all of this. It's okay. Whichever acronym you use for remembering, it's fine. The palm coin is a more fancy and slightly more accepted across the world. And that is my acronym, the one which I gave you. So polyp, adenomyosis, leiomyoma, malignancy, that's the palm. Then the coin, coagulopathy, ovulatory dysfunction like anovulatory cycles or ovulatory DOB, all of them come in this. Endometrial causes like endometritis, infections, iatrogenic causes, and then the not yet classified causes of abnormal bleeding. Okay. So yes, if you know the causes of abnormal bleeding, whichever acronym you use, it's all right. So if you know these causes, then you can probably treat the patient better. I've already told you the basic management protocol of abnormal bleeding. But then yes, if you know the causes, then it helps you treat the patient better and for longer benefit. All right. So let us see something about the Mullerian defects. We know there are two type of ducts in all the humans, the Mullerian and the Wolffian. The Wolffian duct is for the wolves.
the men, and the Mullerian duct is for the women. Mullerian agenesis happens in women. That's a Mullerian duct for women. Easy to remember. So these Mullerian ducts will fuse and they will make the uterus, and the Wolffian will get obliterated. So how does that go? I'll draw it on the screen. So the two Mullerian would fuse like this, and the Wolffian will start getting obliterated. This will start making a primitive uterus, and then finally the fundus will form, the cervix will start forming, and the vagina will start as outpouchings from the uterus and the cervix. And yes, this is the Wolffian getting obliterated. And finally, this gives us the structure which we know as the uterus. So this will become a uterus with the cervix and the outpouchings from the vagina, the fallopian tubes, and of course, you know that the 4/5 of the vagina is made by the Mullerian duct, but the 1/5 of the vagina is made by the urogenital sinus. So that's the complete formation of the uterus, tube, cervix, and the vagina. But yes, this fusion, just now we discussed that this outpouchings of the vagina, which comes and fuse with the urogenital sinus, this may not fuse properly, and who knows, the fusion does not happen. Sometimes the formation of the cervix, this part of the vagina, and this cervix might not form properly. So what all are the defects of this Mullerian duct? If there is a vertical fusion defect, if there is a vertical fusion defect, then there could be formation of the uterus and the upper vagina, and the urogenital sinus also is formed, but it has not fused. So that's what is the transverse vaginal septum. And if the uterus is formed and the cervix is formed, but the vagina is not formed, so that is vaginal atresia. Only the urogenital sinus making a small part of the vagina is there. This is vaginal atresia, and sometimes the cervix is also not formed, only the uterus is formed. So the cervix is also obliterated, and so is the vagina obliterated, and only the shallow vagina is there. That is cervicovaginal atresia, and the whole uterus might be absent, and the tubes also might be absent. Only the shallow blind vagina is there. So this is the complete Mullerian agenesis. So yes, these are the vertical fusion defects, and then there can be lateral fusion defects. The lateral fusion defects is that these two ducts which they come and fuse, these duct has to come and fuse in the middle like this. If this fusion is not good, so lateral fusion defects can happen. So what are the lateral fusion defects? There could be complete non-fusion of these ducts. That means there are two separate uterus and two separate vaginas, or there could be two separate uterus with a common vagina. So this is didelphys. This is didelphys with a bicollis, two vaginas, or unicollis, one vagina. That is the complete lateral fusion abnormality. Or they could be lateral fusion abnormalities which is showing us fusion but not a proper fusion. That is, they could be two horns of the uterus like this, or they could be a proper fusion of the fundus, but the cavity does not have the resorption of the intrauterine septum. So yes, you may have a bicornuate uterus or a septate uterus. And yes, there could be sometimes the formation of there is a formation of one uterus only from one of the Mullerian ducts, and the other one is a rudimentary horn. So yes, that is what is a unicornuate. Now this could be communicating or communicating
or non-communicating? Unicornate horn. So unicornate uterus with the rudimentary horn could be communicating or could be non-communicating. This is that rudimentary horn. There are many instances where the rudimentary horn, which is not communicating, but somehow, some freak in nature, this rudimentary horn has come with a pregnancy in it. So we think it's an ectopic pregnancy, but it's actually a uterus which is having pregnancy, but that's a small rudimentary horn pregnancy, and that rudimentary horn pregnancy will never go to term. It will actually rupture and come much like an ectopic pregnancy, but it's not actually ectopic. It's the part of the uterus which is rudimentary. So the technicality of it is to call it a rudimentary horn, but it presents much like a ectopic pregnancy which ruptures and comes. So yes, how do we distinguish the bicornate and the septate? This is a very, very common problem which we face in the OPD when we do a hysterosalpingography. This part of the cavity gets radiopaque, and in a septate, this part of the cavity gets opaque in a hysterosalpingography if you're doing in a HSG. But what happens, see, in this example, I've given you nicely spread cavities for biconduit and a nicely seen septum. You know, we have made the septum so prominent that you will not have problems in distinguishing in this example here. But in real life, when you see this X-rays, this X-ray and this X-ray of the hysterosalpingography looks almost the same. So there are many radiological features which are taught to us that yes, the distance between the two horns is more than it is biconduit when there is these two horns are closer in a septate, and the angle made by this two horns at the place where they meet is obtuse in a case of biconduit and acute in a case of a septate. Then there is a the distance of this septum coming below the line drawn connecting these two horns is more in a septate and less in a biconduit. There are many radiological features which are taught to us. So every time I see X-ray showing me a picture with the radiopaque dye in the two horns, and I've always been told it's a biconate uterus. So what I actually see on the X-ray and then what I see on the laparoscopy is totally different, because every time I do a laparoscopy for a biconate, it turns out to be septate. I'm not disregarding the radiologist, because it happens so many times that it has always happened, in fact, because I've been doing septums ever since I was a consultant. That was 2002, and it's 17-18 years of working as a laparoscopic surgeon, and I've done so many septums that I'm not counting them anymore. I stopped counting after 300, but I have yet to do my first biconate unification. Yes, we do see biconate in our practice as obstetricians also, and I know that biconate uterus I see at cesarean sections many times because it causes a lot of malpresentations. Yes, malpresentations, it causes a lot, and it can cause preterm labors, it can cause abortions. So I do see them in my practice, but the number of septums I have seen and number of septums which the whole world has seen, there is no doubt that the septate uterus is the most common Mullerian defect. This is the most common Mullerian defect, and the best way to distinguish between a septum and a biconate uterus, the best way is a laparoscopy and a hysteroscopy in the same setting. So a lap plus hystero in the same setting is the best way to distinguish the two. And they've asked you on imaging. Sometimes the question is on imaging techniques which can best distinguish septate from the biconate, that is MRI. Imaging technique best is the MRI. Overall, the best technique is the laparoscopy, hysteroscopy. The other question which they ask you is, what is the most common indication of unification of the biconate uterus? These two separate fundus and separate cavities, how do you unify them? That is known as metroplasty. Jones metroplasty, Tompkins metroplasty. But how do you do the metroplasty is not the question. The question is, what is the indication of doing a unification? Because biconate does give us a live pregnancy most of the times. Mostly it is problem is that it's a transverse lie or a breach, and by cesarean we can give a live baby. So you don't have to actually do a surgery and cut the uterus and join it for a metroplasty. But then they say, if at all you have to do, when will you do? For recurrent abortions, for habitual abortions, 3 and more abortions if a patient has had, then that's the only indication for unification of a biconate uterus. So yes,
Bicornate uterus, septate uterus distinction I've told you, and I've also told you that this is the most common Mullerian defect, the septate uterus. The other question which comes to you is that what is cryptomenorrhea? Cryptomenorrhea is a condition where the menstruation is happening but you cannot see it happening. That means hidden menstruation. So cryptomenorrhea is seen in what all conditions? Cryptomenorrhea, blood is forming here, it is collecting in the vagina. So blood collecting in the uterus, we know it is hematometra. So hematometra and the blood in the vagina is hematocolpos. So this is hidden menstruation. She is menstruating but it is not coming out because of a transvaginal septum, or in a vaginal atresia, or in a cervicovaginal atresia. So these are the conditions where you see cryptomenorrhea or hidden menstruation. There's another condition where you can see cryptomenorrhea, and that is imperforate hymen. I'm not drawing it here. We've done that properly in the app, but remember, I'm not drawing imperforate hymen here because that's not a Mullerian defect. Mullerian defects are these, and imperforate hymen is a cannulation defect of the hymen. So yes, you can understand that imperforate hymen also, the blood will not come out. It will keep forming but will not come out. So cryptomenorrhea, hidden menstruation, is seen in these conditions, and imperforate hymen, which we have discussed. So these are the vertical fusion defects, and I've told you the lateral fusion defects. So all of these are classified by two systems. One is the American Fertility Society system, and then there is the ESHRE system, the European Society for Human Reproduction and Embryology, ESHRE. So the ESHRE one is the later one, and this is the one which is now used more commonly than the American Fertility Society system. So the ESHRE, the European Society system, is that the Mullerian defects are called as U0, which is the normal uterus. This is the normal uterus they're showing, and class U1. U1 is the T-shaped uterus or the infantile uterus, and the class U2 is the septate uterus, partial septate or a total septate, complete septum. U3 is a bicorporeal uterus, that is the bicornate uterus. Okay, you can see the two horns being much further as compared to these two horns in a septate uterus. So U3 is a bicornate uterus, and a hemiuterus, that is a uterus with a rudimentary horn or without a rudimentary horn, communicating or non-communicating. So the U5 is also the group of anomalies in which you see the complete aplasias when the uterus is totally absent, like in the Mayer-Rokitansky-Kushner-Hauser syndrome. And then the U6 is the category in which you see the even rarer defects, which you cannot put into any of these classifications because you've probably never seen them. They've come for the first time. So those kind of rare defects also come sometimes. We have seen many defects which you cannot put into any of the systems, whether it's the American Fertility System or the European Society. In fact, this ESHRE system, which I'm telling you, this came in 2013, and it was in collaboration with the Konuta group. The Konuta group was the congenital uterine anomaly, congenital uterine anomaly group, which had a conference, and they had done a complete revamp of all the defects, because the American Fertility Society was not talking very properly about the obstructive anomalies in the Mullerian system. So the Konuta group suggested, and the ESHRE is following those Konuta recommendations. So I'll try to tell you a little bit more about this. If you see this one picture about, there is more to this system. If you see this, the ESHRE system, which I just now told you, the U0, U1, 2, 3, 4, 5, 6, and in each of this, there is a coexistence class of these cervical and vaginal anomalies. So this is taking care of the obstructive anomalies which were missed in the American Fertility Society system. That's why the ESHRE system is one which is used. So in this, they have mentioned about the septate cervix, the double normal cervix, unilateral cervical aplasia, and this cervical aplasia, and then again the longitudinal non-obstructive vaginal septum, longitudinal obstructing vaginal septum,
transvaginal septum, and vaginal aplasia. So these defects are also included in the Esches system. That's why this is the better system to classify the Mullerian abnormalities. So after discussing about the Mullerian abnormalities, let's see something about the sexual differentiation. So the sexual differentiation starts at 3 levels. One is the chromosomal level, that is, if the person has 46XX, it's a female, 46XY, then it's a male. What decides? Actually, the Y chromosome. This is the sex determining region Y. The Y chromosome has the sex determining region Y, and this SRY, the sex determining region Y, is also known as the testes determining factor. Testes determining factor. So this Y chromosome decides whether there will be testes or there will not be testes. It's not that if there is Y, there will be testes, and when there is X chromosome, there will be ovary. No, we don't say like that. We say if there is Y, there will be testes, and if there is no Y, there will be ovary. Okay. So this is the chromosomal sexual differentiation. Then there is the gonadal differentiation. If the gonad is the ovary, then it's a female, or it's a testes, then it's a male. And then there is a phenotypic differentiation, and that is if there is a vulva, it's a woman, and if there is a penis, a phallus, then it's a man. So sexual differentiation takes place at 3 levels. Now what is the result of all this on the sexual formation, the sex organ formation of a human? Let's see it here on a clean slide. So we know, let's see in a woman first. In a female, we know that there is formation of a uterus from the Mullerian duct, isn't it? So the Mullerian duct makes a female. We all know that the Wolffian duct makes the male. So Mullerian duct makes the uterus, the cervix, the vagina, and the fallopian tubes, and 4/5 of the vagina. But yes, the lower 1/5 of the vagina is made by the urogenital sinus. So that's the 1/5 of the vagina. But yes, there are ovaries also, and the ovaries have origin from the extraembryonic mesoderm, and that is and from the genital ridge. So contribution from the genital ridge makes the ovary. So this is the formation of a female internal genitalia. Now, what is the formation of a male internal genitalia? The formation of the epididymis, the vas, the seminiferous tubules, the prostatic part of the urethra, that's all from the Wolffian duct. Now, let's see, we are discussing about the formation of the internal genitalia. Now, what is the formation of the external genitalia of a human? Now, external genitalia formation is from the genital tubercle and 2 genital swellings. So, there one genital tubercle and 2 genital swellings, and this is the common external genitalia till 6 weeks of intrauterine life. After 6 weeks of intrauterine life, it starts distinguishing between a male and a female. So, how does that distinction happen? So, yes, if it's a male fetus having testes which are making androgens, then these androgens will fuse the swellings to make a scrotum, increase the length of the tubercle to make a penis, and also cause the descent of the testes into the scrotal sac. So yes, descent of the testes into the scrotal sac, that pull down of the testes is because of the gubernaculum testis, and that is also under the influence of androgens. So yes, androgens make a man. Remember this one line, androgen makes that man. Increase the length of the tubercle, formation of the scrotum by fusion of the swellings, and descent of the testes into the sac because of the androgens acting on the gubernaculum. And the urogenital sinus will fuse into the base of the scrotum. Now, what happens in a female? In a female, there is ovaries, and the ovaries, what do they make to make a female genitalia? Actually, we all think that the ovaries make
estrogens and estrogens make a woman. We are correct. Estrogen make a woman feminine, but the formation of the female sex is not because of the estrogens. Yes, the androgens make a man, but all I want in the intrauterine life that there should be no androgens if there is a formation of a female. We don't want androgens. So absence of androgen makes a female. Okay, after the birth, the femininity of a woman, the way she looks, walks, talks, behaves, we've discussed in the first chapter on the app on the menstrual physiology. All of that is estrogenic. But yes, in the intrauterine life, the absence of androgen makes a female sexual form. Okay, so androgen make a man, absence of androgen makes a woman. So minus androgens, there will be no androgens, so this tubercle will not grow big, it will stay small and make a clitoris. And the androgens fuse the swelling in a male, so these swellings won't be fused because there are no androgens, so there will be separation of these swellings. So those separated swellings will modify to make the labia majora, the labia minoras. Okay, and yes, the urogeneal sinus, which comes and fuse into the base of the scrotum in a man, that urogeneal sinus will come and fuse between the two swellings, the labia majora and minor. Between that, this comes and fuses. So that is what is the formation of the lower 1/5 of the vagina. All right. So androgen make a male, absence of androgen makes a female. And look at this, the labia majora minora and the vaginal opening and the clitoris. So look here, the same thing here I am showing you. See that diagram and see this diagram. The upper vagina here and the lower vagina here. Upper vagina 4/5 by the Mullerian duct and lower 1/5 from the urogeneal sinus. And the same thing I am showing you here like this. The upper vagina you can't see here, but since this is the perineal view, you will see the lower vagina, the opening of the vagina, the vestibule. So that opening of the vagina and the lower 1/5 of the vagina is made by the urogeneal sinus. So androgen make a man, absence of androgen makes a woman. So yes, what is the default human sexuality? The female form is the basic default human sexuality. We are all destined to become females, but yes, some of us got corrupted by the androgens, and the corruption of the androgens in a human form makes a male form. Alright, so basically females and corrupted females by androgens. So those females who are corrupted by androgens in the intrauterine life, they actually make them males. That's my way of remembering things. But yes, if you remember, androgen make a man, absence of androgen makes a woman. So that's the basic of this sexual differentiation. Now let's see what happens if the androgens are not working. Let's say in a case of testicular feminization syndrome, when there is testes which is making androgens, but the androgens are not working. Testicular feminization syndrome, all of you know, is also known as the androgen insensitivity syndrome, also known as the testicular feminization syndrome. So in TFS, there is androgens, but the androgens are not working. That means there is absence of androgens, isn't it? So there is androgens formed in the body, but the androgens are not working. So when there are no androgens, the swellings will be not fusing. These swellings will not fuse, they will stay separate. And you know, separated swellings make the labia majora and minora. So yes, in androgen insensitivity, the labia majora and minora will form, the swellings will be separate, the urogeneal sinus will come and fuse in between and make lower 1/5 of the vagina. And the tubercle which has to increase with androgens, no androgens, so there will be a clitoris. In a boy, if a male has androgen insensitivity syndrome, there will be a formation of vulva and the vagina, and there will be a clitoris also. So a boy is born like a female. That is what is the androgen insensitivity syndrome. Alright. We also know in androgen insensitivity syndrome, all of this excess androgens which is not converted into active form dihydrotestosterone, and that dihydrotestosterone, when it is formed, it is not been utilized by the end organs. When they are not utilized by the end organs, these androgens will be converted in the periphery into estrogens, and that estrogens will also give rise to the glandular development of the breast. So in testicular feminization syndrome, there is a formation of female genitalia and there is breast. So we've had a great discussion about this in the app, but remember, testicular feminization syndrome looks like almost a normal female and with breast also. but it is actually a man. Okay. Now, a woman is a woman because there is absence of androgens in the intrauterine life. But if the intrauterine girl has congenital adrenal hyperplasia, if there is congenital adrenal hyperplasia in a girl, so what is the problem with congenital adrenal hyperplasia? The most common type, we know in the hormone synthesis, I'll just show you. We know that the cholesterol will break down in the adrenal gland to make androgens, and the cholesterol will also break down in the adrenal gland to give us the aldosterone, the corticosterone, and the cortisol. So, the breakdown of the cholesterol in the adrenal gland will give us the androgens and the steroids. But yes, the main important enzyme is the 21 hydroxylase for the formation of the mineralocorticoids and the glucocorticoids. And if this 21 hydroxylase is deficient, then there is no formation of these steroids. The mineralocorticoids and the glucocorticoids are not made, so there is no feedback to the brain of these steroids. So the hypothalamus will stimulate the pituitary, and more ACTH will come out, and more ACTH will stimulate the adrenal glands to recruit more cholesterol and break down more of cholesterol to come and try and make steroids. But since the reaction has stopped here, there will be no formation of steroids. There will be continuous formation of this pathway, the pregnenolone, 17-hydroxyprogesterone, and 2-dehydroepiandrosterone, and the progesterone to 17-hydroxyprogesterone to androstenedione, and making of testosterone. So yes, the androgen production will continuously increase. Yes, so that's why in an intrauterine female, if there is deficiency of 21 hydroxylase, there will be more and more production of androgens. And then there is more and more production of androgens, there will be excess androgens in an intrauterine female, and androgens in a female is not required. You know, androgens make a man, absence of androgens makes a woman. So when there is androgens in a female, as in the case of congenital adrenal hyperplasia, the swellings will fuse and make a scrotum, will increase the tubercle to make a penis, and also there will be hirsutism when this happens in a late onset fashion for this girl. So this is what happens in a case of congenital adrenal hyperplasia. So yes, the basic of the sexual formation is androgen make a man, absent of androgens makes a woman. If the androgens are not working in a man, a female genitalia can form, although the chromosomes will be of a male, and in a female the chromosomes will be of a female. If in a case of congenital adrenal hyperplasia, the androgens will increase, and that will make a male form. Of course, there will be no testes in congenital adrenal hyperplasia, which is looking like a male, but there will be no testes. So that is few of the things which we've seen. Now let's go to the higher level and let's see what happens if the testes is not working properly. So far we discussed if the androgens is not working properly. So let's see if the testes does not form properly, if there is gonadal dysgenesis in a man, the gonad of a man is not working. So there is no formation of an androgen. When there is no formation of an androgen, obviously the genitalia will be of a female form, all right. But we also know that testes makes Mullerian inhibiting factor. Normally it makes that, and that Mullerian inhibiting factor makes sure that none of these derivatives, none of the Mullerian derivatives are made in a man. So yes, this testis is not working, so Mullerian inhibiting factor is not made. So there is no Mullerian inhibition in this man. Instead, there will be Mullerian exhibition in this man. So when the testis is not working in a man, there will be no Mullerian inhibiting factor. There will be formation of a uterus. There will be formation of a uterus, and there will be cervix, and there will be vagina, and the lower 1/5 vagina we know will come from the urogenital sinus. So uterus, cervix, and vagina in a man when there is gonadal dysgenesis. So that gonadal dysgenesis in a man is going to make a female form with complete uterus, tube, cervix, vagina, and the lower 1/5 vagina. That is what is known as the Swyer syndrome. A Swyer syndrome is a 46XY female. So if you understand this basics of the development, we can also understand gonadal dysgenesis, what happens in a man. Let's see if gonadal dysgenesis happens in a woman. Let's see if the ovaries is not working properly. If the ovaries are not working properly, that means there will be ovaries not working properly. That means there will be no estrogen production. Of course, still there is no androgen. So what is the formation of a female? Absence of androgen is the formation of a female. So yes, ovary is not working, there is still no androgen in the body, so the genitalia will be a female form. But if the ovaries are not working, after birth, I have told you repeatedly in the app, the femininity, the way the woman looks, walks, talks, the behavior of a woman, the femininity of a woman is all because of estrogens. So those estrogens will not be there. So this one will be lesser feminine as compared to other. So yes, ovaries are not there. There is no estrogen. So there will be no proper development of the uterus, hypoplastic uterus, and there will be primary amenorrhea. So that's what happens in a gonadal dysgenesis in a female. Hypoplastic uterus, primary amenorrhea. So one of the forms of gonadal dysgenesis in a female is the Turner syndrome. Of course, Turner syndrome, you'll also have to know the genetic makeup. You know, it's a 45XO. So that's what makes the ovaries not work properly. And when the ovaries are not working properly, there will be formation of a female which is lesser feminine. Alright, so hypoplastic uterus, primary amenorrhea is Turner syndrome. Of course, the other part of the syndrome we've discussed, there is short stature, there is a shield chest, and there is low set ears, low set hairline, and coarctation of aorta, lymphedema, cubitus valgus. There's so many things which are seen in the case of Turner syndrome. So yes, in our revision, we have briefly seen what can happen if the sexual differentiation does not happen properly in a male or in a female. But yes, parting statements. Parting statement in this slightly complicated chapter. If the gonad is not working in a man, if a gonad is not working in a man, that means in Swyer syndrome, what is the external sexuality of a person when the gonad is not working in a man? We just discussed it's a Swyer syndrome which has a vagina and outside there is a vulva and inside there is a uterus. So the external genitalia of this person when the gonad is not working is that of a female. Now, when the gonad of a female is not working, the external genitalia is still a female. So remember, very, very important part. When there is gonadal dysgenesis, whether it's happening in a male or happening in a female, in either case, the external sexuality is a female form. Alright, very important. I know you know this statement, but now we know how to derive the statement that the default human sexuality is always the female form. Alright, and in gonadal dysgenesis also, mostly the external sexuality is the female form. Alright, so let's just see what can happen if the genotype is altered. We know that 46 chromosome with XX representation of the sex chromosome is a female, and we know that there is when there are two X chromosome, one makes the bar body. So a woman has a bar body, but what if it is 45XO? If one of the X chromosome is missing, so we always say it takes two X factors, it takes two X chromosome to give proper femininity, but if there is one less, there is lesser femininity. So the girl is short and she has got a shield like chest because on the chest there is no well breast growth. So we say a shield type of a chest, no breast almost, and there's coarctation of aorta, and the other things which I just told you regarding the low set ears, the low set hairlines, and the lymphedema and the hyperplastic uterus. All of that is the Turner syndrome. So yes, this is the Turner syndrome when the chromosomes are altered in a female. Let's see what happens if the chromosomes are altered in a male. So male is 46XY. Suppose he gets 47XXY. Suppose there's an extra X chromosome. So 2 X chromosomes make a woman. 1 less X chromosome makes a lesser feminine female. Now 1 X chromosome is good enough for a man because he has to have a Y chromosome to give the masculinity by making testes. Now there is a Y chromosome, but there are 2 X chromosomes. So this man has got 2 X chromosomes like a woman plus a Y. So there is some femininity in this man. So this person is tall, 1 X chromosome less, short, 1 X chromosome more, tall. No breast, this person has gynecomastia. And of course there is obesity and there is testicular atrophy. So yes, there will be infertility also, and there is mental retardation. I'm writing RT, mental retardation. Remember one thing, Turner syndrome, this is Turner syndrome, has normal intelligence, but this 47XXY is the Klinefelter's. So we saw how the sexual orientation of a human takes place, right from the genetic level to the gonad level and the phenotypic level, and then we've gone and altered at each and every level from the phenotype level to the gonad level and now at the chromosomal level. So if you understand the two outright basics which I told you, that the sexuality, the default human sexuality is a female form, and androgen makes a man, and absence of androgen makes a woman. These two will help you derive a lot of sexual problems of orientation, and the chapter on intersex will make much more sense if you remember these two lines, in addition to remembering the diagram of steroidogenesis. This diagram is already given in your books, but please remember this diagram of adrenal